Good morning and welcome to day 2 of the ABTA's 2020 National Conference. As you heard, it's completely virtual this year. I'm Ralph DeVito, President and CEO of the American Brain Tumor Association. It is great to have you either back after being with us yesterday for a phenomenal day of content. Thanks again to Mark and Jean for putting together, along with our staff, a phenomenal program. And today will be a very strong day, beginning now and ending around 5 p.m. We will continue to share with you content and the latest advances in brain tumor treatment and care and research. We have a wonderful program for you. The ABTA, we understand that building community is one way to help manage the many challenges that we're dealing with. We have COVID-19, the pandemic, and we're here to help. We realize the ability to connect with others may be difficult now. We encourage you to reach out to the ABTA to get connected. We have social support options, such as our Community Connect mentor program, where we would match you with someone who's been through the very same experience that you're going through, either as a brain tumor patient or caregiver. We have online support options. We have about 26,000 people in what we call the connections. So we have many options for you. Just reach out to us by phone, by email, by text. We're here for you. We have a pretty strong portfolio of brochures and other materials for patients, for caregivers, and families, and they're completely free of charge for you. So if you find yourself in a situation wanting to connect with others, or you want to connect with us, or if you need information and resources, reach out to us. We're here for you. It's now my pleasure to introduce two friends who have been foundational leaders for many years with the ABTA. They are currently serving as honorary board members. Please meet and hear from Don and Gail Siegel.
Hello, everyone, and welcome to the Saturday session of the 2020 ABTA National Conference. ABTA was founded by Susan Kramer in 1973, whom you met yesterday. Susan was the association's birth mother. Donald and I were ABTA's adoptive parents. We know too well the loneliness caused by a brain tumor. Our son was diagnosed with an inoperable tumor in 1975 when he was just 7.5 years old. Our goal was to erase that loneliness and the accompanying fear by instituting a wide range of patient service programs. We also hoped to realize a future where brain tumors became just another treatable disease, by funding all manner of research projects and encouraging the best and the brightest to become involved in that research. In the intervening years, those programs have been expanded and enlarged, including the conference you are attending today. The first conference was held in 1993 to commemorate the 20th anniversary of our founding. Since then, we have held dozens of conferences, local, regional, and national. We have funded hundreds of researchers and research programs. And as importantly, we have had a seat at the table when brain tumors were the topic in governmental, professional, and patient advocacy organizations. ABTA has been here to assist you and to amplify your voice in many ways. We hope that you continue to let us know your concerns and needs and how we might increase our efforts on your behalf. You are the reason for our existence. We are optimistic that we will be able to meet you in person next year when this horrible pandemic is finally under control. Until then, be cautious, be well, and use this virtual conference to your advantage. And by the way, our son is now a 45-year survivor and counting.
Good morning and welcome. We hope you found yesterday's program to be meaningful, productive, and helpful. We expect today will be the same. As a veteran of over 25 years of these meetings, I can appreciate the work that is required to make it successful, and this year even more. So I thank Ralph, Nicole, Emily, and the whole staff of ABTA for pulling all of this together these challenging times. And I thank you for joining with us under these unique circumstances. I have always left these meetings a little more optimistic and certainly energized, and hope you feel the same. Soon after Susan set up ABTA in 1973, we started raising funds and early on realized the need to wisely utilize our funds. We asked one of our medical advisors what to do, and his advice back then, as you've heard, is give the money to the best and the brightest of the young researchers. We did just that, and we are still doing that. We give the money to encourage researchers at a time when they need to be encouraged to get into the brain tumor field. And it has worked remarkably well, with so many staying in the field and devoting their professional lives to find the cause and the best treatment for brain tumors. Another important and successful utilization of our funding is the Central Brain Tumor Registry of the United States, CBTRUST. Over 25 years ago, ABTA created a committee to study the feasibility of a national registry. At that time, there was no such thing, for the purpose of setting up an organization, which is now CBTRUST, to gather and disseminate brain tumor incidence and mortality data to the professional and lay community. For all these years, that has been headed by former ABTA board member Carol Krujko. ABTA continues to be a major supporter of CBTRUST. If you wish additional information, I suggest that you go to the cbtrust.org website. So as you can see, ABTA has been at the forefront of utilizing the financial support of our many generous donors to advance research and build a better future for patients and families.
Don and Gail, for your contributions to the ABTA and sharing with us today how our resources and funds have evolved over time. In our first session of today's program, you will listen in as a multidisciplinary panel of expert clinicians simulate the review of brain tumor cases to determine the best course of treatment for patients. This session really shows you how complicated care decisions really are. Serving as our panel facilitator is our conference planning co-chair, Dr. Mark Gilbert. Please welcome Dr. Gilbert, who will introduce each of our panelists.
Great. Thank you, Emily. We are really lucky, fortunate to have an outstanding panel to describe and to show you what a tumor board is like. And again, as Emily stated, this is an integral part of decision-making for patients with brain tumors. So today on our panel, we have Dr. Eva Galanis. Eva is a neuro-oncologist at the Mayo Clinic and also chairs the Alliance Oncology Cooperative Group Brain Tumor Committee. For those of you who participated yesterday, you saw Dr. Sean Harvey-Jumper, who's a neurosurgeon at the University of California, San Francisco, and an expert in brain tumor biology. Dr. Jason Hughes, who's a neuropathologist, one of the top neuropathologists in the United States, and he works at the MD Anderson Cancer Center. Dr. Vijay Ramaswamy, who's a pediatric neuro-oncologist at the Hospital for Sick Children at the University of Toronto, and is an outstanding physician scientist. And finally, Dr. Jennifer Yu, who's a radiation oncologist at the Cleveland Clinic and also an outstanding physician scientist. They will join me today as we discuss three different cases. Thank you all for your participation. So if we can have the next slide. Again, no disclosures. Next. Next slide, please. All right, I will start with our first patient. The patient in 2006 was 39 years old and volunteered as a normal control for a study that required a brain MRI. There was an incidental finding, as you can see on the slides. The yellow arrow highlights an area of abnormality on a scan called a FLAIR image. It was determined to be behind the motor strip, and as the patient was a normal volunteer, the physical examination was unremarkable. Next slide, please. So we're going to have a short discussion about the MRI findings, the differential diagnosis, and then I will ask the panel how they would manage this patient. So I'll ask Dr. Harvey Jumper to give us a quick description of what he saw on the imaging studies.
Yeah, thanks. So this 39-year-old, I saw a minimally enhancing expansile lesion in the left parietal lobe. Expansile meaning that it likely represents an intrinsic tumor as opposed to some other pathology that's right on FLAIR, meaning the sequences that show you that could also show up just edema. So I think that probably is an intrinsic brain mass. I think it's, I'm assuming the patient's right-handed. I missed that part.
Yes, correct, right-handed. Mm-hmm.
So I assume this is dominant hemisphere. That's my differential, is that it's likely an intrinsic brain tumor given his age, probably glioma. I would predict in the grade 2 or 3 range, somewhere in there, dominant hemisphere and behind motor cortex, which kind of influences my recommendations from a surgical standpoint.
Okay, Dr. Galanis, any difference from Dr. Harvey Jumper?
I completely agree with that. I mean, obviously, and for our advocates and survivors who are watching us, things we always take into consideration in the differential diagnosis include things like, for example, infection, a stroke, things like a demyelinative disease, such as, variants of multiple sclerosis. But for all the reasons that we discussed, I would also lean more towards a primary brain tumor. And because of the enhancing pattern, I would think more low grade, but perhaps also intermediate grade.
Dr. Yu, in your opinion, what does the fact that this was found sort of by accident, does that influence your decision making?
So we're fortuitous that we found this at a relatively early stage before the patient developed any symptoms. I agree with Drs. Harvey Jumper and Dr. Galanis that this looks more consistent with a lower grade glioma. And considering that this patient is asymptomatic, I think it's reasonable for us to continue to observe the patient.
Great. And Dr. Ramaswamy, although the patient was 39, if you had a comparable incidental finding in a teenager, what would your thoughts be?
Certainly in a teenager, our differential probably wouldn't be that different than what's proposed. And at that age, we advocate very strongly for observation.
Okay. So I'll turn back to Dr. Harvey Jumper, who would likely be the first person to see the patient. What would you do now?
Yeah, so, this is all in collaboration with the patient, but I would actually take a slightly different stance, and I would share with the patient our differential diagnosis and what we know about the natural history of gliomas. We know there's been a number of publications including a French cooperative group, UCSF group. I think Mass General has produced some data on this topic, but incidentally found, patients with incidentally found gliomas with a small series of patients in these studies do have a slight increase in survival, primarily because the tumors are found at a smaller size and their extent of resection is greater. So with that in mind, I would talk to the patient about the risks of surgery, their feelings about observation versus resection, meaning where are they in life right now, and could we do this at a time and in a way that would interfere minimally with their lives. And if all things were equal for them, I would actually steer towards early resection or at least biopsy rather than observation, because I know the safe operation that I can do is best, that I can do most effectively with a smaller tumor. So I guess that's a slightly different perspective than some of the other tumor board members.
Okay, Dr. Galanis, your thoughts?
Yes, I mean, I think it's the way I see that is, I think obviously in conjunction with the time we are discussing. At that time, the time of diagnosis of the specific patient, I would perhaps have leaned towards observation. I have to say today, I would obviously offer that as an option, but I would also encourage along the lines of at least a biopsy, because we know now that that gliomas that maybe appear as low grade on imaging, they're not all created equal. So if this tumor on biopsy had certain molecular characteristics, and I'm sure we'll discuss more about that later on, for example, you know, CDK and 2AB deletion or other characteristics, or a complex chromosomal profile that will make me think that that's a more aggressive tumor, that would be one of the criteria that I would use to say, taking into consideration the risks and benefit, I would lean more towards an earlier resection. The other issue is, of course, the socioeconomic status, and if the patient would be willing and able to come for frequent follow-up. So if I have a patient who is highly informed and wishes to come for a relatively close follow-up, at least the first few imaging follow-ups, I would be comfortable with observation if that's what the patient was. In situations where we're not going to see the patient again for 5 years, when they have some serious neurologic symptoms, I might be leaning more towards advocating an earlier intervention.
Dr. Yu, your thoughts?
I think I agree with what's been said. You know, I think that if this is a patient who is agreeable to being observed, then that is certainly a very reasonable thing to do. Some patients like to know what they have and feel very uncomfortable knowing that there is something that we're continuing to observe. And so in that case, having an intervention may make them feel more comfortable.
Great. Next slide, please. So the patient was followed with serial imaging, no intervention. In 2008, at age 41, there were slight changes in the flare in the imaging with some headaches, and the patient underwent a near total resection. There was some residual flare in the left cingulate gyrus, and postoperatively, there was part of the visual field was lost, and that was thought to be due to some vascular compromise with the operation. Next slide. Okay, so Dr. Hervey-Jumper, do you want to take us through what you see on these images? We have the initial, the pre-op, and then the post-op image.
Yeah, so in the initial, again, we see a left-sided flare expansile lesion, or non-enhancing expansile lesion. In 2008, that the volume of involvement is, the volume of the mass is larger. You can see where now it's extending out to the cortical mantle, and the edge where previously it was more midline, extending out more. posteriorly into the cortical rim. I can see a very nice postoperative scan where they took the resection through the parietal lobe, through the superior parietal lobule, as we call it, stopping at the level of the cingulate gyrus and the cingulate sulcus, which is kind of that medial line that you see there next to the ventricle. And there's a little bit of cytotoxic edema or a little bit of swelling in the surrounding brain around the mass, around the resection cavity, but that all looks really good. It looks like a very nice extended resection.
Great, thank you. Next slide. Pathology. So now I'll call on Dr. Hughes to give us his evaluation and interpretation of the pathology.
So thank you. This is these are H&E stain sections, which give us a sort of a basic idea of the microscopic features of the tumor. The blue dots that you see are cell nuclei, and the pink in the background is what we refer to as the cytoplasma of these cells. But in the brain, it tends to intermingle with the cytoplasma of cells next door, and so you get just this kind of background effect where you see these nuclei suspended in this pink matrix. And anyway, what you see here are predominantly tumor cells, and they have some very characteristic features. Particularly if you look at the figure on the right, we see the nuclei are each surrounded by this clear sort of halo ring. It almost makes it look like what we refer to as a fried egg. If you imagined instead of a dark nucleus that you would have an egg yolk there. This is a very characteristic feature of oligodendroglial differentiation. The figure on the left, you don't see as much of that. And given that this was in 2008, there might have been a tendency to call something like this actually a mixed oligoastrocytoma. I guess we will probably, we'll see in the ensuing slides how that diagnosis has fallen out of favor more recently, as there isn't really a definitive molecular signature associated with oligoastrocytomas. They tend to be either oligodendrogliomas or astrocytomas. But in any case, this is a diffusely infiltrating glial neoplasm with certainly strong oligodendroglial features, although there are some more features that may also be associated with at least conventional astrocytic differentiation on the left.
And Dr. Hughes, what WHO grade would you give this tumor?
Sure. So we don't see a lot of proliferative activity. In other words, sometimes we can actually even see the cells dividing under microscopic examination. We don't see a lot of that here. We also don't see any other overtly high-grade features in those images. Proliferation in blood vessels, areas where the tumor dies, which we refer to as necrosis. That's actually not a good thing. You would think if your tumor died, it would be a good thing, but it usually is an indication that it's growing so quickly, it's outgrowing its own blood supply. So it's usually a sign of malignancy. We don't see that here either. So given the absence of overtly high-grade features in these figures, I would favor classifying this as a WHO grade 2 neoplasm, which is the lowest grade that you can get in a diffusely infiltrating glioma of adults.
Right, so your 2008 diagnosis would be a grade 2, potentially oligoastrocytoma.
Mm-hmm.
Great, next slide. So in point of fact, the pathology report back then called it an oligoastrocytoma, WHO grade 2. And do you want to talk, Dr. Hughes, about what is that 1p19q co-deletion?
Sure. So this is actually a discovery that goes back into the 1990s. It was discovered that tumors that were oligodendroglial in character, they had this very characteristic molecular alteration by which they lost the short arm of chromosome 1 and the long arm of chromosome 19 at the same time. And this was referred to as 1p19q co-deletion. In a lot of ways, we still don't know exactly what that does for the process of inducing tumor formation. But we do know it's a highly specific marker for oligodendroglial tumors. And since then, all of the extensive molecular profiling that's been done on tumors at the last 15 years has only served to strengthen that connection. And so if we saw something like this these days with a 1p19q co-deletion, actually, importantly, as we'll probably get to, a mutation in isocitrate dehydrogenase, that is defining for the diagnosis of oligodendroglioma.
And again, we see something there called an MIB1. Do you want to tell folks what that is?
Sure. MIB1 is an immunostain that we use. So now this is not an H&E stain anymore. These are stains using antibodies that bring out specific proteins that are on the slides themselves. And this particular marker is a marker of proliferative potential in a neoplasm. Basically, any cell that's in the process of dividing, in a matter of speaking, is stained positively by this. And so if you see 3% of the nuclei in a neoplasm staining positive for MIB1, that is a low level of proliferative activity, and which is also, once again, consistent with this tumor being a low-grade glial neoplasm.
Great. Okay, so at this point, it's 2008. Dr. Yu, you're seeing the patient in consultation. What's your advice about treatment or follow-up, or how would you counsel the patient?
This is a relatively young patient, now 41 years old, had a relatively smallish tumor. It did not extend to the other side of the brain. This patient had a near total resection, or a gross total resection of the tumor, and has a low-grade glioma, a very favorable type of low-grade glioma, an oligodendroglioma. I think at this point, the patient has several different options. Observation would be one option for this patient. So if the patient's amenable to observation, I think that is certainly a consideration. At this time, radiation could also be considered. Now, radiation can improve a progression-free survival, so that means there's no evidence of the tumor growing, but radiation does not impact the actual survival of the patient. And so the timing of radiation becomes really important. And so the question is, well, should we do the radiation now, or should we do radiation later on at the time of progression? And that's a difficult and controversial area because radiation has a number of side effects. I should say radiation also is a 6-week course. So it's not a one and done quick treatment. But what we are very much concerned about are the long-term sequelae of radiation. And these include changes in memory, changes in cognition that can be seen years down the road. Patients may find it difficult to concentrate. They may have problems with word finding difficulties. They may have problems with their endocrine function as well in the long term, and may need to be on thyroid replacement pills, for example. Long term, the patients can also be at risk for radiation-induced cancers. That's a low risk, but it's still present, especially for young patients that are expected to survive a long time. So I would speak with the patient about the pros and cons of doing radiation upfront or delayed. And in this particular case, I would recommend observation because I think she is at very low risk of progression.
Okay, so Dr. Galanis, your opinion?
So I would actually have taken a slightly different approach. Going back to the late 90s, where the RTOG 9802 study was decided, it was designed and started, which I think is a very important study that nowadays informs our management of low-grade glioma. So they used at that time clinical characteristics. And what are the two clinical characteristics that were felt that would predict outcome? One is age, and they used age of 40 as a cutoff. And Mark, can you remind me the age of this patient?
39 at discovery, 41.
41 now, yeah. And also the extent of resection. Anything less than a gross total resection was viewed to be a high risk factor. So technically, this patient would have been a candidate for the higher risk arm of that trial. And if I can remind our audience, the study then randomized patients to either radiation or radiation with chemotherapy. And now, of course, we have the long-term results that they were published in 2015 in New England Journal, where in a patient like this, radiation alone would lead to an approximately 3-year of progression-free survival versus radiation plus chemotherapy, which was 8.4 years. So at that time, also importantly, patients who were viewed as being low risk, in other words, younger than 40, and who had a complete resection, a gross total resection, went into the observation arm of that study. And we know, and even in that very good prognostic group, about 50% of these patients end up recurring down the road. So, I mean, these tumors can be innocent, but not as innocent as, they look. Would observation be wrong in an informed patient? Absolutely not. Would observation especially be appropriate back then? I think I would have felt very comfortable with observation based on the state of our knowledge back in 2008.
Great, thank you. So I'll ask Dr. Ramaswamy if this patient, again, was a teenager with the same appearing imaging and the same pathology.
So certainly this is relatively rare in the teenage population under the age of 18. Certainly our threshold to radiate would be much higher, and we would try to avoid that, certainly due to the long-term side effects, and we certainly don't know how long this would take to progress, but we would expect it to be a fairly long, if it were to progress, we would expect this to be a much later event. So our preference would be to definitely be to observe this patient.
Okay, great. So for everyone listening, I hope you get an appreciation for the type of conversation that goes on. There's not a cut and dried answer. In this case, the guidance about the 40-year-old, the patient was 39 on discovery, 41, so obviously right in that gray zone. Next slide. So as Dr. Hughes mentioned, we do have much more advanced molecular characterization, and this patient actually underwent panel sequencing, the brain tumor panel that's done at the NIH. And if you want to just quickly tell us what was found and how that impacts diagnosis now.
Sure. So what you see here are mutations that were discovered in the genes IDH1 and FUBP1. So IDH1 stands for isocitrate dehydrogenase 1, and it's probably the single most important biomarker we have in adult glioma biology at this point. It designates sort of more indolent, lower grade diffuse gliomas from the fully malignant IDH wild type glioblastomas. And so this is entirely consistent with the classification of this tumor as an oligodendric glioma, especially when coupled with the earlier finding of 1p19q co-deletion. I could talk exactly about what exactly IDH1 mutations do in terms of glioma biology for probably about an hour and a half, but I don't think you guys want to hear that right now. So the FUBP1 mutation is also intimately associated with oligodendroglial glial differentiation. This is a gene that's located on chromosome 1, and the thought is that this may reflect some sort of tumor suppressor where now you have this mutation in FUBP1 on one copy of chromosome 1 paired with the loss of the short arm of chromosome 1 on the other chromosome. Although the exact biological consequences of this are still a subject of active research. Bottom line is this is very consistent with the diagnosis of oligodendroglioma Hu grade 2.
Right, and emphasizes for our audience how the histopathology under the microscope combined with molecular testing can confirm a diagnosis. Next slide, please. Okay, and we've talked about the integrated diagnosis. We've talked about the treatment. And Dr. Yu mentioned about the health-related quality of life considerations with early versus late radiation. Next slide. So the patient in 2010 had some seizures, now 52 years old, 10 years post-resection, doing well, and is followed with imaging twice a year. Next slide. And so we'll call on our neurosurgeon and fill-in neuroradiologist, Dr. Harvey Jumper, to take a quick look at these, starting in 2009, 2013, 2016, and 2018, and comment quickly on what you see.
Absolutely. So if we're looking through serial imaging between the dates you described, 2009 through 2018, you see increase in this linear type of flare signal, this white line along the lateral edge of the resection cavity, just next to a sulcus there, and it's increased in diameter, especially between 2013 to 2018, probably 2 or 3 times the diameter that it was in 2009. That combined with the new seizure are suggestive of progression of disease.
Right. All right, so I will ask Dr. Galanis. The patient had seizures in 2010. In 2018, we have image that has, as Dr. Harvey Jumper clearly articulated, has changed, but she's otherwise fully functional and asymptomatic. Your recommendation?
There are two ways I would approach that. One is as a standard of care, and the other, in terms of clinical trial availability. In terms of standard of care, I mean, I'm not convinced that she really has any new symptoms. As Dr. Harvey Jumper, discussed, I mean, I agree there is disease progression, and so yes, the seizure activity is associated with the residual tumor. Not convinced that that's really the disease progression. So I would share my concern about disease progression with the patient, and if she preferred to continue follow-up, and perhaps I would go more into a 3-4 month follow-up as opposed to twice a year, and observation of symptoms, I would be comfortable with that. The other possibility, so this patient could also be a candidate for an IDH inhibitor trial. And we know that right now there is a randomized study that, essentially randomizes patients like this example, patients who have not had radiation or chemotherapy for their disease, and randomizes them to either receive the IDH inhibitor or placebo. So I think that would be a very appropriate study for the patient, and I will have the discussion with them about the possibility of enrolling in the study of targeted treatment.
Dr. Harvey Jumper, would you recommend a reoperation at this point?
I think that should certainly be discussed with the patient. If for both extended resection benefit potentially, as well as tissue classification, right? At this point, we don't know what it is. So whether it still represents a grade 2 or it represents a up classification to a 3 or even a 4, I think 4 would be unlikely, but could this represent a different type of tumor now? This also has to be factored into where they are in life. At this point, this is a patient who's already made a decision about surgery, so I assume a visual field cut is not significantly impacting their lives. They're not a commercial pilot or something like that. And so the major complication I would have them expect or think about with reoperation if it was to be removed could be that their number of their visual fields could be affected just a little bit more than they already are. So that would have to be a discussion with the patient. But identifying a new tissue diagnosis, I think, should certainly be discussed with the patient for sure.
Dr. Hughes, what's the likelihood that this is changing its WHO grade, becoming more aggressive? Is that a common phenomenon?
It can happen, but given the kinetics of the growth here and I mean, I guess I'm not seeing a contrast enhanced MRI here, but my suspicion here would be that it is not progressed in terms of its grade.
Okay, great. Next slide. Okay, so Dr. Yu, your opinion whether we should intervene with treatment now or continue observation?
So I think that they're both options for this patient. And I certainly would recommend that the patient enroll in a clinical trial that will can potentially benefit the patient, but also benefit all the subsequent patients that have this type of tumor. You know, considering that this patient did have seizures and the patient is non-compliant with seizure medications, I do think that it's reasonable to recommend treatment with chemoradiation at this point. We know that radiation can help to improve seizure control, and especially for patients that have a history of being non-compliant, then I think that recommending chemoradiation is certainly reasonable.
Great. Thank you all. That was a great discussion, and I think demonstrated how important it is to have conversation, not only amongst colleagues, but everybody emphasized the need to discuss the findings and the potential options with the patient. Next slide, please. So we're going to go to patient 2. We'll be a little quicker with this patient, but it's really just to contrast disease biology. This is a 41-year-old right-handed man who was previously healthy. He was a graduate student at the time of presentation with seizures in 2006 at the age of 28. And again, we have MRI scans, and you can see that on the post-contrast scan, we don't see much in the way of contrast enhancement. That is the image to the left, and on the right-hand side, highlighted by the yellow arrow, we see the flare abnormality. And we see that this flare abnormality, in contrast to the first case, is not as well contained. It's actually in several different regions, all connected. Next slide. So, Dr. Harvey Jumper, your differential diagnosis?
Again, an intrinsic brain mass has to be included in the differential diagnosis, high or low grade based on age. We have to include infectious etiology, inflammatory etiology, other types of tumors that spread to the brain, I think, are much less likely. Encephalitis, vasculitis can also be added in the differential. Again, there's an expansile quality to this. So I do think this likely represents an intrinsic brain tumor, such as a glioma.
And would you observe this, biopsy it, or try to remove as much as possible?
Yeah, unlike the last case, this is a situation in which there is a cortical component to the tumor that would need to be removed through brain mapping, but there's also a deep component even extending into the thalamus. That's not enhancing, and that removing that area could be very detrimental with long-term serious neurologic consequences for the patient. Again, this is obviously a discussion with the patient. I would tell them that my estimated extent of resection, meaning the goal would be to remove as much as possible using a brain mapping technique. It would not be a gross total resection. This is a case I certainly would want to discuss with the tumor board prior to surgery, to discuss the option of biopsy versus maximum extent of resection. I would lean pretty heavily on the patient as well with respect to their preferences, because even with brain mapping, I think there is a chance that some of their language would not be the same afterwards, including reading comprehensions and some things like that that are really hard to work with moving forward as a graduate student, if I heard that correctly.
You heard it correctly.
Yeah,
Thank you very much for that input.
That could be tough.
Next slide. So the patient did undergo a biopsy, and the pathology revealed a grade 2 oligodendroglioma with the 1p19q code deletion we talked about before, and no further treatment was initiated then. Next slide. So 6 months after diagnosis on surveillance MRI, there was disease progression, and the patient was treated with the chemotherapy agent temozolomide, and 24 cycles were given. And soon after completing that MRI, now showed disease progression with concern now for transformation, as we talked about, as a possibility with the last patient, leading to another tumor biopsy. And now the patient was found to have an anaplastic oligodendroglioma, WHO grade 3. Dr. Hughes, do you want to quickly describe for everybody how you distinguish a grade 2 from a grade 3?
Sure. So these tumors tend to be more cellular. In other words, more densely, there are more cells per unit of area in the microscopic slide. The cells can often appear more atypical in terms of their morphology. But most importantly, overtly high-grade features can be present, which include vascular proliferation. So that means enhanced proliferation within blood vessels, necrosis, tumor death, as I described before, and increased proliferative activity, as you see by either mitotic figures in the cells themselves or increased MIB1 immunostaining, as we talked about earlier.
Next slide, please. Next slide. Okay, so this is just to show how there's a change, and I think everybody can appreciate, particularly with the help of the red circles, that it became much more extensive. Next slide, please. Again, now showing a little area designated by the arrow that is picking up the intravenous contrast, which was a clue that it had undergone a malignant transformation from grade 2 to grade 3. Next slide. So again, looking in retrospect, after that initial biopsy, and again, without a resection, would we in retrospect have recommended a different strategy, Dr. Galanis?
Yes, I mean, thank you for choosing this case, Mark. I think is illustrative for more than one reasons. I mean, this is a situation where what we know today about the beneficial effect of radiation and chemotherapy in high-risk patients with low-grade gliomas, I think is very applicable. And as we discussed, use of radiation and PCV chemotherapy in this large national study improved median progression-free survival from 3 to 8.5 years, and overall survival from 7.3 to 14 years. Also, at the time that the diagnosis was made, because the 1p19q co-deletion and the IDH status of the tumor are associated with chemosensitivity, it was very common to just treat patients with temozolomide chemotherapy. And we now know that that's not necessarily always a good idea. This year, we had 2 pieces of data that I think are very informative. One is coming from UCSF that was presented at ASCO this year, and they presented their experience for patients with the IDH mutation, so like our patient diagnosed with low-grade glioma and treated with temozolomide. And what they found is that the majority of the patients, about 80%, would recur with high-grade tumors, what we call a transformation. And then the majority of these tumors will have this molecular alteration called hypermutation that it is associated with a negative prognosis, so much more aggressive tumors. And at the same time, we had the publication in Nature this year of a series of approximately 10,000 patients with a database emerging from Keith Ligon's group, who similarly found that, exposure to temozolomide early on in the disease course is associated with this hypermutation, this more aggressive phenotype at recurrence. So I think we need to keep it in mind when we take low-risk patients or low-grade glioma patients and we put them on temozolomide early on in the disease course. I mean, that needs to be taken into consideration. The other piece of data I want to quickly mention is data that they were just published last month, coming from another national trial, the CODEL study, the N0577. And in the earlier version of the study, one arm of the patients just received temozolomide alone. So at 5 years with temozolomide alone, approximately 70% of the patients had relapsed, as opposed to 34% if some form of radiation with or without chemotherapy was used. So retrospectively and based on the information we have, I think we would have done something different. But, and to connect that with the next session in the afternoon, we're going to talk about clinical trials. The reason we know that we would have done something different is as a result of two large national trials, as well as the prospective, careful study of data from individual institutions. So a lot of thanks go to our patients who will allow us, next patient who comes to us with the same histology and characteristics, will allow us to treat differently.
Great, thank you. So next slide, please. So the patient did get radiation therapy, finished in 2010. I'll quickly go through the history. So after that was observed January of 2014, there was progression. There was a third surgery, this time a more extensive resection, found to have the same grade 3 or anaplastic oligodendroglioma. Next slide. And you can see what the tumor looked like at the time of that third recurrence. Next slide. And then you can see the partial resection. Patient was then treated with chemotherapy, which is a standard chemotherapy for oligodendroglioma, procarbazine and CCNU. And then another resection, the fourth resection, and then reirradiation. And we can talk about that, but unfortunately we're running short on time. But we have found that it is safe, carefully done to reirradiate patients, particularly if there's been an extensive amount of time. Next slide. Patient was stable until 2017, and again had evidence of regrowth of tumor after the resection and reirradiation, and underwent epilepsy surgery because he had refractory epilepsy. There was active oligodendroglioma. Next slide. And here's a look at the pathology. If Dr. Hughes, you want to quickly describe what you see.
Yeah, so it's much more cellular than the last example that we saw. And of note, on the lower left-hand corner in particular, if you look at the blood vessels, they are proliferated and expanded. This is a feature that we associate with malignancy.
Okay, thank you. Next slide. And we did extensive molecular testing. Here we have something called whole exome sequencing with a mutational burden of 1.3 mutations per megabase. That's just a measure. Hypermutator, most people define it as greater than 10 mutations per megabase. Next slide. And again, we can discuss this. Unfortunately, we're running a little short on time, but the patient was placed on immunotherapy. Next slide. And completed a full course, 16 cycles of nivolumab, the anti-PD-1 immunotherapy, and remained stable. So again, the two cases, both had oligodendroglioma, had a very different clinical course. Fortunately, both patients continued to do well. Next slide. Let's turn now to our third patient. This is a pediatric case. This is a 9-year-old right-handed young man who in 2009 presented with headaches, vomiting, and ataxia. MRI scan showed a mass in the midline, no history of cancer. They put in a drain because he had what we call hydrocephalus, and then took the patient to the operating room. Dr. Harvey Jumper, do you want to quickly tell everyone what you see and how you would approach this surgically?
Yeah, there's a mass, partially enhancing cystic solid mass within the posterior fossa or the back of the brain. Looks like it's different within or either within or compressing the fourth ventricle. This is a situation in which a patient has what we call a suboccipital craniotomy. They're face down, they have an incision in the back of their head extending from just about the midline, halfway down the skull down to roughly the second or third vertebrae. And we enter through that midline approach to remove the mass. And the surgical goals are not only diagnosis and maximum extent of resection, but also to relieve hydrocephalus or the fluid buildup as well, because the mass is in the fourth ventricle, thereby causing a fluid buildup, which is called hydrocephalus.
Thank you. Next slide, please. And again, you already mentioned, is there a role for biopsy treatment, or would you propose trying to take it out?
I think there's pretty clear-cut evidence that we would try to remove. Not a lot of controversy here.
Great. Okay, next slide. Patient had a complete surgical resection, awake immediately post-surgery, but 1 day later stopped talking, was very irritable, couldn't sit, stopped eating, and had nystagmus. Dr. Ramaswamy, do you want to describe what this patient had?
So this is a very common a common scenario after surgery for this particular tumor, especially in the posterior fossa. And this is called something called posterior fossa syndrome, or cerebellar mutism is the other name for this. So this is something we see in approximately 20 to 25% of children with this diagnosis. The natural course is that this gets better. And although we say that this is a result of surgery, certainly this is not the surgeon's fault, and it's not a result of the surgeon themselves, but it has to do with when you decompress these tumors. So when these tumors are removed and you relieve that pressure, this is a complication that can unfortunately occur as a result of the treatment.
Great, but typically reversible.
Yeah, the natural course is this gets better over the first 30 to 60 days after surgery.
And you advise the parents in advance, of course, right? That's,
of course.
Yep. Next slide. Next slide. We've already talked about that. Pathology, Dr. Hughes.
So this is what we like to refer to as a small round blue cell tumor, which sort of speaks for itself. I don't think I really need to describe more in that regard, which is evidence of what we call an embryonal neoplasm. The most common of which, particularly in this age group, is and in this location is medulloblastoma.
Great. Next slide. So back in 2009, they called it a medulloblastoma with classic histology, and back then could stain for a protein called MYC. It was non-MYC amplified. Dr. Ramaswamy, do you want to give us a quick overview of how our thoughts about medulloblastoma have evolved?
Yeah, so over the past 10 to 15 years, what we've learned is that even though almost all medulloblastoma looks like that, the previous image that Dr. Hughes described, it's actually comprised of 4 distinct diseases, and we call these subgroups. And they refer to their, not to get too much into it, but these are really quite very distinct in terms of their clinical behavior, their survival, and their biology. So the 4 groups are called WNT, Sonic Hedgehog, which is actually in relation to the character from the Sega Genesis game from the 1980s, Group 3 and Group 4. And so this patient has a Group 4 medulloblastoma, which is the most common medulloblastoma. It's present in about 40 to 50% of patients in this age group. And of these 4 subgroups, there's quite a bit of prognostic information. So the WNT subgroup is the best performing. These patients have survivals close to 100% with our current therapies. And a group called Group 3 have poorer survivals. So we've significantly improved our ability to study medulloblastoma, but also predict survival, which is also changing how we treat these patients in our most recent clinical trials.
So Dr. Hughes, what is the current pathology standard when you have a tumor that looks like a medulloblastoma? What do you do in addition to look at it under the microscope?
Well, it depends. It depends on the institution that you're at. The current standard at our institution is to try and determine whether it is within the WNT or Sonic Hedgehog categories, because at this point in time, there's lots of heterogeneity in Group 3 and Group 4 that has to be worked out in terms of to establish sort of definitive prognostic patterns and whatnot. So we typically do a beta-catenin immunostain to determine whether or not it's a WNT driven medulloblastoma. We're looking there for nuclear reactivity. In this case, we had cytoplasmic reactivity, which does not count. GAB1 is an immunostain that's used to determine whether or not a tumor is in the Sonic Hedgehog group. We also usually run a P53 stain because that has direct implications within the Sonic Hedgehog group in terms of patient performance, with P53 positive tumors doing worse and P53 negative tumors doing better. You can also run additional testing. In this case, it looks like a nanostring test was done, which actually can refine groups 3 and 4. And there are other biomarkers that you can do, which have associations with the groups as well. As you mentioned, MYC amplification is classically, they're not invariably associated with group 3. Isochromosome 17q is a classic medulloblastoma finding, but it's most strongly associated with group 4.
Great, thank you. Next slide. So we've already talked about the integrated diagnosis, how to proceed. Dr. Yu, what do you recommend?
So I recommend for these children with cancers, they really need to see pediatric specialists, and all of the patients should be on a clinical trial. So, my recommendation is that the patient really enroll in a clinical trial if there's one that's available. Now, as far as standard types of treatments, we think of these patients as being in different risk categories, and we also take into consideration the patient's age. And this is a patient who is 9 years old. Considering the type of cancer and the pattern of spread, this is a patient for whom I would recommend radiation followed by chemotherapy. And the radiation is involving the entire brain and the spine. So this is a considerable amount of radiation that you are giving to a young child.
So would you recommend protons or photons?
So I would recommend protons for this patient. We can perhaps advance to the slide with protons. And protons are a different type of radiation as opposed to photons, which are X-rays. So protons are particles, and they have this property where they deposit almost all their energy within a very narrow peak. So once they traverse a certain amount of tissue, there's no more radiation beyond that point. And you can see the proton plan on the left. And these colors, they represent different doses of radiation. So there's the orange color, the green, blue, purple colors. And the orange color is the dose of radiation that we are delivering to this particular patient. And in particular, if you look at the proton plan, you can see that there's no blue that's extending beyond the vertebral column, right? So in the area where there's the heart, there's the stomach, bowel, all of those areas are spared from radiation compared to the photon plan shown on the right. And that has significant consequences for this patient, right? So the patient may experience less nausea or vomiting during the time of the radiation treatment. Proton therapy can also reduce the risk of long-term deficits as far as learning. Radiation for these patients, whether it's by protons or photons, is largely covering their vertebral bodies or covering the spine. And so that can have important ramifications as far as the patient's growth is concerned, because the bones are not able to grow properly because of the radiation. The patient may also have hormone disruptions as well because of radiation to the pituitary gland. And so I would anticipate that this patient may have long-term endocrine disruptions as well.
Great. But the recommendation is proton for all the reasons that you stated.
Absolutely.
Great. Thank you. Next slide. So the patient was treated with actually photon and then followed by 4 cycles of chemotherapy based on a clinical trial. Recovered from the syndrome, returned to school in regular classroom with some modifications to the curriculum. Next slide. 2 years follow-up, started having growth delay and fatigue. And as you predicted, Dr. Yu, the patient did have some pituitary dysfunction, some growth failure, required growth hormone replacement. And at 5 years had no evidence of disease, recurrent disease. Dr. Ramaswamy, do you want to make a final comment about this patient and the treatment course?
Yeah, so certainly this was in 2009, and so at that point protons weren't as prominent, but certainly I would agree with Dr. Yu that we would refer all of our patients to protons. In fact, Canada doesn't have a proton facility, and we've been sending patients to the US and paying for it. Even through COVID, in fact, we've been sending patients to Florida, so we feel strongly that it's worth getting proton therapy. And certainly we try to put all patients on clinical trials, but in general with this treatment, the outcome is very favorable for these patients. So.
Great, thank you all. I think we have some time for questions. Emily, is that true?
Yes, thank you, Dr. Gilbert, and thank you to all of our tumor board panelists. We do have some time for questions. Just as a reminder, if you do have a question that you'd like to ask our tumor board, please type and submit it using the question box at the bottom of your control panel, and we'll answer questions as time allows. So, Dr. Gilbert, I'll direct the questions to you, and if you can please direct them to the appropriate panelist member to answer. So the first question we have here is asking, in all health centers, treatment centers, does the tumor board consist of experts nationwide, or are they just experts within that treatment center?
So I will ask Dr. Galanis, who is involved in the Alliance Oncology Cooperative Group, where it's a mixture of both academic centers as well as community-based centers.
So it kind of varies. The majority of the major academic centers have their own tumor board. And these are usually the experts of the specific center. But then obviously now an expanding number of academic centers have different clinical associations with smaller practices, community practices. So even before COVID, For example, the Mayo Clinic had a number of virtual tumor boards with other sites. And I know this is happening more and more, and our community partners very much appreciate that, because it's very difficult. It's small town or city with one oncologist sometimes to really have the subspecialized expertise. But what Dr. Gilbert is referring to is another part of work that we are doing with support from the National Cancer Institute, and this is the cooperative group system consisting of more than 500, in our case, in alliance, both academic and community centers working together to develop the best possible trials for patients with brain tumors. And another very important also cooperative group is NRG. And also the NCI has recently sent out a solicitation where it is asking to encourage us, all of us in the neuro-oncology community, to develop collaborations in developing new drugs for brain tumors. So they will be funding a number of collaborative centers essentially to think about how to bring the best possible science with new treatments for brain tumors to the clinic. So these are some of the different board and board-like options, both for clinical and research.
And let me add to that, our own program at the NCI, we also have a network called NCI Connect for patients with rare cancers of the brain and spinal cord. And we've also developed a tumor board that encompasses the member sites around the country who participate in that tumor board, again, for the rarer cancers. So the COVID has sort of pushed us into the virtual world, as we're all on a virtual tumor board, but this is becoming increasingly common, as Dr. Galanis mentioned.
Thank you so much for sharing that. Another question here is asking if you can please explain what brain mapping is and what role that plays in diagnosis as well as selecting appropriate treatments.
So Dr. Harvey Jumper?
Yeah, excellent question. Brain mapping is really based on this idea or knowledge that intrinsic brain tumors like gliomas are not outside of the brain, right? They're made up of part of the structure that helps, that allows information to pass from one part of the brain to the other. So many times these tumors are in areas of the brain that affect functioning. And so in certain locations, particularly in the left frontal temporal parietal lobes, but other areas as well, if you remove the tumor without brain mapping, it could cause harmful permanent neurologic deficits or impairments that would impact quality of life. And so there are a number of ways to prevent that, and one of them is brain mapping, in which during the surgery, you ask the patient to wake up and perform a series of cognitive and behavioral tasks, and you use the mapping results or the performance on those tasks to guide the operation. That's a process called brain mapping.
Thank you so much for sharing that, Dr. Harvey Jumper. Another question we have here is asking about who compromises the tumor board. Is there anyone on the tumor board who discusses or addresses diet and lifestyle changes as appropriate for the tumor and the diagnosis?
I will ask Dr. Ramaswamy if he would talk about the tumor board at his hospital, and then ask the other panel members.
So that's a good question. In general, at least in children, it tends to be a bit more of a consideration, and we do think about diet and lifestyle changes. We don't have somebody specific on our tumor board that addresses this, but at least at our institution, we do work with with some alternative providers, and we work very closely with a dietitian within our group to address these. So certainly in our practice, it's very frequent to address both. And depending on the type of tumor, we have some tumors that the side effect is the tumor is that children actually gain a lot of weight. And this is a scenario where we intrinsically involve our dietitian and nutrition experts.
So Dr. Yu, in your experience at the Cleveland Clinic?
So we do not have a dedicated nutritionist on our tumor board, but we do involve symptom management to help with any symptoms that the patient is dealing with, any pain, any other issues. We work closely with our social workers as well. Sometimes we have a neuropsychologist who is part of the tumor board and can speak to some of the neurocognitive sequelae of treatments, what can be expected and what exercises can be done to help to mitigate those.
And I will say at the NIH, in our tumor board, since we routinely monitor symptom burden using established instruments in our patients, this is part of the clinical description and helps us in monitoring the patient outcomes. And so it does become part of the discussion.
Wonderful. Thank you all for sharing that. Another question we have is asking, are patients able to sit in on the tumor board that is discussing their case? And in addition to that, do patients receive a written record of the tumor board meetings? Do they have access to what's shared during the tumor board?
Dr. Hervey Jumper, do you want to discuss what goes on at UCSF?
Yeah, at UCSF, it's probably very institution specific, but at UCSF, we have had patients on occasion participate in tumor board. I think it's important to remember that while we're having this discussion as an illustrative example with you guys, it's not a patient-facing event. And so we sometimes move pretty fast through cases and can have upwards of 40, 50 cases to discuss within a relatively short period of time, like 2 hours. And so, yes, there are times when patients can sit in and they're invited to sit in, but that's an exception and not the rule. Every time after tumor board, every patient is called about the results. There's a record of the decisions and consensus or non-consensus opinion put in the medical record for the patient, and we do keep tumor board notes. But more importantly, the results about a discussion for each patient are had with the patient after tumor board. That's really how you close the loop. We make sure every patient knows how the discussion went about their care.
Dr. Gilbert, anything to add from the Mayo Clinic perspective?
Same for us. Patient presence, usually an exception for the reasons discussed. And then also we always keep a record and communicate with the patient. So I think for our advocates here in the board who are watching us, I think ask your doctor if the option of a tumor board exists and make sure you connect with them to know the recommendations, I would say.
Great, thank you so much. I think we have time for just one more question. I believe in the first case that was presented, Dr. Hervey Jumper had pointed out that the patient was right-handed. Can you please explain why that's important if the patient is right or left-handed?
Oh, yeah, so that's really a very high-level establishment of whether they're left or right hemisphere dominant for language or cognition or whatever you're worried about. So for a patient with a left-sided tumor, worry about language if they are right-handed. Frankly speaking, most left-handed people still have some element of language in the left hemisphere, but anytime you're talking about lesioning the brain or removing an area or tumor, you want to have be as informed as you can about what the risks may be, and handedness is part of that informed decision-making process that we discuss with patients.
So may I say some closing remarks? I wanted to thank the fantastic panel. That was a great discussion, and I hope that all of the folks watching get a sense of the depth of discussion and the thoughts and thought processes that go behind our making decisions about patient care and how important it is that we involve the patient and have the discussion and make sure that the recommendations are in alignment with what the patient is perceiving to be best for them. So there are cut and dry situations, but there's often discussion and the need to put things into context. So thank you all for just a really outstanding presentation and discussion.
Thank you.
Thank you.
Thank you.
Thank you.
My name is Zhengjie Yang. I'm an associate professor at the Fox Chase Cancer Center in Philadelphia. I was awarded with a discovery grant from American Brain Tumor Association, supported by an anonymous family foundation. Medulloblastoma is the most common malignant brain tumor in children. The improved strategy to treat medulloblastoma are still urgently needed. I have been studying the differentiation of tumor cells in medulloblastoma. Recently, by single-cell RNA sequencing, we identify a subset of tumor cells in human and mouse medulloblastoma. We found that this subset of tumor cells becomes spontaneously differentiated. In other words, they autonomously become mature neurons. Moreover, those differentiated tumor cells stop dividing in vivo and in vitro. After intracranial transplantation in skin mice, those differentiated tumor cells failed to develop into tumors, suggesting differentiated tumor cells have lost their tumorigenicity. Compared with other cells in tumor tissues, those differentiated tumor cells highly express NeuroD1, a helix loop helix transcriptional factor. In false expression of NeuroD1 in tumor cells, inhibit them to proliferate and induce them to differentiate, started expressing differentiation marker MAP2. This data suggests NeuroD1 can drive tumor cell differentiation. As expected, NeuroD1 overexpressed tumor cells failed to form tumors after intracranial transplantation. So this data suggests NeuroD1 stimulated tumor cell differentiation, thereby inhibiting tumor growth. We next examine the epigenetic regulation of NeuroD1 expression in tumor cells. By cheap PCR, we found that the regulatory region of NeuroD1 regions is more occupied by EZH2-mediated H3K27 trimethylations. By immunohistochemistry, we further found that the expression of NeuroD1 in tumor cells was mutually exclusive from H3K27 trimethylation as well as EZH2. This data suggests the NeuroD1 expression in tumor cells is suppressed by EZH2-mediated H3K27 trimethylations. Indeed, EZH2 inhibitor, including GSK126 and even C9999, significantly inhibit the in vivo growth of tumor cells. By immunostaining, we further defined that following the treatment of EZH2 inhibitor, tumor cell differentiation was dramatically enhanced, evidenced by the increased number of cells expressing differentiation marker NeuN. So this data suggests that the EZH2 inhibitor suppressed the tumor growth by promoting tumor cell differentiation. Overall, our study established the differentiation capacity in medulloblastoma, supported to use EZH2 inhibitor to treat medulloblastoma. These findings are recently published in Cell Reports. We are working to test the therapeutic efficacy of EZH2 inhibitor in medulloblastoma treatment in clinical trials. Thank you for your attention.
Hello, everyone. In our next session, you will hear about the importance of patient outcomes assessments in determining optimal treatment. Dr. Mark Gilbert will introduce our next speaker. Thank you so much.
Hello, everyone. As you know, assessing a patient's progress against treatment We call that patient outcomes is an essential step in care. This session will cover the need and benefit of evaluating outcomes for the patients, the scientific progress, and how we use that in our evaluation of new treatments. I am pleased to introduce my colleague and the presenter, Dr. Terry Armstrong, who is both Senior Investigator and as well as Deputy Chief of the Neuro-Oncology branch at the National Cancer Institute. Her program research focuses on clinical outcomes, assessments, and clinical trials. And as a fun fact, she reports that her daughter just became a wildcat, for those of you in the Chicago area, starting graduate school at Northwestern this week, and that she is raising a golden retriever puppy who still thinks he is tiny, although he has eclipsed 50 pounds. So please welcome Dr. Armstrong.
Thank you so much, Dr. Gilbert. It's really a privilege to be here today and to speak to you all about patient outcomes assessment. Next slide. I have no disclosures. Next slide. So as Dr. Gilbert mentioned, I really hope to discuss what the benefit is of using patient-reported outcomes for the evaluation of new treatment, but also hopefully I'll show you the benefit for you as a patient as well as your healthcare providers. The session will be about 30 to 35 minutes. And again, I want to thank the ABTA and the meeting chairs for this opportunity. Next slide. So I think we all recognize that primary CNS tumors are rare, and data shows us that they can impact the person really from the time of diagnosis due to the symptoms and impact on function that they can have. And I'll talk a little bit in more detail about that later. Next bullet point. So there are limited therapeutic options for patients with CNS tumors, and sometimes those treatments show improvement in survival in terms of months. And it's often a question, what's the benefit to the person in terms of months? Are they also having improvement in their symptoms or their function and how they feel and function? Or is it just control of tumor? The graph at the right is a survival curve from the seminal publication by Roger Stupp, showing the difference in survival between the use of concurrent temozolomide and radiation to radiation alone. And you can see the average difference in survival is only a couple of months, but we all recognize the impact of that. Next bullet point. So the flip side is that there's also been estimated that there's nearly 700,000 people living with the diagnosis of a primary CNS tumor. And what is life like for them as well? So what is life like for that short-term improvement in survival? And what is life like long-term? And what is the quality of that life? Next slide. So I think quality of life is something that's on all of our minds. We as healthcare professionals and researchers think about it when we develop new treatments and care for patients. And of course, you, when you're diagnosed, or your caregiver has that on their mind, particularly when there are changes in your life. But the issue with quality of life is it really may be something different for each person. What defines their quality of life may be impacted by what they do for a living or the people around them. And it also may change over the course of the illness. Next slide. So my perspective and those of several other people who focus on this in relation to treatment is that symptoms may be a more direct measure of the impact of the disease and the treatment, what we're doing to the tumor. Next slide. This is a figure developed by Wilson and Cleary that talks about quality of life that I think puts it into perspective. And you can see on the far right that overall quality of life is paramount, but it can be impacted by many things like the individual characteristics, the environment, even the perceptions that you have. Whereas as you see in the red box on the left, symptoms are really closely related to the biologic and physiologic variables, the tumor and its treatment. And that functional status in the middle may be impacted by those symptoms. So we focus a lot in evaluation of treatment on symptoms and function. Next slide. So I thought I'd talk a little bit about what we know about symptom impact in patients who have primary CNS tumors. Next bullet point. I mentioned earlier that the impact can be from the first time the tumor is diagnosed, from the first presentation. And studies show us that over 80% of those with malignant tumors like glioblastoma are unable to return to work because of symptoms or impact on function. And our work with rare tumors and low-grade tumors such as oligodendroglioma and ependymoma show that over 40% of people with those diagnoses also have an impact with the ability to work. Next bullet point. Qualitative studies, which are when a researcher sits down and talks to the person with a disease and understands what their experience has been, has shown us that people say they spend the majority of their time dealing with their illness and they aren't able to participate in some of their usual activities. Next bullet point. So that can not only impact the person, but have been shown to impact the caregiver as well, in terms of changes in their roles and the patient's stress, financial situations, and more recently, even the health of that caregiver. Next bullet point. So our work has shown that primary brain tumor patients and primary spine tumor patients have a lot of symptoms at one time. So people tend not to have only one symptom. And in fact, half the people in a study that we published reported 10 symptoms co-occurring at one time, 10. And 40% reported at least 3 of those symptoms, which they rated as moderate to severe. So what does that mean? That means if you give someone a scale of 0 to 10, and you ask them to rate a symptom like pain in terms of severity, with none being absent and 10 being the worst it can be, they rate it greater than 4. And that's really important because in cancer, that type of symptom report impacts that quality of life that we talked about, but can also impact survival, regardless of the disease state. Next slide. So because of this focus and the need to evaluate not only the impact on the tumor, but on the person when we evaluate treatment, I was asked to lead a workshop in 2014, at the end of 2014, co-sponsored by the FDA and the Jump Starting Brain Tumor Drug Development, JSBTDD, coalition, which included the American Brain Tumor Association. This brought a whole group of people together to talk about what should these outcomes be in clinical trials and evaluation of treatment. Next, I don't know what to call that, next bounce. So we realized before we started this that we really needed to follow Dr. Osler's recommendation, and we needed to listen to patients. So next slide. Part of this workshop, we included conducting a survey. Jen Helfer, who was at the MBTS, led this work, and we asked patients and caregivers what their experience was in some specific questions. So this table outlines the question that we asked them: of the symptoms you ranked as very important, which would you consider to be the most important? And 30% said retain brain function, which was really a global question about anything that may be impacting their ability to care for themselves or think or walk. Next was walking and basic physical tasks, and then memory and ability to concentrate. But you can see that there were a whole host of symptoms that people rated as the most important to them, indicating there's not one cardinal symptom for these patients, but there are several that may be important. Next bullet point. So in this table, we then asked, in addition to allowing a person to live longer, what would you most like to see future brain tumor treatments do? And in this question, they had to rate the question on 1 being 0 being not important at all, to 5 being the most important. And you can see here that a rating of important 4 or higher was given to some of those same symptoms that we saw before: ability to walk, memory, brain function, disease-related personality changes, mood, seizures, headaches, and weakness. So all these are important to people, and we recognized that we needed to consider all of them. Next slide. So as a result of this workshop, we made some recommendations. The one was that any trial going forward should accurately track what the dose of corticosteroids and anticonvulsant medications are, because people say those can really impact them. Next, we said that these symptoms were important, and the list of symptoms you can see here, we felt were all a priority for trials going forward, and using patient-reported outcomes, the patient's voice, to tell you what those symptoms are would be important. For functional outcomes, we also said that the patient's report of what their function is in terms of ability to work and walking and general activity would be important, but you could also use clinician-reported function like the Karnofsky performance status, testing like cognitive function, or even the use of smart wearable devices. Next slide. So a small group continued this work going forward to put discrete guidelines in place for clinical trials going forward. And this was a joint effort between the National Cancer Institute, RANO, which is the Response Assessment and Neuro-Oncology group, a group of academics who put guidelines forward about the care and treatment of brain tumor patients, the FDA, the EMA, which is like the FDA, but in Europe, and advocacy organizations. And the result of this work was published earlier this year in Lancet Oncology. And we identified these baseline symptoms and functions that should be included in any trial. This doesn't mean that a trial can't collect more, but they at least need to collect these. This includes difficulty communicating, pain, perceived cognition, seizures, treatment-associated symptoms. So that's dependent on what the treatment is that's being evaluated. And I could say that the FDA has taken this a step further, and they have launched a campaign in which patient-reported data is available through their website, so you can see what patients said about various treatments that are undergoing review by the FDA, which is critically important. Functions including physical functioning and role functioning. Next slide. So once we had that list of core symptoms, our group at the NCI decided to go forward and evaluate what is the relationship of just these symptoms to disease progression, because that hadn't been done before. Next slide. So we have a study, which I'll talk about in a minute, in the Neuro-Oncology branch, in which over 400 people had participated at the time of this analysis. And we collect patient-reported symptom data at each visit. And so we compared people who had progression on their MRI or to those who didn't have progression on an MRI. And importantly, people fill out this questionnaire a week before their MRI, they have their MRI, and then they meet with a clinician. So it's before they knew the results. And we found that each of these symptoms was much more severe in those found to have progression on their MRIs than who didn't. So this seemed to validate that these symptoms were quite important. Next slide. We then took this same group of folks who had progression and compared what they reported at their last visit to what they reported now. And the graph on the right is what's called a waterfall plot. The line in the middle indicates no change. Those things to the left are worsening, and to the right is improvement. And you can see a large portion had significant worsening of these symptoms, a 3-point change on that 0 to 10 scale, which is pretty significant. You can also see that there was a subset who had stable disease, and very few had any improvement in these symptoms. And that change or improvement was less than 1 point, the level that's considered the minimally important difference. So overall, patients with these symptoms had them either be stable or worsen at the time of progression, again, supporting that these symptoms may be important. Next slide. So I thought I'd show you a few examples of how patient-reported outcomes help us understand the impact on the person in addition to the tumor in clinical trials. And the first example that I'll share with you is 2 studies actually that were completed in newly diagnosed glioblastoma patients. And these were phase 3 studies. Phase 3 studies are those that compare an experimental treatment to a standard of care treatment. Next slide. These 2 studies, RTOG 0525 and 0825, were both led by our meeting chair, Dr. Gilbert. And the first, 0525, evaluated dose-dense temozolomide to standard, and 0825 compared the use of bevacizumab to just temozolomide, both in newly diagnosed glioblastoma patients. Unfortunately, both of these studies did not show a survival advantage with the experimental arm. Next slide. The patient-reported data, though, was really helpful in this study, and the table on the left looks at what factors at baseline when the people entered the study were prognostic for overall survival. You can click twice. For me, it'll highlight 2 red boxes in that table. Thank you. So we can see in this table that the baseline neurologic symptoms that the person had, an early change in cognitive perceived cognition, which was baseline to the end of radiation, were prognostic for overall survival. And this table is an example of a multivariate analysis. That's when you put a lot of factors together and you look to see which ones stay significant when you take into account them as a group instead of looking individually. And importantly, these symptoms stayed in this model even with methylation status and RPA, which is a standard classification of patients used in clinical trials, indicating the importance of symptoms at baseline in predicting how long someone lives, and really got us thinking about the importance of symptom management at baseline and throughout to hopefully improve survival, and more about that later. On the right, you can see a table that outlines the impact in one of the studies, 0825, over time. And this is specifically the interference, those functional impacts of the treatment. And unfortunately, the red line is the patients treated with bevacizumab, and the blue line is those treated without. And you can see that the folks who received bevacizumab actually were doing much worse as the treatment went on when they were on treatment. So unfortunately, no survival advantage, and we were hoping there would be clinical benefit, but there wasn't any. So we couldn't do anything to support the use of this treatment, at least up front. Good data for the use at recurrence. Next slide. So the second example I thought I would give you is for those with ependymoma, and this is a phase 2 study. In this study, everybody gets the experimental treatment. Next slide. So this treatment compared, was using temozolomide and lapatinib in recurrent ependymoma. And if you can click once, it'll highlight that there's no proven treatment for recurrent tumors. So we couldn't have a comparison arm in this study because we didn't have any treatment that was found to be effective in that setting. If you can click the button again, you'll see the response rate in this study. And there were some people who had response, which means shrinkage of tumor, either a complete response, which it means it disappeared, or partial response. But 33 of the patients had stable disease on that study. So really important to know what that was like when they had stable disease. The two MRI images in the middle, the top is a brain MRI scan with a sagittal cut, kind of through the middle of the brain. The blue arrow, we added, which indicate the area where the tumor is. And you can see the tumor on the left compared to post-treatment, where the tumor was essentially gone in that patient. Really dramatic and exciting. The image on the bottom is a spine scan in that same view, sagittal view, and the tumor is the large white dot kind of in the middle of the screen. And unfortunately, that didn't change over the course of the treatment, but interestingly, the person behind this MRI was on narcotic pain medications and in a wheelchair and came off medications and was walking at the end of the trial. So even though the disease was stable, we saw clinical improvement. Next slide. So because we use a standardized approach to assess symptoms in all patients, we can take a look to see what the impact was in everybody. And if you can click one more time, you can see in the spine symptoms graph to your left of the black box, the red line indicates no change, and then the percent change in symptoms is indicated in the gray boxes. We can see a striking decrease in moderate to severe disease and autonomic symptoms across patients on this study, which was really exciting. You can click one more time. It'll highlight that the box on the figure on the bottom right is that functional evaluation, activity-related interference. And we saw a striking decrease in significant activity-related interference. So patients not only felt better, even though their disease primarily was stable. Next slide. We also looked at physician rating of functional status, and we saw with spine tumor patients, 50% had improvement in their functional status rated by the clinician, and no one worsened. And on the bottom, the brain tumor group, 43% had improvement in KPS or was stable. So patients, even the clinician rated functional status was also improved in people on this treatment. Next slide. So this was really important because stable disease sometimes is not considered a response in cancer treatment. So by showing that we had clinical improvement, the NCCN guidelines, which are published, which indicate the standard approaches to treatment of cancers, brain tumors, but also other cancers, thought that this treatment was worth including for recurrent ependymoma. Next slide. And if you can click one more time, you can see lapatinib and temozolomide listed now in these NCCN guidelines, which is significant because any clinician caring for these patients now has this as a guide to use this treatment. And also insurance companies look at this too, and now it's considered recommended, and that helps with getting it paid for. So really excited that symptoms helped make this treatment available to patients. Next slide. The third example is use in brain metastasis patients, and this was an NRG study that was a phase 3 study, again, comparing to a standard radiation with hippocampal avoidance radiation and memantine. So they avoid a certain portion of the brain. The primary outcome was neurocognitive function, and they showed that there was delayed time to neurocognitive decline in people who got hippocampal avoidance. Next slide. We included patient-reported data on this study as well, and we found that patients also reported that they perceived their cognitive function, particularly their memory, was stable or even better during the 6 months after this treatment. And that was really important because it wasn't just a change on an objective test, but the patient's perception was they were better as well. Next slide. Because of those findings, this treatment is also included in the NCCN guidelines and available to any patient with brain metastasis. So I hope those examples showed you how outcomes assessment can help evaluate treatment. Next slide. But one of the issues with use in clinical trials is it's really just a snapshot of time in the total disease course you may be experiencing. The trial therapy may impact the outcome and not become standard of care, like the example in the dose-dense temozolomide or the bevacizumab trial. So then it's not helpful for us to care for patients going forward. The best of the best take part in clinical trials. People who may have worse function or other issues may not participate. And it's really hard to continue to get data after someone's progressed on a clinical trial, so we don't really know what happens long-term. So next slide. So Ethan Bash is a physician who works in general cancer care, and he thought around the same time that we started thinking about this, that symptom monitoring may be important for general care as well. And the standard approach to cancer clinical care is that you go to your doctor, you may have limited time, you may forget to discuss a particular symptom, and then nothing's done. Or if you're at home, you may be reluctant to contact, or even if you want to, sometimes it's hard to know how to get a hold of and who to call when you need to. Next slide. So his approach was to use these patient-reported outcomes sent electronically to patients to allow them to complete it either at home or when they came to the office visit to impact care, and then have a proactive approach. So the physician or nurse practitioner or nurse receives those symptoms and then can talk to you about them, and it starts that communication. Next slide. So he actually did a study of this in which he took patients with advanced cancers, not brain tumors, and compared those who reported their symptoms and those who did not. And importantly, that quality of life was better in patients who reported their symptoms, but patients also lived longer. They were less likely to go to the ER. They were more likely to stay on their treatment. They were less likely to be hospitalized. So merely by reporting their symptoms, they show a dramatic impact on the patient's outcome. Next slide. One of the things they did in this study is they took a group that they considered computer inexperienced, and they defined that as people who were elderly, maybe not have access, frail, and they did their assessments only at the time of their clinic visits. And the impact was actually a little bit greater in that group. So some of the thoughts, that can we do this in the brain tumor community? I think this highlights we can and we should. Next slide. So our group at the NOB is really focused on bringing this type of assessments and improving care across the trajectory in addition to what we do in clinical trials. Next slide. We have a natural history study, which was the source of the data I showed earlier, which allows us to follow people throughout the trajectory of their illness, and people can come to the Neuro-Oncology branch at no cost to them for a consultation and enroll in this study, and we monitor you at least once a year during that time. We have over 800 people who have participated, and we're learning a lot from that data beyond what we can learn in a clinical trial. If you look at the figure on the right, it shows kind of the trajectory of what a disease can be. And when we do evaluation just in trials, it may just be between that acute and that first recurrence hump, or it may just be between those two recurrence humps. So you can see how it doesn't give us a good view of really what's happening to the person overall. Next slide. So I mentioned what we do at the NOB, and I thought I'd share what one of these visits looked like for people in the natural history study. The pictures on the left are what our workroom looks like pre-COVID, not now. But hopefully soon we'll be back to this. And we all sit around and talk about each person's case. We look at their MRI, as shown in the picture on the bottom left, but we also look at the trajectory of their symptoms, as shown on the bottom right. And I blew up these symptom graphs to show you, we look at the symptoms over the last 3 visits, and we can see the trajectory of symptoms over time. We can see how you're reporting your symptoms and if things are getting better, or unfortunately, like on the bottom, if they're getting worse. And this really helps us start that conversation, try to manage those symptoms so we can see improvement like we did with the person's graph at the top. You can click again. And this is similar to what Ethan Bash did in his study where he showed survival advantage with his symptom report. Next slide. So we're taking what we developed in the brain tumor patient population, and Dr. Leeper, a staff clinician in our group, is leading a development of a multi-center study which will bring this symptom reporting out to the brain tumor community to assess if we can have an impact in survival, first working with patients with newly diagnosed glioblastoma, but very quickly moving on to other types of tumors like we're doing within our own institution. Next slide. I mentioned earlier that smart wearables can also be a way to assess these, and we're trying to move that forward in neuro-oncology as well. And Dr. Shabani Mulligan is a circadian biologist who has developed a study using Fitbit in brain tumor patients. If you can click again, we're really focused on evaluating sleep and activity using smart wearables. And our hope is then we can use this information to prescribe or do a study where we look at health and wellness factors in our patient population, because we truly believe if we address these, we can have an impact and outcome for patients. Next slide. The other area where we're focused on and what we've learned from our natural history study data is symptoms of depression and anxiety. And this impacts those survivors that I talked about with the first slide. Next slide. So this is data from our natural history study from patients reporting depressive and anxiety symptoms using PROMIS scales, which are national scales available for any disease state. And we found that in the entire sample, about 44 to 46% had depressive or anxiety symptoms at the time we saw them. And on our long-term survivor cohort, and those that have been alive greater than 5 years, we found that incidence was equally high, which was concerning. If you can click for me. We looked to see how many people had both depression and anxiety, and almost 20% of our patients had moderate to severe depressive and anxiety symptoms. So it led us to believe, is there a group that's at risk that we can try to intervene in? You can click twice for me here. Unfortunately, what we found is that we couldn't really predict it based on any of the disease factors, nothing related to the tumor. We found with depressive symptoms, our white patients were more likely to report those than other races. And those with anxiety and depression who were already on medication, who had a history of anxiety or depression, continued to have that during their disease course. In addition, depressive symptoms were more common in those who had worse performance status, who had difficulty walking or caring for themselves. So this has led us to think that there may be an underlying genomic reason why some folks are more at risk, and we're exploring that within our study. But we thought maybe we can do things to address this overall since it's so pervasive and common in our patients. So next slide. So there's a couple of things that we're working on. On the far right, you see Alvina Acquay. She's a licensed counseling psychologist, and she's bringing the CALM program, which was developed by Gary Roden at Princess Margaret, and is designed as a cognitive behavioral therapy, talking therapy with patients. And we're going to do it with patients and their caregivers remotely through telehealth to see if we can improve quality of life and depressive symptoms in brain tumor patients. Dr. King in the middle has brought virtual reality to us, and we're looking at this with use with that scanxiety, that anxiety you feel before your MRI. With use of these headsets, we believe that you can use it to learn how to calm yourself and hopefully get through that MRI easier, and also be able to come to the appointment at a different level of anxiety than maybe before and get more out of the visit. So really excited about this study as well. And then finally, Dr. Selinexor, who's a staff scientist in our group, is working with me to develop an app to empower patients to be able to manage their own symptoms at home. So next slide. This app is called My Story, and we hope to have it available in the App Store in the beginning of 2021. This will allow patients to monitor their symptoms just like we would do in a clinical setting. You can rate them, you can access information related to self-care. So what can you do on your own to help make the symptoms better? You can log what you do related to your symptoms and if they improve. And then we have a calendar function where you can list your symptoms in relation to the treatment that you're on. And then finally, it'll allow you to connect to your medical record, to your physician, to anyone in your contact list if you want to share your information to have the dialogue. And we hope this will help people care for themselves and also help foster the communication that will lead to improved symptom management. So next slide. So in summary, I hope I've shown you that by accurately assessing symptoms, we can evaluate the clinical benefit of treatment. By exploring who's at risk, we can alter our approach and hopefully prevent the occurrence of some of these symptoms or manage them early. And by exploring biologic processes, maybe we can target the process and not just treat the symptom once it occurred. So next slide. I'd just like to end by thanking my mentors, particularly Dr. Gilbert, who's been my mentor for the last 30 years, my co-investigators, my NOB research team, and especially the 6,000 plus patients and caregivers who have shared their journey with us and helped us to develop what we have. So thanks again for the opportunity.
Thank you so much, Dr. Armstrong. So we do have time for questions. Just as a reminder, if you do have any questions, please type and submit it using the Q&A box at the bottom of your control panel, and we'll answer questions as time allows. So one of the first questions we have here is going back to the study you had mentioned about depression and anxiety and survivorship. And you had discussed patients who are self-reporting these symptoms. Do you or have you factored in the stigma associated with issues, mental health issues such as depression and anxiety? Do you consider that that number may be smaller because people are not reporting it? As well as culturally, in some cultures, people don't really talk about their mental health. How are you incorporating that or ensuring that we're kind of combating that stigma and ensuring that we're helping the patients who might not be talking about it as much, but still need that support as well?
Yeah, wow, that's an excellent question. And I'm not sure that we're doing everything we could, but we really tried to address those topics. One interesting thing that we've found is we send this questionnaire prior to the clinic visit in the week prior. And our experience with using these questionnaires is that sometimes people are more likely to report when they're not face-to-face, when they're answering the questionnaire. We've found that with mood symptoms as well as sexual dysfunction questions that are part of our questionnaire as well. So that's one point. The second is when they report the symptoms, we share the reporting and talk through it with them, because it has been shown culturally, as this person obviously knows too, that there are some cultures that may not be as likely to report the issues that they're having. So the report isn't the end all and be all. It's a conversation starter that allows us to then have that dialogue with the person face to face in a supportive environment. Lastly, when we talk about these, we really talk about how this is not a weakness on the person's part. This is really part of the disease process. So just as if you had nausea, we would give you medication for that. If you're having symptoms of anxiety or depression, there are things we can do to help it. So we try to make it seem part of the usual program, and I think that helps. Lastly, we've tried to do qualitative components to some of our studies to explore those issues. So we recently completed a study looking at the impact of body image, and we have one-on-one sessions where we allow people to kind of talk through these so we can better understand those limitations. So I hope that helps.
Thank you so much for providing that insight and advice. Another question we have is from a patient who's wondering, what are ways that patients themselves can report patient symptoms to groups such as the NIH or NCI?
Oh, that's a great question. Thank you for asking that. So we have a couple of different ways that you can participate with us in what we're doing. The one is we have a web-based program that's particular for people with rare tumor diagnosis, so things like ependymoma, medulloblastoma, oligodendroglioma. And that web-based process allows you to interact totally virtually without coming to the NIH and sharing your data. And we have almost 500 people who participated in that study over the course of several years, and we learned so much from that. Another option is that natural history study that I talked about. And the perspective of the Neuro-Oncology branch under Dr. Gilbert's leadership is that anybody in the US who wants to come for a second opinion, we welcome them to do that. And by coming, we offer you participation in the natural history study. That one visit, right now we're doing that remotely with COVID or delaying that first visit, but enrolling people. We can then follow remotely from that point forward. So you can continue to come, or you can just stay at home, and we reach out to you at least once a year to say, hey, can you give us an update, report your symptoms? And we're learning so much from that. So if you can participate, I'd really appreciate it. And other centers are doing similar things. So talk to your healthcare provider about what you can do at your own centers to help support that. And think about the work that the FDA is doing as well, because they're collecting those patient voices too.
Great. Thank you so much for that advice, Dr. Armstrong. Are you aware of any reporting tools that caregivers can use in order to report the symptoms that their patient or loved one is going through?
That's a really great question. So one of the tools, in full disclosure, that I helped develop is the Medulloblastoma. And we actually did a study in which we had the caregiver report the symptoms that the patient's having and the patient. And we found if we asked the caregiver to report, how do you think the patient would report this? They were very congruent. So we've shown that the Medulloblastoma is a valid instrument to use by the caregiver. So that's one tool that you can use. I know there are other apps that are out there. I would encourage you to explore those. And our app that we'll have out there soon will allow you to do that using your phone. You could track it, you could share it with your family, you can share it with your healthcare provider. So we hope that'll be something that people will be useful, and it's doesn't tie you to any study. It's your data. It's stored on your phone. So it's really a tool that we hope you can use.
Wonderful. Thank you. And from a patient or a caregiver's perspective, how do you recommend that he or she uses the information from these patient outcome assessments?
That's great. That's a really great question. So I think a couple of things. One is, I think using as a way to communicate and monitor how you're doing. Sometimes it's helpful to kind of track how you're doing and see what the changes are. It's not uncommon for you to have fluctuations in how you feel over time. So by using these routinely, you can really get a sense of where you are and if things are fluctuating, which is normal, or things are getting worse or getting better. So it really provides that tool, tracking tool for you to use. And the second thing is, I think it's really a communication aid more than anything else with your healthcare provider. We use terms like their pain is a 5 on a scale of 10. So by using these tools, it allows you to use that language and talk in a way that's standardized, and then you can assess response.
Thank you. And can you share information on how a patient might enroll in the natural history study if they're interested?
Yeah, absolutely. You can go to the Neuro-Oncology branch website. And there's information right on there if you're interested in enrolling. Right now during COVID, we're really trying to enroll people working with the local healthcare provider, primarily because we want to be sure it's something, that based on your location or your health, that it's a good thing for you right now. But prior to that, you can refer on your own through that website. So if you're interested, reach out to us. We can talk you through that process. And definitely once things are a little more stable, please enroll, because we really learned so much from you.
Thank you so much. You had mentioned the Fitbit clinical trial. Is that something that's open for enrollment as well? And can you share where patients and families can find more information on that clinical trial?
It's not open yet. So our hope is that we're going to start enrolling patients at the end of the year, and it'll be registered as all clinical trials at clinicaltrials.gov and also on our website. We're finalizing the information on that. We had completed another study using Fitbit in which we worked with caregivers and patients, and we learned so much from that data on the importance of walking. So we're really interested in exploring that, and also how sleep really impacts how you feel. So stay tuned, very soon.
Great, really exciting. You had talked about the My Story app that's hopefully coming and will be available in the future. Is there any similar apps that are already available or similar tools that patients and families can use today to track their symptoms?
Yeah, there's one other app that's available that's out there, and I apologize that I don't have it available, but I can share it with the ABTA to share it with you, or people on the call might be involved with it as well. That is available specific for brain tumors. I think there is no app like ours for brain tumors that incorporates both symptom reporting and monitoring and tracking what you're doing about it. So those health and wellness factors. So I think that's pretty unique, and we're pretty excited about offering it. I think it only exists for one other disease state, not brain tumors, on a very small scale. So we're excited about it.
Great, and I think we have time for just one more question. You had discussed how there have been studies on depression and anxiety in long-term survivorship. Many long-term survivors may also experience late effects from their treatments and their diagnosis. Are there studies on these late effects? What can patients do now to help prevent or maybe prepare for such late effects down the road?
Yeah, that's a really good point. And there are some published studies looking at that. They're relatively small, but we know that the impact of radiation or other treatments can go on. We recently looked at our study, our natural history study, and have a paper that we're just submitting for publication. But I can share with you, we found that it's about half the people have significant issues and about half don't. So there's a real dichotomy there. And, you know, we're not really good at knowing exactly what predicts that. Some of the things that we thought didn't really pan out in our study. So I think we need more studies exploring people from the beginning of the diagnosis through that long-term survivorship to really understand. And I truly think that thinking about kind of the long-term effects from the time of diagnosis will be pivotal. We have to think about the impact of everything we're doing from the beginning through the survivorship period. So look out for that paper. Hopefully it'll be published soon.
Great. Thank you so much for your time, Dr. Armstrong, and all of you for your wonderful questions. That's all the time that we have for questions for this session. I'm going to go ahead and turn it back to Emily and we'll move forward.
Thank you so much, Dr. Armstrong. What an incredible session hearing about patient outcomes. We thank you for your time. We will now proceed with our lunch session. We encourage you to listen in while enjoying your lunch for this unique opportunity to meet the ABTA Board of Directors. In this session, you will hear why they are involved with ABTA and passionate about the mission. Following this meet and greet session, you will have the chance to hear from our researchers, Drs. Hannah Sabelstrom from University of California, San Francisco, Min Tang Schomer from the Jackson Laboratory for Genomic Medicine, and Fan Zhang from Fred Hutchinson Cancer Research Center. You will also have the opportunity to hear from our sponsors who have helped support this event. Chiropharm Therapeutics, NorthShore University Health System, Northwest Biotherapeutics, Electa, and Novacure. Each sponsor will share what resources they offer to patients. For those of you who need a break, please feel free to do so now, but we would love for you to join us for this lunch session. We will resume the afternoon program at 1:10 p.m. Central Time. Thank you so much.
Good morning. I'm Jim Riley, Chair of the American Brain Tumor Association Board of Directors. Thank you for joining us for a session designed to give you the opportunity to meet the ABTA Board, which is a group of volunteers who are responsible for governing and working with our President and CEO, Ralph DeVito, to provide strategic direction to the ABTA. Ralph provides the day-to-day leadership and responsibility for achieving the board-approved outcomes. Thank you for viewing part or all of our virtual national conference. In my day job, I'm the Vice President for Human Resources and Communications for Winco Foods. We're based in Boise, Idaho, where I live with my wife, Aggie. My personal connection to brain tumors is both my mother-in-law and my mother both had brain tumors. My mother-in-law unfortunately passed away from a glioblastoma back in 2005. and my mother was a survivor of a meningioma tumor back in 2000. I would like to ask 6 of the 8 board members who are joining us here today to introduce themselves and why it is that they are involved with the ABTA. Unfortunately, 2 of our other members had conflicts today. Let's start with Brandon Starkoff, Vice Chair of the Board of Directors. Brandon?
Excellent. It's great to meet all of you. Thank you for joining us. As Jim pointed out, I'm Brandon Starkoff, Vice Chair of the ABTA Board, and my day job is the CEO of a marketing technology consultancy. I'm based out here actually in Columbus, Ohio, formerly from Chicago. And I have my wife and 2 10-year-old twins that are keeping us very busy. My connection to brain tumors is actually myself. I'm a 9-year survivor of brain tumor of a grade 3 astrocytoma, and also actually recently have small reoccurrence. I'm going through treatment at this time, and I'm actually feeling pretty good going through it. And I am about 6 months into a 2-year trial, which has been really helpful for me. My involvement with the ABTA actually started with my own personal events. I started a charity called Cater to the Cure, which was inspired not only by my own situation, but some very close friends around me were also diagnosed with brain cancer. And so I decided to launch my own called Cater to the Cure. We are in our 6th year. Unfortunately, this year's event, which is typically an on-site cooking event, where we also have silent auction, has been postponed due to the current pandemic, but we plan to work around that in the very near future. And I want to certainly offer up the opportunity with all the tools that the ABTA now has for all those looking to raise funds. We've raised over $250,000 over the last 6 years through these events and tied them closely to the BT5K. So a lot of opportunity out there, and it's just a matter of having the tools and capabilities. So again, want to thank all of you for joining us today. And I would like to hand it off to Carla Varner, who's our secretary.
Thank you, Brandon. Hi, everyone. I'm Carla Varner, and I live in Chicago with my husband, Seb, and our 2 children, Natalie, who's 7.5, and baby Jack, who's 2, as well as our dog, Max. Professionally, I'm the Chief Legal Officer of a financial services company here in Chicago, and have been working there for about 10 years. As for the ABTA and my involvement with this great organization, it really stems from a desire to give back and to make a difference. I haven't personally been affected by a brain tumor, thankfully. But at the end of 2013, I made a New Year's resolution and decided that I was going to give back and look for volunteer opportunities, which I did. And through that research, I became familiar with the ABTA. And it just so turned out at the same time, 2 of my very close friends, my good friend Greg from college, had lost his father to a GBM, and my childhood friend Julie had lost her father-in-law to a GBM. So, getting familiar with the ABTA and the staff, the mission, which is such an impressive and meaningful mission, all of that kind of came together and caused me to accept the volunteer opportunity. And of course, since becoming involved, I've met numerous people through my personal life, not even through my volunteer work with the ABTA, who have been affected by brain tumors. And I'm just deeply honored to be part of this organization and to fight the fight, advance research against brain tumors, and helping to support caregivers and patients. So thank you all for coming here today, or dialing in anyway to our conference, and for your support of this organization. So with that, I would turn it over to Susanna Davis, who's one of my fellow directors. Thank you.
Thanks, Carla. Hi, everyone. I am Susanna Davis. I live in Austin, Texas. As for family members, it's just me, though I do have 5 siblings that are all married and 10 nieces and nephews kind of scattered across Texas. I was actually diagnosed with a brain tumor in 2007, and it was a bit of a wake-up call for my entire family because we were very fortunate that all 6 children of us were born and literally went home the next day and never had a single health issue, it seemed, until I was 23. And it was located in my hippocampus. It was ganglioglioma grade 1, and I was very fortunate to get admitted into MD Anderson down in Houston. Dr. Sajut Prabhu was my neurosurgeon. An amazing team, did an amazing job, and just really woke me up to how short life can be. And I guess it was a motivation for me after that all took place and had such an amazing outcome with it that I was so fortunate. I got very involved in other organizations here in Austin with other types of cancers and whatnot, and was introduced to the American Brain Tumor Association by Dr. Prabhu one year when I went down for a follow-up. He just felt like my story was a great story. A lot of people feel like when you're diagnosed with a tumor, it's the end all, there's no turning back, but your mental and emotional health has such a profound effect on it. And so he had asked me to be a part of some of the programs that they were doing down at MD Anderson, and that introduced me to the ABTA. And I was fortunate to get in touch with the ABTA and start following them via LinkedIn. And one thing led to another, and I was asked to join the board. I'm now on my 7th year being a part of it. And I guess, it's been so rewarding for me because it's something that I went through myself, and I can relate to the people that come to us for support and help and answers. And so when you've dealt with it personally, it really is all the more rewarding to try and help somebody else, because I feel like nothing in life is sometimes an accident. I feel like it happens for a reason. And I felt like it gave me the opportunity to take what I was dealt and turn it around into something better. Really enjoyed the organization, loved the board that I serve with and the employees with the organization, and just what we're doing, trying to move forward with getting awareness of who we are and supporting the research and everything. But just a wonderful organization, and appreciate all of you who have tuned in today and do support the organization, and even those of you who turn to us and see us as that resource to go to, because that's what our goal is to become that first place you can turn to whenever you do get that unfortunate diagnosis. But then even, still being a part of our organization beyond your treatment, your everything that you go through, because it's paying it forward, in my opinion, sometimes when we face challenges in life like this. But thank you all for joining, and those of you who are battling it, you're in my thoughts and prayers, and hope very much that you're finding value in our organization at the American Brain Tumor Association. And with that, I will pass it on to Bob Cruchin.
Thanks, Susanna. This is Bob Cruchin. Hello, everybody. I'm a volunteer board member from the Chicago area, and I'm currently the chair of our ABTA Development Committee. In that role, I work with my board teammates, our Chief Development Officer, Kelly Sitkin, as well as our terrific staff to help find creative ways, and our creativity has certainly been challenged during the pandemic, but we're trying to drive together vital brain tumor research and patient support services funding. We also work together to ensure that all of our collective efforts fit exactly well with the mission of the ABTA. Additionally, I work on the ABTA Finance and Audit Committee, but in my day job, I'm a 30-year veteran of the marketing and media industry, the last 19 years of which I have been with a leading advertising services organization by the name of Extreme Reach. I have 3 college-age children, actually one just recently graduated, and my wife Lori and I have been involved with the ABTA since I originally got involved as a volunteer in 1998. In 98, that was when my best friend Paul Fabry passed away after a 10-year courageous battle over 10 years, passing away from a glioblastoma at the age of 31. my extended family, my friends, very, very deeply impacted by Paul's incredible battle. Truly a life-changing experience for all of us, and I'm sure everybody tuned in right now can relate to that. Paul's and my mutual friend Jeff Fougeroux suggested that we, because Paul was an all-conference basketball player, that we start an annual golf outing and raffle dinner in tribute to Paul and to help drive funding for the ABTA's mission. I'm happy to report that, actually thrilled to say that due to the incredible generosity of many of Paul's friends and extended family, and now that it's been 22 years since his passing, many people are involved with our event that never unfortunately had the opportunity to meet Paul. But over those years, we've been able to contribute over $650,000 directly towards ABTA brain tumor research grants in Paul's name. And we're excited. Hopefully actually we're able to pull off our 23rd annual event in August in person in a golf event, the first large-scale event that the golf course that we're partnered with was able to host this year. But we're set for our 24th annual. We call it the Pauley ABTA Golf Classic, and that's next June 5th. You can see the details, and if any of you out there have an inkling to start a golf outing, please feel free to reach out to me via the ABTA website, and the details are at paulfabry.com. That's FABBRI.com. One important side note, our collective passion for the mission of the ABTA ultimately led my friend Jeff to lead the ABTA board for several years, ultimately becoming the board chairman. And when his term ended, he recommended me 3 years ago to join the board. It's my great honor to serve on this team and in support of brain tumor families, patients, and survivors everywhere. As Susanna said, my thoughts and prayers are with all of you as you go through this battle. I'm sure that you've picked up some fantastic insights and opportunities through this virtual conference. And with that, I'll pass the baton to my board partner, Jackie.
Am I on?
You are on. Good to go.
Okay. Sorry. Thanks, Bob. Good afternoon to everybody. Professionally, I'm the Chief Financial Officer at XG Sciences in Lansing, Michigan. Personally, I live in Indiana with my husband of 26 years, Brian, and our 4 children. I got involved with the ABTA. On our 10th anniversary, Brian was diagnosed with choroid plexus carcinoma after a total resection of a golf ball-sized tumor, which, you know, one day we knew about, the day before we didn't know about. And I remember during this hectic time with 4 kids between the ages of 1 and 7 and no idea what the future held, receiving a book at the neurosurgeon's office by the ABTA. And it made me feel better that an organization was spending their time and effort specifically on brain tumors, on caregivers, and on you know, the people who are going through it. There was nothing specific on choroid plexus carcinoma, so I kind of put it to the side. But after, you know, Brian has been a survivor now for 16 years. I have joined the board about 3.5 years ago, and I serve on the audit committee as well as the governance and nominating committee. And I just want to say it's an awesome cause and an awesome group of people, and we're getting somewhere. We're doing what needs to be done to help patients and caregivers and researchers get further in their knowledge of how the brain works and how we can take care of tumors and hopefully get rid of them someday. So I know that was quick, but I want to pass this on to Mindy. And I just want to say thank you to everybody for participating. Mindy?
Thank you, Jackie. Hi, I'm Mindy Plugas. I live in Los Angeles, California with my husband, Matt, and my 2-year-old daughter, Isana. Professionally, I lead global marketing and brand strategy at Edwards Life Sciences. And I've been involved with the ABTA for quite a while in different capacities. My father was diagnosed with a glioblastoma in 2000, and it was, as it is for most people, most patients and caregivers, a complete shock. And he went through 2 brain surgeries, chemotherapy, radiation, and he passed away 11 months after his diagnosis. And it was during that time that we relied on the ABTA for a lot of resources and support. And then after that, we continued to stay involved in terms of donations. In 2013, I joined Team Breakthrough for the Chicago Marathon. And after doing that event and just seeing the passion of the people involved in the organization, I wanted to get even more involved. And I was at a place in my life where that made a lot of sense. And so I joined the board 3.5 years ago as well, at the same time as Jackie. And I am the chair of the mission committee. So I work very closely with Nicole Wilmarth, who is our chief mission officer, as well as her team, Heather Calderon, who's the director of research and grants. And I really, really relish the opportunity to be a part of this board and to be a part of this organization. This is a group of very smart, passionate people that are working extremely hard toward our mission to eradicate brain tumor and to someday be in a world where brain tumor doesn't exist. And so, you know, thank you so much for joining our national conference. You know, we have all of you in mind who are either going through brain tumor diagnosis and treatment, or are a caregiver, or you know somebody who is and you just want to be more supportive, or the researchers and the doctors and the teams that are involved to help, you know, toward our mission. Thank you so much. And with that, I'm going to turn it back over to Jim Riley, the chair of the board.
Thank you, Mindy. And thank you, ABTA Board of Directors, for sharing your story and why it is important you're involved with the ABTA. Most importantly, we thank you for your outstanding leadership and service to the mission of the ABTA. I want to thank each of you for joining us. ABTA welcomes those of you who want to become more involved with the ABTA and our mission to visit our website at www.abta.org. Our website, you can find ways to get involved through volunteering, fundraising events, join our peer mentorship program, which pairs brain tumor patients and caregivers with peer mentors who've been through a similar situation, or simply share your story to let others know they are not alone on the brain tumor journey. Much of the ways you can get more involved can be done virtually. When it is safe to do so, we will be holding in-person walks and runs for patient meetings. If you need further information, you can always call the ABTA Care Line at 1-800-886-ABTA. Our caring staff will provide information and assistance. Thank you and enjoy the rest of the conference.
Hello, my name is Dr. Jaden Shaw. I'm the Executive Vice President and Chief Medical Officer at Karyopharm Therapeutics. Karyopharm is proud to be a sponsor of the American Brain Tumor Association National Conference and proud to sponsor ongoing research in GBM. Karyopharm is a small pharmaceutical company based outside of Boston, Massachusetts, started in 2008 by our founder and Chief Scientific Officer, Sharon Shackham. We've been focused exclusively on developing selective inhibitors of nuclear export, and specifically a drug named Selinexor. This is an oral therapy that's given once or twice a week. We were recently granted approval for this drug for patients with 2 different types of blood cancers, including myeloma and diffuse large B-cell lymphoma in 2019 and 2020. As you can see in this slide here, there's lots of ongoing research that we have right now with Selinexor, both in various blood cancers, including myeloma and lymphoma, as well as various solid tumors, including in patients with sarcoma, endometrial cancer, other solid tumors, as well as GBM, which we'll be focused on today. How does Selinexor work? So Selinexor specifically and selectively inhibits XPO1. And XPO1 is a protein that shuttles tumor suppressor proteins from the nucleus to the cytoplasm. These tumor suppressor proteins should be inside of the nucleus where they'll normally be activated and where they function to suppress tumors. Now, cancer cells will overexpress XPO1, and they do this to bypass the mechanisms of tumor suppressor proteins. So when they overexpress XPO1, then these cancer cells will shuttle these tumor suppressor proteins into the cytoplasm where they're no longer active. So by inhibiting XPO1, which Selinexor does, it leads to the nuclear localization of these tumor suppressor proteins. So these proteins then live inside the nucleus where they can function and kill cancer cells. Importantly, Selinexor also combines very nicely with radiation therapy and temozolomide, which are two commonly used treatment modalities in patients with GBM. In our initial experience with Selinexor in GBM, in recurrent GBM, we learned two very important things from this KING study. Number one, we know that Selinexor crosses the blood-brain barrier and then gets into the space around the brain where it's important where it can actually work for patients with GBM. And we showed in patients with GBM, that Selinexor does have single-agent activity. We saw patients with both a partial remission as well as a complete remission for those patients with relapsed GBM. Based on that, we've launched this new study called Export-GBM.29. In this study, we're adding Selinexor into the current standard of care. So whatever you'd otherwise get as a standard of care, we're adding Selinexor on to see if it improves it. For example, in patients with newly diagnosed GBM, we'll add it either to radiation or a combination of radiation and temozolomide based on if your disease has MGMT methylation status. And importantly, for patients, unfortunately, with recurrent GBM, we're combining it with lomustine, which is another important standard of care, to see if we can improve outcomes with a combination therapy. This trial is currently open now and enrolling at these various centers that you see here, and more centers to come soon. Our contact information is here for any questions or information. Thank you so much for your attention.
I'd like to thank the American Brain Tumor Association for continuing to partner with NorthShore. NorthShore Neurological Institute is located in the northern suburbs, just outside of Chicago. We've been a long-time sponsor of ABTA's annual events and the national conference. I've had the opportunity to speak numerous times at the conference and via the ABTA's webinar educational programs. I am passionate about the work I do in neuro-oncology and have a strong connection to the field through family members who have been affected by brain tumors. I treat patients diagnosed with primary brain tumors, meningiomas, lymphoma, and brain metastases. My philosophy is to involve my patient and their family in making decisions about their treatment. Communication and education play key roles to ensure patients feel comfortable with the course of treatment. I work with a team, so having a multidisciplinary model is a critical part of the care I provide. NorthShore Neurological team includes neuro-oncologists, neurosurgeons, radiation oncologists, and many others. However, the patient remains at the center of our team. We also have a brain tumor support group that meets monthly. This group helps patients connect with others who are going through similar circumstances. At NorthShore, our treatment plan is customized to patients and may include surgery, radiation, chemotherapy, immunotherapy, and promising new treatments through clinical trials. We incorporate the most advanced technologies in treating brain tumors from the surgical side. This includes functional MRI and diffusion tensor imaging for surgical planning, Synaptive, an intraoperative surgical navigation tool, NICO BrainPath, an endoscopic port device, and most recently GammaTile therapy, a new approach to treating brain tumors. NorthShore is the first in Illinois to offer this new FDA-cleared therapy. The GammaTile is a small 3D collagen tile embedded with cesium-131 radiation that can be placed at the tumor site after the tumor is surgically removed. NorthShore has a long tradition of offering a portfolio of clinical trials for multiple types of brain tumors. We have participated in several national clinical trials over the years and belong to several consortia. We have also participated in pharmaceutical-sponsored trials and have offered patients single-agent investigational drugs in select cases. I urge patients and families seeking treatments to research the trials available at northshore.org/NNI trials. You can also find more information about our wide array of neuro programs on our website. I'd like to thank ABTA for providing families with the support needed on this journey.
Hi,
My name is Hanna Sabelström, and I'm here to present work from my postdoc research in Dr. Anders Persson's lab at UCSF in San Francisco. That's where I studied a novel pressure-reducing therapy to abrogate tumor invasiveness and immune infiltration in glioblastoma. And this was work done in support of the 2017 ABTA Basic Research Fellowship in memory of Joel A. Gingras Jr. Glioblastoma is the most common and aggressive primary brain tumor with a median survival of 12 to 15 months post-diagnosis. And the capacity of glioblastomas to aggressively invade and infiltrate normal surrounding brain tissue makes complete surgical resection nearly impossible. There's an immense interest to develop therapies that inhibit tumor growth without developing invasive and treatment-resistant recurring tumors. As brain tumors grow bigger inside of the confined space of the skull, the interstitial fluid pressure increases. And this makes it harder for drugs to reach the tumor cells. And that is why we have developed a novel approach to measure interstitial fluid pressure inside of human glioblastomas xenografted into animals. So by simultaneously implanting a pressure sensor and patient-derived glioblastoma cells expressing luciferase, we are able to continuously measure the interstitial fluid pressure here in red and tumor growth in blue during tumor progression in these mice. Now, anti-secretory factor, or AF, is an endogenous protein that has both anti-secretory and anti-inflammatory effects. It can be used as a dietary management of inflammatory bowel diseases, including Crohn's disease. And we found that induction of anti-secretory factor will reduce the interstitial fluid pressure in these patient-derived glioblastoma tumors. And we can do this both chronically over days and weeks by inducing anti-secretory factor through the diet with a specially produced cereal, or SPC, or we can lower the pressure very acutely over minutes by administering anti-secretory factor as a peptide through a nasal spray. We found that by reducing the interstitial fluid pressure in these tumors, this ultimately leads to a longer survival of the animals. And you can see that here if you compare the red lines with the blue non-treated animals. So here are two different patient-derived glioblastomas and one mouse allograft model of glioblastoma. We also found that anti-secretory factor blocked recurrence following chemotherapy with temozolomide in these human-derived or patient-derived glioblastoma xenografts. We also performed some mechanic studies followed by anti-secretory factor, and we found that it reduced the sodium-potassium chloride cotransporter 1, or NKCC1. And that's critical for the migration or movement of glioblastoma cells. So next we were able to show that when we induced anti-secretory factor, we're able to block tumor invasion. And we can also reduce immune cells inside the glioblastoma cells. And this is similar to when we treat the animals with either the NKCC1 inhibitor bumetanide or with the edema-reducing corticosteroid dexamethasone. Both of those two agents, though, have shown various side effects in patients in contrast to anti-secretory factors, which as of today has no known side effects reported. So in conclusion, we hope that anti-secretory factor could represent a novel pressure-reducing therapy to improve outcome in glioblastoma patients and high-grade glioma patients. This work was done together with many collaborators and with funding sources from around the world. Thank you so much.
Hello, my name is Mingtang Xiaomer. My study is entitled Ion Channels as Potential Drug Targets for Medulloblastoma. This study is supported by ABTA Discovery Grant by an anonymous family foundation. Medulloblastoma is a deadly brain cancer for children. It's subdivided into 4 types from its genomic profiles, as you see here, into Wnt signaling, sonic hedgehog, and groups 3 and 4. Group 3 and 4 has poor prognosis and few treatment options. When we examined their genomic profiles, we found that certain ion channels are overexpressed in group 3 and 4 MBs. Ion channels are those proteins that span the membranes, as you see here in this cartoon. They maintain the membrane potential by controlling the passage of charged ions. Upon activation, it leads to calcium influx. Calcium influx then trigger signal transduction pathways that affect gene transcription, cell proliferation, and mobility. However, the role of normal ion channel expression in brain tumor have not been well studied. We then started to examine ion channel expression in patient cells derived from the fresh tumor. We have found that patient MB cells maintained normal ion channel expression. As you see in this heat map, on the left side, this reddish color, this hyperexpression is different than the rest of the samples, which are other types of tumor cells. We also found that patient MB cells exhibited calcium signaling. In this picture, you see these MB cells staining green. Here on the right, you see the representative traces of calcium over a span of 1 minute. Such behavior is unexpected from non-neuronal cells in the brain, and we have not observed such behavior in other tumor cells as well. We then want to test the channel blockers with tumor effects. About 20% of FDA-approved drugs target the ion channels. As you see here, it's a representative list. These drugs target a major classes of ion channels. Out of these drugs, we test a total of 12, and including BAP is a calcium chelator, and digoxin, which is a sodium potassium pump inhibitor, also found to target MBs. We did the drug testing on the cell line DAOI. In DAOI cells, we found that out of those drugs, the 3 drugs showed activity to suppress the calcium signaling. As you see here, the representative calcium signaling, in the first minute without a drug, we see the calcium pulse, calcium wave in almost every single cell. Upon drug application, such a wave disappeared. We then test the drug to see if they can kill the DAOI cells after prolonged exposure. Here shows the dose response of these 3 drugs. And they also showed potent cytotoxicity effects at the dosage range that's similar to calcium, to those that suppress calcium signaling. In conclusion, we showed that calcium signaling is linked to abnormal medulloblastoma growth, and certain ion channels, such as MEB and digoxin, may present a potential new targeting therapy. In future, we want to confirm the drug effects in patient cells and in animal models to support future clinical trials. We also want to assess drug toxicity to determine the drugs that kill the tumor cells but spare the normal brain cells. Overall, our study have identified ion channels as potential new therapeutic targets for medulloblastoma. Thank you.
Hi everyone, my name is Sam. I'm currently a postdoctoral research associate at Fred Hutchinson Cancer Research Center in Seattle. And I have received the Basic Research Fellowship Award from American Brain Tumor Association in 2018 in honor of Susan Strel-Metzger, and to support my project, which is called Program Tumor-Clearing Macrophage with a targeted gene therapy. So basically in this project, we're trying to develop a novel gene therapy that could specifically target macrophage in our body to fight against the cancer. Macrophage, as you can see in this picture here, is a key immune cell that regulates our immunity, specifically to help our body to fight against infectious disease and also to help our body to repair from injuries. And in terms of the tumor, macrophage is actually hijacked by the tumor cells to help them to grow. And specifically, in brain tumor, it is estimated that macrophage could account for as much as 30% of the tumor mass, which means there are a lot of macrophage inside of the brain tumor. And based on this, target and reprogram macrophages could reduce the burden of the brain tumor in the patient. And in this project, we have developed a novel gene therapy by using engineered nanoparticles. So what exactly are nanoparticles? Nanoparticles are particles with size that range between 1 to 100 nanometer, or in other words, 10 to the minus 7 meters. And if this is not direct for you, when we're comparing the size of the nanoparticles to the size of the soccer ball, it actually resembles when we compare the size of the soccer ball to the size of the Earth. So indeed, nanoparticles are really small. And by applying my expertise in engineering, our team has developed engineered nanoparticles that carries a therapeutic gene, which is designed to program the macrophage from the hijacked mode to tumor-clearing mode. And in order to enable the ability for macrophage to target nanoparticle to target macrophages, we have chemically modified the surface property of these nanoparticles with the targeting moiety, so that once we're injecting our nanoparticles into the patient, they could specifically engage with the macrophages in the tumor. And we have shown that by exposing our nanoparticles to the tumor, these nanoparticles could specifically engage with macrophages in the tumor. And once they get taken up by macrophages, the therapeutic genes will be released within the cells and therefore program the macrophage from the hijacked mode to a tumor clearing mode. And to test this idea, as we have tested this idea in the mice that carries a glioma, specifically in combination of radiotherapy, which is currently standard of care for treating glioma patients. So as you can see here, compared with the mice that only received the radiation, the mice that received both radiation and nanoparticle treatment, their tumor not only grows slower, but also the size of the tumor is smaller. And in the end, we have shown that with this combination therapy, we were able to extend the survival of the glioma mice for about 60% compared with the mice that only received the radiation treatment. And with the support from American Brain Tumor Association, this study has been published in Nature Communication, which is a peer-reviewed journal. And our lab is working on pushing this new technology into the clinics.
Hello, my name is Linda Powers. I'm the CEO of Northwest Biotherapeutics. Our company is developing personalized immune therapies for cancer, particularly brain cancer. We're very pleased to be able to help support the ABTA Annual Meeting 2020. And we think ABTA's work in the field is super important, super helpful for the whole field. I'd like to take about 5 minutes to just talk about 3 subjects that I think may be of interest to folks. Firstly, the key challenge for immune therapies in trying to treat solid tumor cancers. Secondly, I'd like to describe a little bit about some of the key elements of the immune system, human immune system, that offer a real opportunity for, we believe, powerful treatments for cancers. And then thirdly, I'll describe a little bit about our particular approach with our DCVax technology. I will flag right from the beginning, we're very excited because just in the next couple weeks, later this month of September, we will be expecting to unblind, unveil, announce finally the results of our 13-year-long phase 3 trial of DCVax for glioblastoma brain cancer. And we think this study is going to be a major contribution to the field in terms of data, and we certainly hope to be able to bring a new treatment option to patients. So please stay tuned to see those clinical trial results in just a few weeks. So the key challenge for immune therapies, and really for other therapies too, in trying to treat solid tumors is that they are so highly variable. Solid tumors comprise the vast majority of all cancers. These are tumors in any tissue of the body as opposed to blood cancers or lymphomas. And the variability, the heterogeneity is really at all levels. Firstly, of course, there's a lot of variations among cancers. Brain cancer is different than lung or colon cancer. There's also extensive variations among patients, even who have the same cancer. For example, brain cancer, the patient may have MGMT gene methylated or unmethylated. They may have an IDH mutation or not. So variations among patients. There's even variation within a single patient as the disease progresses over time. And strikingly, even a lot of variation within a single tumor in a single patient at a single moment in time. If you take a biopsy from one part of a single tumor, you may get a very different profile than a biopsy from a different part of the tumor. A challenge? Well, it's a challenge because most cancer therapies have taken the approach of precision targeting and trying to be as laser precision focused as possible with a single active agent and a single target on the cancer, kind of a silver bullet approach. But the tumor can mutate and escape from that. So nature has built an immune system that's really well structured to help help stop these tumors and treat them. So you have the innate arm of the immune system and the adaptive arm, and they are complementary to each other. The innate arm is your first responders. They're rapid responders within hours or days. Those immune cells are basically born with a built-in library to recognize things that are bad, bacteria, virus, tumors, etc. The adaptive immune system follows on and takes longer, weeks or months or even longer to respond. And here we particularly focus on the T cells, a very important foot soldier, both helper T cells and killer T cells, although of course we have the B cells that make antibodies as well. But importantly, over the top of all of this is the master immune cell, the master cell of the immune system called a dendritic cell, sort of the general of the army. The job of the dendritic cell is to identify anything bad in the patient's body, pick up the information, process it, and present it to all of these other immune players, immune agents in the immune army, so that they're all activated to attack those bad things that the dendritic cell identifies. The dendritic cell is actually very efficient at doing this. The dendritic cell, when it picks up this information about the tumor or the pathogen, presents it to the T cells, for example, and activates the T cells to spread out, fan out throughout the whole body, looking for the bad thing to attack. And each one dendritic cell mobilizes hundreds of T cells, both large numbers of T cells and diverse T cells, to attack different biomarkers or antigens on the tumor or other pathogen or bad thing. So the approach that we're taking in DCVax is following nature's system. We're using the dendritic cell as the active agent and having the dendritic cell mobilize all of those immune agents to work together to attack the tumor. In addition, it's fully personalized. We use the patient's own immune cells and the patient's own tumor tissue sample, so we know that we're getting the right version of the targets on the cancer, and we don't have a Russian roulette issue about whether the patient's tumor does or doesn't express the target, as cancer drugs typically have that issue. And lastly, we use the full set of tumor biomarkers, tumor targets, not just one or a few or 5 or 6. And this makes it as difficult as possible for the tumor to escape. And so with this combination, many weapons hitting many targets, we've seen very encouraging results in our early stage trials, mid-stage trials, and compassionate use. So please stay tuned for the results of our phase 3 trial. We're really hoping to be able to bring this as a new treatment option for patients in the field. Thanks so much.
Welcome, and thank you for joining me in learning about Optune, an FDA-approved treatment for glioblastoma. I would like to thank the American Brain Tumor Association for allowing me to present to you. My name is Renee Adams, and I am the Thought Leader Liaison for Novocure. Today we'll learn about Optune, which is an FDA-approved wearable portable device indicated to treat a type of brain cancer called glioblastoma multiforme in adult patients 22 years of age or older. In newly diagnosed glioblastoma, Optune is used together with chemotherapy called temozolomide, or TMZ for short, if your cancer has been confirmed by a healthcare professional and you have had surgery to remove as much of the tumor as possible. In recurrent glioblastoma, Optune can be used alone as an alternative to standard medical therapy if you have tried surgery and radiation and either they did not work or they are no longer working, and you have tried chemotherapy and your GBM has been confirmed by your healthcare professional. Optune is not for everyone. Talk to your doctor if you have an implanted medical device, such as a programmable shunt, a skull defect, such as missing bone with no replacement or a bullet fragment. Optune has not been tested in people with implanted medical devices, which may cause the devices not to work properly. Optune is not tested in patients with skull defects or bullet fragments, which may cause Optune not to work properly. A known sensitivity to conductive hydrogels, the gel on the arrays placed on the scalp, like the ones used on EKGs. When Optune comes into contact with skin, it may cause more redness and itching, or may rarely cause life-threatening allergic reactions. Do not use Optune if you are pregnant or planning to become pregnant, as it is not known if Optune is safe or effective during pregnancy. Optune should only be used after receiving training from qualified personnel, such as your doctor, a nurse, or other medical staff who have completed a training course given by Novocure, the maker of Optune. Do not use any parts that did not come with the Optune treatment kit sent to you by Novocure or given to you by your doctor. Do not get the device or transducer arrays wet. If you have an underlying serious skin condition on the scalp, discuss with your doctor whether this may prevent or temporarily interfere with Optune treatment. Some of the most common side effects of Optune when used together with chemotherapy, temozolomide or TMZ, were low blood platelet count, nausea, constipation, vomiting, tiredness, scalp irritation from the device, headache, seizure, and depression. The most common side effects when using Optune alone were scalp irritation, such as redness or itchiness, and headache. Other side effects were malaise, muscle twitching, fall, and skin ulcers. Please visit optune.com/safety for Optune patient information and operation manual, as well as complete information regarding the device's indication, contraindications, warnings, and precautions. Talk to your doctor if you have any of these side effects or questions. Please note that an Optune user or caregiver cannot provide you with medical advice because each person is different. Consult with your doctor for medically related questions. Today we will provide you with a general information about glioblastoma multiforme, Optune, and matters related to using Optune. For questions about your personal health or your treatment plan, the best person to ask is your doctor. Your healthcare provider can review how Optune works against your tumor and how it fits into the daily lifestyle to determine your best path forward. What is glioblastoma? Glioblastoma is also called glioblastoma multiforme, or GBM. GBM is a type of primary brain cancer. This means that GBM tumors begin in the brain rather than starting in another part of the body and then traveling to the brain. GBM is the most common type of primary brain cancer diagnosed in adults. Optune is a wearable and portable FDA-approved treatment for glioblastoma. Optune uses 4 adhesive patches called transducer arrays to deliver tumor-treating fields, or TT fields, to the location of the GBM tumor. It has been shown in clinical trials to safely deliver continuous therapy to the area of the brain where the GBM tumor is located. These transducer arrays are applied to the scalp and are connected to the device and battery. Optune treats where the tumor is. Glioblastoma tumor cells divide quickly, creating more and more cells that form a mass or tumor. As you can see in this illustration, Optune affects where the tumor cells begin to divide. When Optune is turned on, it creates low-intensity, wave-like electric field called tumor-treating fields. Using those 4 adhesive patches called transducer arrays, tumor-treating fields are delivered to the location of the GBM tumor. In this illustration, you can see that tumor-treating fields interfere with the dividing tumor cell. Tumor cell division may then slow down or stop, and some of the cells may even be destroyed. If you have newly diagnosed glioblastoma, Optune is used together with chemotherapy after surgery and radiation with chemotherapy. If you have recurrent glioblastoma, Optune is used alone once treatment options like surgery and radiation have been exhausted. In people with newly diagnosed glioblastoma, Optune is proven to extend survival. A large clinical study showed that by adding Optune to chemotherapy provided the greatest opportunity to live longer compared to chemotherapy alone at 5 years. In a 5-year follow-up, people on Optune plus chemotherapy lived longer across all groups analyzed, regardless of well-being, age, gender, and how much of the tumor was removed. Additionally, nearly half of people using Optune plus chemotherapy were alive at 2 years, compared with 31% of people on chemotherapy alone. Continuous treatment with Optune can be received almost anywhere. If your doctor says it's okay, you can use Optune while you go about your daily routine at work, while traveling, and at social functions. Transducer arrays need to be applied directly to your scalp to work properly. You will need to shave your head and change the arrays at least 2 times a week, or every 4 days at the most. To prevent transducer arrays from getting wet, cover them with a shower cap when bathing or showering. Optune should be worn and turned on for at least 75% of the time, which equates to about 18 hours per day, to get the best response from treatment. As you can see in the photos of these actual patients, head coverings are optional. It is important to select a head covering that is breathable and lightweight. For a complete list of these head coverings, please visit optunedailylife.com. Novocure offers webinars throughout the year to help you stay informed and inspired. Optune users and caregivers will discuss their experiences living with GBM and integrating Optune into their lives. You'll also have a chance to ask questions and discuss other topics about Optune. To find out more or to register over the phone, call 1-844-247-1636 or visit optuneopenhouse.com to register for a webinar today. Our Encompass Complete Support team supports you every step of the way, and we provide customized support based on your need. We offer 24/7 technical support via phone. They're able to reorder supplies, answer ongoing questions about Optune, and offer travel tips and resources. Additionally, the device support specialist, another member of the Encompass team, delivers Optune, provides training to help you get started, and shares tips and resources on how to incorporate Optune into your daily life. Additional benefits of the Encompass team are that they can help provide information on Optune and how it works, answer questions about the potential benefits and side effects of Optune. Thank you so much for joining, and I hope you found this education beneficial.
Welcome back, everyone, to our afternoon session. We hope you took advantage of this break to meet our ABTA Board of Directors, hear from our sponsors, and our researchers. Our co-chair, Jean Arzbaecher, will introduce our next speaker.
Hello. In our next presentation, you will learn about how participation in clinical trials can offer patients and families across access to novel brain tumor treatments. This session offers ground-level strategies in considering clinical trials. Presenting again is the conference planning co-chair, Dr. Mark Gilbert. A fun fact about Dr. Gilbert is that he actually does like to have fun. At all his virtual meetings, he always brings a dad joke. One of his favorites is, why is a koala not officially a bear? I will let him answer this question. Please welcome Dr. Gilbert.
Thanks, Jean. So before I start on my talk, I want to again thank the ABTA for putting on a fantastic session. And while I've been talking, hopefully people are thinking, why is a koala not officially a bear? I did pose this question to the people in the Neuro-Oncology branch at the NCI and had some very interesting responses. One of them was because it's a marsupial. That's probably scientifically correct, but the real answer is a koala is not officially a bear because it does not have the koalifications. All right, let's get started on clinical trials. Next slide, please. I don't have any disclosures to report. Next slide. So what am I going to talk about? Well, I will start by defining what constitutes a clinical research, a clinical trial, or clinical study. What are the types of clinical trials, which I know is an area of great importance to many of the people participating today. What are the barriers and challenges to participating in clinical studies and trials? And finally, what myths exist about clinical trials? Next slide. So what is clinical research, a clinical study, and a clinical trial? Well, clinical research is defined as medical research involving people. There are two types, observational studies and clinical trials. Observational studies are still considered clinical research, and this is where you observe people in normal settings or in people with certain diseases. And here the researchers gather information according to study-specific characteristics and try to address questions that typically occur over time. And if you were present for Dr. Armstrong's outstanding presentation, she talked about natural history study, which affords the opportunity to see what happens to patients over the trajectory of their disease. On the other hand, clinical trials are different. And we have two definitions here. The first is from the World Health Organization, where they define a clinical trial as any research study that prospectively assigns human participants, patients, or groups of humans to one or more health-related interventions to evaluate the effects on health outcomes. So obviously this would be called either an interventional or a therapeutic clinical trial. The NIH defines a clinical trial as a research study in which one or more human subjects are prospectively assigned to one or more interventions, which may include a placebo or some type of other control to evaluate the effects of these interventions on health-related biomedical or behavioral outcomes. So again, important to know that there's a broader spectrum to clinical research than just clinical trial. Next slide, please. So if you go to clinicaltrials.gov, you can actually search for various clinical trials and diseases. So here's the results of a search asking about studies for glioblastoma in adults. And it's looking for studies recruiting, interventional studies as opposed to observational, again, the adult population. And you can see that across the world, the highest number of these studies are actually in the United States. Next slide. If you do go to clinicaltrials.gov and you decide that you want to also see a map, there's actually a tab on the top that says on map. Next slide. Well, let's compare that map with all the studies on clinicaltrials.gov. And you can see that in the US, even though there are close to 200 for adult glioblastoma, there's a total of 132,000 clinical trials ongoing in general. So lots of clinical research going on. A very small segment is for malignant brain tumor. Next slide. So you heard earlier, if you did listen to Dr. Armstrong's presentation about the natural history and observational studies, and she pointed out very importantly that if we only get information for patients while they are on a clinical trial, it's very limited, and as shown in the graph, again, she had the same one in her presentation, where the green lines represent on clinical trial. You can see that there are many gaps. So natural history studies enable us to really get a sense of what happens to patients over the entire trajectory of the disease. So again, as it states, it provides an unprecedented opportunity to understand the patient experience and the challenges that both patients and families face during the illness. Again, not next slide, but there we go. And that inset again shows how we in the Neuro-Oncology branch track patient symptoms, and that's a snapshot. That's one of the things we use in our clinical practice, as Dr. Armstrong so eloquently illustrated. Next slide. So let's talk about clinical studies. All clinical studies must have the following. And the most important, and I'm sure you've all heard about this, is officially sanctioned review panel or board approval. In the US, it's typically the IRB, the Institutional Review Board. The IRB makes some important determinations from a clinical trial. It must have the following criteria: an appropriate risk to benefit likelihood. So again, there are certain clinical trials where there's very little risk, others that are very risky, things like stem cell transplantation. But again, it has to be an appropriate risk to potential benefit. The IRB is looking to make sure that it's based on sound scientific rationale, either based on prior data from clinical trials or preclinical studies. They must be incorporated into the study adequate patient monitoring, and so that they can look for toxicities and report those rapidly if in case they do see toxicities. And studies have been stopped because an excessive amount of toxicity has been determined that was not anticipated. Patient confidentiality is a big issue, and again, the expertise and resources to successfully accomplish the study and monitor patient safety. So doing a study and then not having the resources to complete it, you've put patients onto a trial and for which there will be very little information, and that is not considered to be appropriate. An important aspect of clinical trials is consenting the patient. They'll look at the consent form. They'll want to know if it's comprehensive yet easy to understand. Does it truly reflect the risks and potential benefits from participating? And does it provide a full explanation of study requirements and obligations? Again, signing a consent is like a contractual arrangement, an agreement between the study team and the patient and family. So everybody needs to be sure they know what they're agreeing to. Next slide. So what are the components of a clinical trial? Well, actual clinical trial a protocol document always has a rationale and background that enables the reviewers to be able to determine whether it makes sense to go forward with the study. The objectives, what are you trying to measure? Is it survival? Is it progression-free survival? In certain studies, are you looking for improvement in symptoms, or are you looking for things like maintenance of the quality of life or cognitive function? In the objectives, you also determine the phase of the study, and we'll talk about the various phases, phase 1, phase 2, phase 3, and also we'll talk a bit about phase 0. What are the endpoints? What are your measurements? And again, that directly relates to the objectives. If you want to see if a study improves survival, then your primary endpoint would be evaluating overall survival and likewise progression-free survival, as well as the other endpoints. In the study protocol document, you need to address patient management issues, importantly, eligibility and ineligibility criteria. And this is often concerning to patients and families. They're interested in a study, they undergo an evaluation, and then they're told they don't qualify because of some eligibility or ineligibility criteria. So these are really designed to make sure that the study is both interpretable and is safe for the patients. So again, its primary concern is to maximize patient safety and also to enable us to optimally interpret results. So we want to make sure that we know what the disease or diseases are that we are treating and that they've been well defined, and that the patient population is well defined so that we have our best chance of making an accurate interpretation. We also need to have a report in the protocol document of what the anticipated adverse events are and actually what their likelihood or frequency is. And then importantly, and increasingly importantly, correlative studies. You had heard earlier about the importance of patient outcomes measures, and these are increasingly being incorporated into clinical protocols. Dr. Armstrong gave some examples from clinical trials where the patient outcomes assessments were critical to the interpretation of the results. And again, the correlative biology also important as we try to determine why a treatment works in some patients and not in others. Next slide. So one of the important aspects in a clinical trial is measurement of response. And so there have been a variety of measures incorporated into cancer clinical trials. The classic one, of course, is response rate. Does the tumor shrink? And of course, if the tumor shrinks, one can feel pretty confident that the treatment is actually working. Advance one, please. And actually, in neuro-oncology, though, we do have sort of a confounding issue. And we did hear from Dr. Harvey Jumper yesterday about this issue of pseudoprogression. And the illustration here, which starts up at the top when the patient after radiation had an abnormality on the right side of the brain, which actually grew over several months, but then spontaneously got better. And this is an example of chemoradiation causing pseudoprogression. So you can imagine in the context of a clinical trial, if the patient was enrolled after their tumor grew in panel B, the experimental agent would look quite good because the tumor got better. But that tumor got better while remaining on the same temozolomide treatment. So this phenomenon of pseudoprogression makes us concerned about using response rate as a sole measure. There's also progression-free survival, which counts disease stability as a success, and of course overall survival, which is very objective. But of course, if you're looking at a study, first-line study, do subsequent treatments alter survival, and that becomes an issue. Next slide. Advance again, please. Okay, so we talk a lot about determining survival. We talk about comparison, and very often we refer to what we call a Kaplan-Meier curve. And I know Dr. Harvey Jumper discussed this yesterday during his talk, but I thought important enough that everybody understands why we use a Kaplan-Meier curve. It is the most commonly used method to evaluate outcomes in clinical trial, be it survival, overall survival, or progression-free survival, or any event for that matter. Why it's so great is it statistically allows us to account for patients where we don't yet have an event. So if we want to look at a study and there are still patients doing well, if we just look at patients who have had an event, then obviously those who are doing well wouldn't count. But what this allows us to do is statistically account for patients up until the time that they were last evaluated. So patients who were lost to follow up for whatever reason, patients who are doing well, are all included in the analysis. We typically talk about things like median survival. Median endpoint is the most common, means that the point where 50% of the patients have had an event. Again, median survival, and you can see illustrated here that the median survival between the treatment A and treatment B is different. You can see the median survival indicated is 39 months for treatment A and 15 months for treatment B, hence the difference. We also use landmark analysis. Here illustrated, we have the 2-year survival rate, which was 70% for treatment A, and the 2-year survival rate was 30% for treatment B, and that's all obtained from this survival curve. How do we compare them statistically? Well, there are a variety of statistical measures, and we're always looking for a p-value. What is a p-value? The p-value is an estimate of the likelihood that the difference would occur by chance. So across most studies, we've decided that a p-value of 0.05, which means a 1 in 20 chance that this happened by chance. And we feel like that's comfortable, that there's a 95% chance that the difference we're seeing is real. In the case we see here, this example on the curves on the left, the p-value was less than 0.02. So a 2 out of 100 chance that it happened by chance. And we would say there's a significant survival difference here between treatment A and treatment B. I hope that was helpful in explaining the Kaplan-Meier survival curve. Next slide. So clinical trials, okay? Now here we're going to go through the various phases. And the classic phases were phase 1, 2, and 3. And more recently, we incorporated the phase 0. The phase 0, as I will show you, is designed to determine drug delivery to the target, and this is what we call target pharmacokinetics, and as well as determine if the drug impacts the target, and this is target pharmacodynamics. The phase 1 study is mostly a safety study. We're trying to determine what the maximum tolerated dose or the optimal biologic dose is. Phase 2 is the first test of effectiveness, and phase 3 is the comparison clinical trial. Next slide. So the preclinical and early clinical studies using phase 0, really important. This is very much dependent upon very strong studies in the laboratory to make sure we understand what the drug can do on the preclinical models before we take the drug into a clinical trial. Typically, patients who need some form of operation to remove their brain tumor will get the drug before the operation. The tumor will be removed, and part of it go to the laboratory to both measure the amount of drug that was able to get into the brain, cross the blood-brain barrier, and oftentimes see what effect it had on the target of that drug. So that's the phase 0 study. Next slide. So here's an example of phase 0. There's a drug called lapatinib, which in preclinical studies look quite promising in brain tumors. And a study was done, and from the preclinical study, we knew that we needed a certain concentration of lapatinib. So if you look at the graph on the bottom, you see that orange line, that's 1500 nanomolar concentration. And then all of those numbers below are patient samples. And you can see the number of dots above that concentration were very few compared to the number that were below. And this indicated that in the majority of patients, an inadequate concentration of lapatinib was achieved by giving it by routine administrative use. So this was very important because if you did a clinical trial of lapatinib, unlikely you would see much effect because not enough drug got into the brain. So very useful for this phase 0 study to tell us that the standard dosing of lapatinib would be inadequate. Next slide. Looking at phase 1 studies, again, here we're starting with a low and known to be safe dose and gradually increasing with the idea that the higher the dose, typically the better. So we get to a point where we consider the dose to be safe. It's typically 3 patients at a time get evaluated in what is called a 3+3 design. This is often accompanied by measuring concentrations of the drug in blood called pharmacokinetics. And what I've illustrated on the right was a study that I was involved with a drug called irinotecan or CPT11. And we know that CPT11 or irinotecan is a prodrug, that its active drug is called SN38. And what the PK studies showed us, and I have highlighted in the red boxes, is that the higher concentrations of CPT11, the body's ability to metabolize the drug decreased. So we got more CPT11 in the body, so that shows a decrease in clearance, but the increase in the amount of the active SN38 was far less than the amount of increase in CPT11. So we were getting much more toxicity than we were getting an increase in the effective SN38. So this told us that even though we could push the dose of CPT11 higher, we were not getting an equal trade-off for that extra toxicity. So pharmacokinetic studies, very helpful. Next slide. And again, we typically in phase 1 studies with most chemotherapies look at a month. And this slide is to remind me to say that the time for evaluation of safety is really dependent on the agent. Here with immune checkpoint inhibitors and all of the effects that they can have, the autoimmune effects that Dr. Fecci talked about yesterday in his presentation, tells us that there are some effects that occur 6, 8, 10, and even as late as 12 weeks after. So the phase 1 studies in immune therapies may have to be much longer than the typical 28 or 30 days. Next slide. The phase 2 studies are designed to get, like I said, a preliminary signal to see if there's effectiveness. Traditionally, you would treat a group of patients and then compare it to historical controls, but there are concerns about that. And so recently there's the idea of the randomized phase 2 study where you have a smaller study than a phase 3, but patients getting treated and others getting treated with standard of care for an early comparison. Push return, please. Oh, back to, go forward, please. Forward, I'm sorry, forward. Great. Push, next slide. Okay, nope. We keep going back. Forward again. There we go. Okay, so here's an example of the DCVax phase 2 study. It was a single-arm trial. It's represented by the blue line on top. And you can see compared to historical controls, it looks quite promising. But again, concerns whether or not this was just because the patients who were eligible for the DCVax were different than historical controls, many concerns, certainly encouraging, and it did actually lead to the randomized placebo-controlled DCVax phase 3 trial. Next slide. So talking about phase 3 trials, these are the comparative randomized studies. Dr. Armstrong talked about these two studies that I've illustrated here. The top was the RTOG 0525 study, where we asked the question whether a more intensive temozolomide regimen, giving the treatment 21 out of 28 days, would be better than the traditional 5 out of 28. And we randomized the patients to the two arms, and we made sure there was balance in both arms regarding the MGMT promoter methylation, which is both predictive of response to temozolomide as well as prognostic. As she mentioned earlier, it was not therapeutically positive, so there was no benefit to the more intensive chemotherapy. And on the bottom, it's the RTOG 0825 study, which was also randomized, but now patients receive either standard of care and placebo or standard of care plus bevacizumab. We felt it very important to include a placebo because we wanted to objectively monitor both response as well as side effects. And it's hard to do if the investigators know what treatment the patient's receiving. Next slide. Why do we do a randomized trial? Well, I intimated before that sometimes historical controls may not represent your patient population. Here are the results from a study published by my good friend and colleague, Dr. Grossman at Johns Hopkins. They had 3 trials of patients with glioblastoma in newly diagnosed setting. Those are represented on the right side, right graph, by the 3 upper lines, and all look better than historical controls. And their concern was, is it likely that we have 3 consecutive trials, all that are better? And the answer is no. They were concerned the historical controls did not actually compare with the patients enrolled on their trials. So randomized trials would obviously eliminate this problem. Next. Why not to do a randomized trial? Well, it uses a lot of resources, patient accrual, financial, requires a lot of oversight, but very important to really get an accurate answer, particularly in diseases like glioblastoma. However, in rare diseases, it's very difficult. And so there are certainly examples in general oncology, but even in neuro-oncology, where a single-arm clinical trial in a rare disease has proven to be beneficial and enough to get FDA approval. So here we have the example of the subappendable giant cell astrocytoma. And in this study, single arm, all patients getting what is called an mTOR inhibitor, everolimus. They saw an objective response in 75% of the patients. They combined it with quality of life measures. In this case, there was a dramatic decrease in seizure frequency, and the combination of objective response and patient improvement led to FDA approval. So randomized trials not always necessary. So let me turn now to the challenge of accrual. to clinical trials, and many have heard that very few patients with brain tumors are enrolled on clinical trials. Next slide. But when patients are eligible and offered a clinical trial, more than 50% of the patients enroll, and this is across all cancers. Next slide. However, when you look at the brain tumor population, only about a fifth of primary brain tumor patients are ever on a clinical trial, and approximately 10% of those with newly diagnosed glioblastoma participate in clinical trials. Next slide. What are the top reasons for not participating in trials? And this is based on a survey done of brain tumor patients in 2016 by the NBTS. The first was that their doctor did not recommend one. The second one, they didn't qualify. Or the third is they did not know where to find one. And I think some of these have been addressed by some of the organizations with navigation, as well as the clinicaltrials.gov. Next slide. There was a survey done by Dr. Armstrong's group in collaboration with the Society of Neuro-Oncology, surveyed the members, asked from the provider standpoint, what are the challenges and barriers to referring patients for clinical trial? So 372 SNO members, less than 30% of all patients were referred for clinical trials. Many said that their institution didn't track clinical trial referral, and the biggest barriers overall were eligibility of the patients and distance from the clinical site. Next slide. Again, another study done with the Society of Neuro-Oncology, asking what the perception by the healthcare providers, barriers to accrual enrollment in brain tumor clinical trials. They felt there were community and patient factors, disparities in who was being offered studies, the physician and provider factors, and we had some hint of that from what our patients reported, and clinical trial factors. And most notably, there was a feeling that the eligibility criteria were not optimized, and that there were insufficient number of high quality, thoughtful clinical trials that the healthcare providers felt comfortable referring patients to. And then they also cited organizational and site factors. Next slide. So let me finish up addressing some clinical trial myths. The first is that new treatment is always better than the standard of care. Next slide. This is not true. Again, most new treatments are not superior, but we have to go into the clinical trial saying there's a chance that it is better. If we knew it was better, we wouldn't need a trial. If we knew it was not better, we wouldn't do the trial. And we call this position equipoise. So we're hopeful, but we need to do the study. Next slide. Next. There's concern that patients who are on a placebo-controlled trial may not get treatment if they're on the placebo. Next. But actually all brain tumor treatment studies include treatment. So there'll be a treatment plus or minus the active agent. There may be a placebo, just so everybody can look at things objectively. Next. Clinical trial will cost me a lot of money. Next, please. Next. But in reality, most, if not all, costs that are associated with the clinical trial itself should be covered. If not, you'll be told in advance what is not covered by the study and what you would be responsible for. Next. There's no benefit for me to be on a clinical trial. Next. Although the new treatment may not be better, in fact, than standard treatment, patients on clinical trials tend to do better, and let me show you a study that confirms this. Next slide, please. So colleagues at MD Anderson looked at their clinical trial participation, patients with glioblastoma, and the patients enrolled on clinical trials did better. Next. So here they looked at a large group, 622 patients, and they looked at those who were not on a clinical trial, that was 111, and those who were on a clinical trial, whether it was recurrent or newly diagnosed glioblastoma. Next. The factors that predicted for trial enrollment were educational level, current employment, whether they were in Texas or not, and their functional status, and folks with neurologic symptoms like language dysfunction tended not to be on study, and interesting, those who were smokers. Next slide. But here is the bottom line, and the blue dashed line represents those folks who were on an upfront clinical trial compared to those not on upfront clinical trial. And in both instances, both looking at overall survival, which is graph A, and progression-free survival, graph B, both the group that was on an upfront clinical trial did statistically significantly better than those who didn't participate, regardless of whether the study was therapeutically positive. Next slide. So I hope this has been helpful. I think you all realize that clinical research is a vital part of advancing our treatment for diseases. In our case, certainly we rely on this to help us determine what is the best therapies for our patients. There are a variety of clinical research approaches. We've talked about the natural history studies, observational studies, and of course the therapeutic clinical trials. Therapeutic clinical trials are performed in phases. We want to make sure the treatment has an established safety profile. We know the optimal dosing. We also want to see that there's some effectiveness before we go forward and expend all the resources and involve many patients in a treatment which we could have predicted was not going to work. And again, I emphasize that patient outcomes measures are increasingly being incorporated so that we know the impact on the patient. And as Dr. Armstrong illustrated, there are treatments that actually make patients feel better and more functional. And of course, we advocate for increased participation in clinical research, which is essential for progress. And I would encourage everyone to investigate the possibility of clinical trials if you need treatment in the future. So with that, I'll conclude, and I will greatly appreciate the opportunity and your attention. Happy to answer any questions.
Thank you so much, Dr. Gilbert. So we do have some time for questions, and just as a friendly reminder, if you have questions, please type and submit it using the Q&A box at the bottom of your control panel. So Dr. Gilbert, can you share at what stage of disease or treatment should a patient or their family member start considering a clinical trial?
So that's a great question. It does depend a little bit on the disease, but we would encourage people start to investigate at times even before a firm diagnosis is made. There are studies in glioblastoma that require that the original tumor be removed and processed carefully for vaccine production or other types of either analysis or preparation for a clinical trial. So in those instances, the patient doesn't even have a firm diagnosis, just an imaging study that is consistent with that disease. But that's the window of opportunity. In other circumstances, particularly when it's an uncommon disease, you would want confirmation of the diagnosis, often using some of the advanced molecular testing that we've talked about earlier, and then get involved in the clinical trial process.
Thank you for sharing that. You had briefly touched upon placebos in clinical trials. Can you just clarify that a little bit more? What is a placebo, and can you emphasize again what happens when a patient is on the control side versus actually receiving the clinical medication or therapy?
Right. So it's a very important point, and thank you for allowing me to clarify. So we use a placebo in a clinical trial in brain tumors, always in conjunction with a therapy. So we're asking the question whether the experimental agent, when combined with therapy, is better than the primary therapy alone. In order to be able to interpret the information with the highest degree of accuracy, the use of a placebo enables us to evaluate the important data, which is things like response and side effects, without having any unintentional bias. So we're looking at an image. If we know a patient's on an immunotherapy and we see a little bit of fuzziness, is that tumor growth or is that inflammation? If we know the patient's not on the immunotherapy because they're on the other arm, then we don't attribute that fuzziness to inflammation. So we want the investigators, we want to not have any unintentional bias. We want the patients to report their symptoms to make sure that they're also not attributing things to a treatment. So it provides the highest level of evidence about not only the effectiveness of a therapy, but also what its true side effects are.
Thank you so much for clarifying that. And can you share with us who has the primary responsibility for finding a clinical trial for the patient? Is it the patient and their caregiver? Is it the clinical professional?
So I would say it's a partnership. And I think through the course of dialogue, expression of interest in clinical research by patient and family should spark some discussion. There are times that patients and families can use some of the navigators through organizations or go to clinicaltrials.gov, although that can be daunting. There are hundreds of clinical trials, and sorting through those can be difficult. So I would say the majority of that discussion is either with a navigational group or with the healthcare team where the patient's being cared for. And again, also opportunity to seek out second opinion at centers of excellence.
Thank you so much for that answer. What about patients who have inoperable brain tumors? Do they qualify for clinical trials?
So that's a terrific question. Increasingly, the definition of inoperable is changing. So several years ago, it became evident that even tumors that were considered to be inoperable, they could be sampled through a biopsy. So for example, the brainstem glioma, it is now safe to be able to get a small biopsy, which enables an accurate diagnosis. And as we're increasingly learning, there are subtypes. And so almost every clinical trial requires that there be some material, some tumor material for analysis to confirm diagnosis before entry onto the study. So I would be very careful about using the word inoperable. And I would say that if a patient is told that their cancer isn't inoperable, it may be that it can't be removed, but the question can then be, can it be sampled so that we can get a firm diagnosis, which may open up opportunities for clinical trials.
Thank you so much for clarifying that. And can you share what entity approves clinical trials? Is it different from country to country? And specifically in the US, who is the one who's actually approving treatments that are on clinical trials?
Well, that's a great question. It's a bit complicated. So at each institution, the IRB does the final approval. If the study includes a drug that has not yet been approved or is being used in a way that's quite different, the FDA would also need to approve it under something called an IND, an investigational new drug. So those studies, those clinical trials, in addition to getting IRB approval, would also need to get FDA approval, and a whole extra set of oversight is required for IND studies.
Thank you so much. One more question we have is asking if you can share some advice for patients who are trying to maximize their chances of finding a promising clinical trial that they will qualify for. Is there anything more proactive they can do in addition to just talking to their neuro-oncologist or looking into a clinical trial database?
So yeah, again, we've heard it can be quite difficult to navigate. But organizations like the ABTA can provide some help and guidance in that regard. And I centers of excellence in brain tumors often have a very good idea of what the national landscape is. So that though there are resources, it does take a little bit of investigation. And I know there are groups working on mechanisms to make that navigation easier for patients. But there are many clinical trials, and it's hard to actually identify those that are optimal for an individual patient without a lot of prior knowledge.
All right, thank you so much for sharing your insight, and thank all of you for asking your wonderful questions. That's all the time that we have for questions for this session. We'll go ahead and move on to the next portion of the program. Thank you.
Thank you so much, Dr. Gilbert, for sharing this important session about clinical trials. You may now lead into the clinical trials panel discussion with experts.
Yes, well, thank you. We thought that this is such an important topic that we've actually asked a group of experts as well as a patient to share their thoughts about clinical trials. So joining us are Donna Van Rijn, who is a clinical trial patient. She has glioblastoma and has been on a couple of clinical trials, and she'll report her experience. My co-leader, Jean Arzbaecher, who has been a nurse practitioner and caring for patients on clinical trials and has terrific experience. Dr. Terry Armstrong, who's already presented today, and her insights and expertise in clinical trials. Dr. Fetchy, neurosurgeon from Duke University, who presented yesterday in immunotherapy and is obviously involved in immunotherapy clinical trials as well as others, particularly in the neurosurgical space. And Dr. Eva Galanis, who is part of the tumor board this morning, who is one of the top neuro-oncologists in the US and the chair of the Brain Tumor Committee of the Alliance Oncology Cooperative Group. So we've asked them each to provide some thoughts, and we'll start with Donna.
Good afternoon. My name is Donna Van Rijn, and I have participated in 2 clinical trials. Now, in difference to some of those who had to look for their own clinical trials, mine kind of came to me. So I had been diagnosed with a glioblastoma in 2005. I had done the standard of care and really did not seek clinical trials at all until along came the 3rd tumor. Now, the first 2 tumors were taken care of through surgery or chemotherapy. Now, when the 3rd tumor came along, it was one of those places in my life where it said, you know, you need to do something different because the tumor just kept progressing. So in 2007, with the 3rd tumor, we decided to look into a clinical trial. Or actually, my doctor had mentioned a clinical trial. And I was presented with a clinical trial there was an investigational drug that had not been approved. So this was a phase 3 trial. During this phase 3 trial, I was given the drug Avastin. Now, I was also given another drug to go along with this. And after about a year, or actually 16 months of taking this drug, they found that the tumor had responded very well. But at the end of the 16 months, they decided that the tumor had progressed. So that's when I needed to go on another clinical trial. And this was at the suggestion of my doctor out of University of Chicago. And there was a new clinical trial going on. It was a phase 1, and it was where they combined scorpion venom with radioactive iodine. And so after a lot of thought about this, I decided to go ahead and do this trial. basically because I was at a point where, of course, I had 3 tumors. This was the 4th tumor that came along. So we knew we had to do something totally different. So I went ahead, signed the paperwork, knew that this was not going to be a cure, or it was not guaranteed to be a cure, but we hoped to just keep me around long enough until something else came along. But actually, this worked very well for me. I was able to do the clinical trial, and after some time of recuperation, I was at home for about 14 months. I had been a teacher before this, so I took a year off and actually recuperated from this clinical trial, and then went back to work. And I've been back since. I get a scan once a year, and it shows that since 2008, the tumor has been stable. Now, with my original diagnosis being in 2005, it seems like I have responded very well.
Thank you so much for your insights and sharing your experience with clinical trials. I would say you are probably a big advocate for participation in clinical trials.
Yes.
Now I'll call on Jean.
Hi, I was asked by Dr. Gilbert to talk about concerns and questions that patients have regarding participation in clinical trials. I think one of the biggest things is that the consent form, it can be very long and scary, and sometimes people get overwhelmed by reading it. So what we recommend is, give it a chance. You don't have to sign it the day you walk in. Take it home, read it. Understand that we are obligated to emphasize any potential risk that may or may not occur, that we're obligated to do that. So, read the consent, but understand that the consent is geared toward the study and any potential risks, especially, I'm sure Donna will tell you, if it's a phase 1 trial, it may actually say somewhere in the consent form that you may be the first human to ever receive this drug or this drug combination. And just, be aware of that. The other thing is that, and Dr. Gilbert talked about this in his talk, is the inclusion and exclusion. People get very frustrated because either treatment character or treatment, previous treatments or tumor characteristics that they don't qualify for a clinical trial. So we have to have well-defined populations in order to determine whether this treatment is effective. Once the treatment, like Donna said, she was in the Avastin trial, which is now approved. Once the treatment has been determined to be effective, it's likely that it will be approved for all people who've had all types of treatments. So the other thing is the rigors of the trial. It takes so much work. There's a lot of follow-up, and frequently you have to go to the center that's doing the clinical trial in order to have all your tests and things like that. So that's something to take into consideration. If this involves traveling, that can be, costly, and it can be tiring. So keep that in mind, that the good thing is that people get watched very carefully in clinical trials. So that's, Dr. Gilbert talked about, people do well even if the trial doesn't work because they're watched so carefully. The placebo group, that was another thing, and I think Dr. Gilbert covered that both in the questions and in his talk. The final thing is, what if there's more than one clinical trial? How do I decide these things? And so you have to take into account the convenience of it, what it involves, what phase of trial it is, and feel free to talk to your healthcare professionals regarding, what they think, and feel free to ask us our opinion, but eventually the decision has to be yours. Thanks.
Thank you, Jean, for those great insights. Dr. Armstrong.
Thanks, Dr. Gilbert. You had asked me to address the question of use of patient-reported outcomes in clinical trials and including the patient voice. And one of the most important aspects of clinical trials is understanding the impact on the person. Depending on the phase of the study, sometimes our primary objective is to understand how tolerable it is to the person. So you shouldn't hold back with sharing what your experience is and asking questions. Sometimes I think we have a approach of don't ask, don't tell. People don't want to bother their doctor with what's going on. Maybe it's normal, maybe it's to be expected. and the doctor may not ask all the things that may be going on. So make a list for yourself and be sure to share your experience with the trial. Secondly, if there are patient-reported outcomes as part of the trial, and as I mentioned, we published guidelines earlier this year that says that they should be, please take the time to fill those out as accurately as they can. It's really your experience and what is going on with you. By filling them out, it'll help us understand what the impact on the individual person is, and help us to understand the clinical benefit of a treatment and not just the impact on the tumor. And then in terms of being sure that this is included, please ask the provider if this is part that's included in the trial. It should be told to you. You should be offered the ability to have a consent if it is. Sometimes it's considered optional in the trial, so please opt in if you can. And that would be really helpful in our understanding your experience. So thanks a lot.
Thank you, Dr. Armstrong. I'll now ask Dr. Fetchy for his thoughts.
Sorry, I just realized I had to unmute. Dr. Gilbert had asked me to discuss a little bit about what the role of neurosurgeons might be in trials and how we can actually help facilitate getting patients onto trial. And I think one of the key things I would say is that neurosurgeons have to be part of a team. The trials themselves tend to be very complex, and there are, of course, as I think a lot of questions reflect from this meeting, there are a lot of trials out there, and they all have very different eligibility criteria and very different rules of engagement, so to speak, on who might qualify, what extent of surgery there needs to have had occurred prior to that, whether or not the tumor is going to be a first diagnosis of, i.e. glioblastoma or some other cancer, or whether or not it's a recurrence that we're looking at. And if you're at an academic institution where there's a large team of folks working together, each person is equally important in kind of understanding that this is a bigger question than what they are themselves providing. So for me as a surgeon, my instincts might be to see tumor and take it out, but that may or may not be the right thing, particularly if for instance, I can only get a certain percentage of the tumor out and the trials that someone might be interested in mandated gross total resection. Or in some cases, believe it or not, there are actually some clinical trials out there that don't want the tumor taken out. And some of these are for recurrent glioblastoma. I think the poliovirus, which some folks are aware of, that's a trial where they want some residual tumor to put a catheter into to try to get the drug into that tumor. And so the surgeon's job is really to kind of push the pause button a little bit, because in a lot of cases, we may be the first person that somebody with a tumor encounters. It's not uncommon for me to be the first person that someone comes to see at Duke. Or perhaps the first symptom of a tumor is a seizure or weakness, and so I'm the first person they see in the emergency room. And if I just kind of march forward without making myself a member of the team, including the patient's team, that discusses what the best options are, then I think I've acted irresponsibly. And so I think the neurosurgeon's role and responsibility is to act as part of a team, a multidisciplinary team that discusses things before steaming ahead. And the patient's job is also not to be convinced by a neurosurgeon at a hospital to march forward immediately with surgery without kind of understanding the landscape and understanding what other possibilities and trials there might be. In general, though, the role of surgery, of course, is important. Many trials do require a full surgery or a complete resection of a tumor to qualify. And so you want to make sure you're going somewhere to have a surgery that does a lot of the type of tumor that you have, to make sure the surgeons are experienced and can get a complete resection and feel comfortable doing that, because that's going to increase your eligibility for many studies. And if there's a tumor recurrence, oftentimes a biopsy will be needed in order to establish that diagnosis of recurrence, as well as to find molecular markers and mutations in the tumor that might actually be specifically necessary to have those to be targeted by whatever clinical trial someone is enrolling in. So I guess the moral of the story is, push the pause button, explore your landscape, understand that there are different criteria for different studies, and make sure that the surgeon is somebody who's on your team and as an advocate is not simply trying to steam forward and steam ahead with care. There's a lot of things to consider before making decisions.
Great, thank you so much, Dr. Fetchy. And finally, Dr. Golanis.
So good afternoon, everyone. Again, it's a true honor being part of the panel this afternoon. Clinical trials are my passion, in part because I'm as frustrated as our patients are about the relatively slow advances in our field. So in the last 15 years in the glioblastoma arena, we had 2 new drugs and 1 device approved in the United States. Think about other tumor types with, in some cases, 5, 10, 15, 20 new drugs. So we need to do better. And I'm a firm believer that in order to do that is we need the best science to come to the clinic fast. And the second part is to be innovative in the way we conduct our studies. Dr. Gilbert gave a brilliant talk about the key elements and key designs. Also explained very beautifully why the historic controls are not good enough. So if you just do studies where everyone is treated the same way and we don't have a contemporary control, we are actually losing a lot of time, because if the drug is approved, is proved to be ineffective down the road with the follow-up randomized trial, you have lost a lot of time that you would have been able to gain if you were able to compare from the beginning. And having said that, there are a number of innovative trial designs, what we call adaptive designs, where the study changes real time depending on the observations, what happens in terms of efficacy, toxicity in the study, and also what happens in terms of molecular characteristics in the study that can predict response. The other point I want to make is the issue of access. And I think it's so critical, and Mark shared the numbers. You know, 1 out of 10 glioblastoma patients being enrolled in the study for a disease that we all know it is a true challenge for patients and the family. I would argue if we can double, say 3 times that, we're going to have answers 3 times faster. So a big part has to do with awareness. Second issue is for our patients to ask for trials, to think about trials early. I cannot tell you how many times in my practice I see patients with a new diagnosis of glioblastoma who receive standard of care radiation and temozolomide. Well, it's too late to start a study. When you start the combined modality treatment as part of standard of care, you cannot add an investigational agent. So, as Dr. Gilbert and the other speakers encourage us, think about it. When you first find out that perhaps there is a brain tumor, that's the time to look for trials. So the access issue, I think, is huge also as it pertains to our patients in community areas, community practices, and rural areas. So there might be additional barriers. And this is one of the reasons I very actively support and participate in cooperative group research. Again, this is NCI-funded research and includes clinical trials conducted as part of a group. We're talking about more than 500 sites for the big groups, Alliance and NRG, who do, with physicians who do neuro-oncology trials. So the expertise is there, but the important thing, these are both community-based and they're also academic center-based. So you get the best of both worlds. And I think the community trials that can benefit community patients need to be practical, need to take into consideration the fact that patients sometimes live in remote locations. To do that, it's our responsibility as academic oncologists to work very closely with community oncologists. And as the cooperative group studies have shown again and again and again, and both Terry and Mark showed some examples, the fact that you conduct a study in the community does not take any of the science away. The last point I want to make is that these truly challenging times we're living through, the pandemic, the COVID pandemic, can actually be an answer for all of us as to how we can improve access to clinical trials. Think about things we have never been able to do before, being able to do virtual consults and our patients not having to pay for it out of pocket. The telehealth, the ability to reach out to patients no matter where they are. And a lot of us had to adjust our clinical trial practices, anywhere on, presenting the trial electronically to actually sending an oral drug to where the patient lives, to following up for some of the study visits where it was not necessary to have imaging. So this is, I think, where the patient advocacy is huge. We need your help to convince the regulators that we need to have these visits, virtual visits, as appropriate, reimbursed, and also with FDA to incorporate telehealth in clinical trial conduct in this country, and hopefully all over the world. So thank you so much again for this opportunity.
Thank you so much, Dr. Galanis. I think I'll pass it back and see if we have time for some questions.
Thank you so much. We have time for maybe a couple of questions. So the first one that we have here, Dr. Gilbert, if you can help just direct the questions to the appropriate panel member. The first question we have is on insurance coverage. Will a patient have issues with their insurance coverage down the road if they were on a clinical trial because standard of care wasn't adhered to?
So that's a great question. I think I will ask Jean to handle that question.
Okay. No, I think by law, insurances are not allowed to make decisions based on research, whether you've had research. And most of the trials include the standard of care. So if you were in a trial at diagnosis and your tumor progressed, you would likely then get whatever standard of care you did not receive. So I think that's the answer to that question, if anyone else has feedback.
Dr. Fecci.
Yeah, I would just add that oftentimes clinical trials for the experimental agent is being funded either by a research study or by an industry partner, for instance. And so as Jean brings up correctly, the standard of care portion will be covered by insurance. Insurance companies, as a rule, don't cover experimental therapies usually, except in rare instances. But generally, if someone is conducting a clinical trial, there is funding for that experimental therapy.
Right, and as I mentioned, additional costs that are study specific are typically covered by the clinical trial. Great, thank you.
Thank you so much for sharing that. Another question we have here is asking, what is the physician's responsibility for informing patients when securing their consent prior to joining a clinical trial? What information are they required to disclose to the patient?
Dr. Galanis, would you like to handle that one?
Sure. There are, and this is a wonderful and very important question. So this includes information all the way from why are you asked to participate to what are the side effects associated with this approach. We are asked in the consent form also to give the relative likelihood, the risk of these side effects. So more rare, common, very frequent, and also what are the alternative approaches. We need also there to clarify if we ask that the patient allow us to use tissue, either the brain tumor tissue or other tissues as part of the study and future research. And also that there is a clear explanation as to what part of the care received in the trial is standard of care and what part is experimental, and also the coverage for that.
Thank you so much. This next question is for Donna. Donna, do you mind sharing some advice to patients and families that are wanting to join a clinical trial but might be a little hesitant on the experience, and any advice on kind of sharing that decision-making with your loved ones and your family?
Actually, I would encourage anyone to go onto a clinical trial. Now, for me, I had done the standard of care, and it came to a point where it wasn't working anymore. So I was actually given a chance to be on a clinical trial, and that was delivered by my doctor. So for both of them, I really didn't search. It was just presented to me.
Thank you for sharing some of your experience. So another question we have is asking about Dr. Galanis, this is actually directed towards you. You had talked about one of the issues with clinical trials being awareness. Can you share some ideas on how we can increase that awareness? What are some solutions that you have in mind so that more patients and families know about the clinical trials that are out there?
Yeah. And the forum today and the meeting, I mean, obviously is an opportunity. I would say, first of all, some of my patients, like to at least peruse the clinicaltrial.gov, but I would agree with Dr. Gilbert, that's very difficult to navigate. I would say the advocacy organizations for brain tumor patients have wonderful navigators, and they can help with specific clinical trial questions. And then obviously ask your oncologist, because sometimes patients are a little bit concerned about that. They don't want their oncologist to feel bad. In reality, because we don't have good answers frequently, all of us, we encourage second opinions. And also, if your oncologist says, well, we don't have any clinical trial opportunity, before you start treatment, ask for a referral to a tertiary center or center of excellence where you can have a more extensive discussion. These are some of the ways, but again, the hope is with the cooperative group research that you would not have to travel, that the trial will come to you, as happened with Donna, rather than the other way around. But we have to work on that in parallel, I feel.
Thank you so much. That is all the time that we have for questions for this panel. Thank you all for sharing your insight and advice, and thank you to our attendees for the wonderful questions. I'll go ahead and turn it back to Emily for the rest of the program. Thank you.
Thank you so much, Ambreen. And thank you to each of you as panelists. Wow, what a great session. Truly makes us think we should have had more time for this, and we really wish we would have been able to answer all of your great questions. Thank you all for each of your insight and expertise. We will now proceed with the rest of our program. For those of you who need a quick break, please feel free to do so now. We invite the rest of you to stay on to hear from our researcher, Dr. Kristen Yam from Stanford University. We will be back at 2:25 p.m. Central Time for our next session on holistic management of brain tumor symptoms. Thank you so much.
The title of my talk is Radiogenomic Prediction of Pediatric Medulloblastoma Molecular Subgroup. This was a discovery grant that was awarded in 2018 in memory of Lisa Jean Ga. Medulloblastoma is the most common malignant pediatric brain tumor and poses many challenges due to complex pathology, molecular makeup, cells of origin, as well as image features. In fact, some of these medulloblastoma, even if they look very similar, can behave very differently. For example, on the left is a 3-year-old patient who passed away within a year from medulloblastoma, whereas the patient on the right is a patient who has survived this tumor and now is in college. Molecular studies have unveiled subgroup-specific driver mutations that include previously undiscovered actionable targets with therapeutic implications and have really enhanced the knowledge of these tumors. Looking back at some of these MRI features, we found that on gross visual inspection that certain image features tended to recur with certain molecular subgroups of medulloblastoma. While modern advances in MRI can help interrogate tumor microstructure, physiology, magnetic properties, as well as chemical signatures, there is also pixel-based image features on routine MRI that can be used to mine important digital information. So the motivation of our study was to apply machine learning approaches to MRI-based tumor characterization. Specifically, we wanted to assess for quantitative feature extraction of pediatric medulloblastoma and evaluate machine learning approaches to developing MRI-based models for predicting specific molecular subgroups. An overview of Radiogenomic's approach to predictive modeling of the medulloblastoma subgroups are shown here, including some of the individual steps. Within some of the initial data set of 109 tumors from Stanford, Toronto, and Boston Children's, we developed a computational framework to extract MRI-based radiomic features from tumor segmentation. And an illustration is shown here. Further, we were able to use some of these features as shown here to do predictive modeling, and using support vector machine classifier, we found that edge sharpness and features were the most important features predictive of sonic hedgehog and group 4 medulloblastoma subtype. Now, upon learning about our ongoing ABTA work, more institutions have joined and contributed their data sets so we can get better at predictive modeling. So using a larger data set, we also examined the feasibility of using deep learning approaches. We first trained our architecture to learn different types of posterior fossa tumors, not just medulloblastoma, but also ependymoma, pilocytic tumors, and diffuse intrinsic brainstem tumors. We also used a model to learn how a normal pediatric brain develops over time. And using this different larger data set, we used a 3D classifier deep learning model that can learn to distinguish different medulloblastoma molecular subtypes. With this larger data set, you can see that now the deep learning model can distinguish the Wnt pathway versus the sonic hedgehog or group 3 or 4 medulloblastoma subtypes with a fairly good accuracy. We also developed a 3-way classifier that looks at the Wnt versus sonic hedgehog versus group 3 and 4 medulloblastoma tumors. Our next steps are to combine radiomics and deep learning approaches so we can get even better at distinguishing these tumors so that we can provide more precise tumor characterization for our tumors. We thank the ABTA for this amazing opportunity, and also Edward Lee, Sarah Matnan, Michelle Han, who are our students and postdocs who helped contribute to this, and our collaborators from all over the world. Thank you for your time.
Welcome back. Our co-chair, Jean Arzbaecher, will introduce our next speaker.
Hello again. In this session, you will learn about common brain tumor symptoms during the phases of treatment, as well as complementary approaches and interventions such as cannabis, acupuncture, and other therapies. Presenting is Dr. Roy Stroud. Dr. Stroud is a neurologist, neuro-oncologist, and clinical trialist at the Comprehensive Cancer Center at Wake Forest School of Medicine. His research focuses on developing innovative treatments for brain tumors and new therapies to manage symptoms, prevent complications, and improve the lives of brain tumor patients. An interesting fact about Dr. Stroud is that he has been a beer brewer for the past 15 years, having developed an interest during a biology lab in college. It's too bad that the session is virtual, as maybe he would have brought us some samples. Please welcome Dr. Stroud.
Great, thanks so much, Jean. Really delighted to be here. Thanks to Dr. Gilbert and Jean, both of you, for the invitation to come, and to the ABTA for setting this up. You picked a great fun fact. I would love to be in person and share this opportunity to break some bread and share a drink of any kind. But kudos to the ABTA for continuing this really important event, even despite what COVID is throwing at us. So for the next 30 minutes, we're going to focus on holistic management of brain tumor symptoms. And I feel really privileged to have the opportunity to speak with you about this. I think this is one of the more important, maybe the most important, but certainly one of the more important topics for brain tumor patients, their caregivers, and for we as oncologists. As we go through this talk, there will be 3 things that I really want you to hear and focus on. The first is holistic management, and this is something that we do every day. We're going to talk about acupuncture, we're going to talk about yoga, meditation, massage. But the bedrock of holistic management, taking care of the whole patient, really starts with a good relationship and a strong relationship with your oncologist. And so a lot of the things that we'll talk about, we'll draw some generalities, and I will encourage you to speak with your doctor and your oncologist about how to integrate those into your therapy. The second thing I want you to take away, we're going to talk about alternative and complementary approaches and think about how to integrate those into traditional medical therapies, and we'll talk a lot about that. And the third piece is timing, and I think what you'll hear during the course of this lecture and the next 30 minutes is is maybe not which therapy should I use, but not only which should I use and how and when should I integrate those into my treatment. So we have a tall order of things to cover over the next 30 minutes. I'm going to start with talking about common brain tumor symptoms. We'll cover nausea, sleep dysfunction, fatigue, and cognitive dysfunction, seizures, and symptoms from brain swelling. And we'll think about some of the traditional approaches to managing these. And then we'll shift and talk about alternative, complementary, and holistic treatments and think about how we can integrate the two together to have the best treatment course for our brain tumor patients. We'll talk about supplements and vitamins. We'll talk about cannabis. And then I'll briefly mention acupuncture, yoga, and meditation. Next slide. And I think one of the most important principles to take away from this 30 minutes is this concept of balance. And we think about that when we're thinking holistically with patients. And as providers, this is what we do a lot in the clinic with our patients and look at the benefit of a treatment and the risk. Ideally, we're looking at for treatments, as you see here, that have a high proven chance of benefit and low risk, low chance of causing harm. And a lot of the treatments that we use traditionally in medicine have proven high benefit and low risk, and we like those treatments as providers, and we like those treatments as patients. We look to steer away from treatments that have high risk and low benefit, and a lot of the treatments that we'll end the talk with, the complementary and alternative medicines, fall in the middle. We want to make sure that there is low risk, but the benefit is unknown. And this is where we think about personalizing the decisions for our patients to find those treatments that are at highest likelihood of benefiting the patient with the lowest chance of risk or harm. Next slide. So where are we headed? In the next 15 minutes, the first part of the talk, we'll talk about nausea and how our patients experience nausea and some of the treatments we have. And then we'll talk about sleep dysfunction, fatigue, and neurocognitive dysfunction, often which co-occur and are one of the most common symptoms that brain tumor patients experience. We'll end with seizures and symptoms from brain swelling. Next slide. So nausea, this is an important discussion for all patients with brain tumors, but particularly important for patients with newly diagnosed high-grade brain tumors, metastatic disease, or other types of tumors of the brain. There are many causes of nausea, and you can see here, brain tumors themselves can increase the pressure around the brain and cause nausea. Chemotherapy can induce nausea and vomiting. Infections can cause nausea, urinary tract infections being a common offender. Other medications that patients will take or we may prescribe, other medical conditions can contribute to nausea. And anticipatory nausea is that sense or fear of impending nausea as a result of a treatment or an anxious or stressful situation. And so one of the first things that we as providers and with our patients do is try to uncover what is the cause. How do we work it up? What do we look for? Well, depending on where patients are in their treatment, we think about the need for brain imaging. Do we need to evaluate the tumor and what may be going on in the brain? We evaluate for infection in cases where there may be an infectious risk, and we do a good history to think about other medicines and a physical exam. And the first step is to treat the cause that may underlie, that may result in the development of nausea, and then manage the symptoms for the patients. Next slide. When we think about chemotherapy, one of the biggest fears for my patients and for patients who are starting treatment for a brain tumor is, am I going to throw up and will I have nausea? And this is true across the cancer center. Many of our treatments, our chemotherapy treatments, can contribute to nausea, but not all chemotherapy is created equally. Next slide. As we see here, as oncologists, we divide chemotherapies up into those that are high risk of causing nausea. Greater than 90% of patients will experience nausea or vomiting, moderate, low, and minimal risk. Next slide. And then if you want to advance one further, please. Most of the chemotherapy, as you can see here, that we see on television, that a family member may have experienced with a non-brain tumor malignancy or cancer, has a high risk of nausea. And those are the treatments that I think many of our patients fear and we as providers don't expect in a brain tumor course. The vast majority of brain tumor chemotherapies really fall into this low or minimal risk of causing nausea. Next slide. And if you advance one further, and you can see here a lot of the common treatments that we use in neuro-oncology, both for primary brain tumors and metastatic brain tumors, carmustine, lomustine, temozolomide, bevacizumab we've heard about, as well as vincristine, really fall into this low or minimal risk of causing nausea. So this is usually something that we can see but manage well in our patients. Next slide. So what are those treatments? We have a lot of conventional medical therapies to address nausea. And here's a list, and you can see it's a long list, a lot of medicines that work differently. And in general, we categorize those into 3 groups. Advance forward. This first group are common medicines that we use to prevent nausea from happening. They're commonly prescribed along with chemotherapy, ondansetron or Zofran being one that's frequently used in neuro-oncology practices, but also Kytril and the Sancuso patch. And those are medicines that we commonly start with. Next slide. This second group of medicines are typically added to those for nausea that may break through for patients who are on treatment. And these are excellent medicines that have high benefit and low chance of risk. This last group of medicines, Ativan, Decadron, and Marinol, which we'll talk about later in the talk, have substantial benefit but can have some risk in certain patients. And so we use each of these 3 phases or steps in treating nausea, individualizing it for the patient. And we have a lot of good treatments to address nausea in our patients. Next slide. How about sleep dysfunction? And we'll really talk about sleep dysfunction in combination with cancer and chemotherapy-induced, radiation-induced fatigue, as well as neurocognitive dysfunction. This is one of the most common symptom complexes, symptoms that we see in brain tumor patients. Somewhere around 60 to 80% of brain tumor patients will experience excessive daytime sleepiness. It is extremely common in this patient population, as many of you all have experienced and know. In addition, we see insomnia as a result of corticosteroids or other causes, and not sleeping at night worsens daytime sleepiness during the day. There are a number of causes of this, and we'll look at this symptom complex in more detail on the next slide, but we think about treatment-associated fatigue, corticosteroids, which are incredibly commonly used in brain tumor patients and contribute to this symptom, and obstructive sleep apnea. Next slide. So how do we think about these symptoms in brain tumor patients? We really see all 3 symptoms of sleep dysfunction, fatigue, and neurocognitive dysfunction in brain tumor patients. The sleep disturbance contributes to fatigue, causes our patients to be fatigued. That fatigue can cause and contribute to neurocognitive dysfunction, and we see a cycle where these symptoms play into one another. Next slide. In addition, we often see that patients who aren't sleeping well, who are more fatigued, and are having problems with their thinking, have worse quality of life and more depression. And so as an oncologist, as we look to dissect this and manage this for patients, sometimes we're talking about fatigue, but managing the sleep disturbance. And improving the sleep disturbance will help patients with fatigue. Sometimes we're seeing and feeling, and caregivers are witnessing depression and mood dysfunction. And as oncologists, we're looking to manage the sleep dysfunction and fatigue that may be contributing to that. So as oncologists, we really ask for all 3 of these symptoms. How are our patients sleeping? What are they experiencing fatigue, and how is their memory or neurocognitive function working? And we look to manage these equally. Next slide. In working up this symptom complex, sleep problems, fatigue dysfunction, and neurocognitive dysfunction, there's a number of medical conditions that can contribute to this that we see in brain tumor patients. We think about the thyroid. Low thyroid function can contribute to all 3 of these symptoms and is important to evaluate in brain tumor patients. Both radiation and chemotherapy can contribute to problems with thyroid function. We think about specific vitamin levels. Low vitamin B12, which is one of the vitamins that's important in nerve health and nerve function, we can see low in brain tumor patients, can be deficient, as well as folate, vitamin D deficiency, and anemia or low hemoglobin. And each of those we evaluate in patients who are experiencing these symptoms. We think about, is there enough steroid? Many of our patients are on steroids, but the body needs to make its own steroid. And sometimes after long-term steroid therapy, patients' bodies don't remember to make that stress hormone, that stress steroid, and we need to give it back. Low testosterone is something that's important for men, and we think about, could patients be suffering from sleep apnea? So this workup is important in first evaluating each of these symptoms for our patients. Next slide. What kind of treatments do we have? We'll talk about some complementary and alternative approaches to managing sleep dysfunction, fatigue, and neurocognitive dysfunction, but there are a number of traditional medical approaches that we have that are very effective in managing each of these symptoms. With fatigue, Ritalin, which is a stimulant, can be effective in some patients. We need to think about the seizure risk of that medicine, but is an important thing for providers to remember and for patients to ask about. Provigil, Nuvigil are wakefulness promoting agents that keep patients awake during the day and help to address that excessive daytime sleepiness. And amantadine is a medicine that we can sometimes use in certain settings. With sleep, we think about sleep studies and CPAP to manage obstructive sleep apnea. Melatonin, our patients can be deficient in melatonin, and there are some temporary sleep aids that can be helpful for getting patients through a difficult time in treatment or a difficult time in their cancer course. And for neurocognitive dysfunction, we work closely with many of our neuropsychologists and think about cognitive rehab. And actually, physical activity is one of the best preventative and treatment mechanisms for patients suffering from neurocognitive loss and memory dysfunction. The third symptom we'll talk about is seizures. This is incredibly common. 50 to 70% of brain tumor patients will experience a seizure at some point during their course. Patients and providers, when we see a seizure or when a patient suffers a seizure, the thing we think about is this the tumor or is this not the tumor? And about half of the time with a breakthrough seizure, it is from the tumor. There is underlying tumor progression that's contributed to that manifestation of seizure, and about half the time it's not. So when we think about breakthrough seizures, as oncologists and neuro-oncologists, the 5 things we think about and ask our patients about and want to hear from you about are, is there a missed seizure medication that could have caused or contributed to the seizure? Is there a new medication the patient could be taking that would cause the brain to be more likely to seize? And I've put 2 here, tramadol or bupropion, which are common medicines used in brain tumor patients. Is there an electrolyte imbalance, an infection, or has the patient been missing sleep? And missing sleep stresses us all out, it stresses the brain out and can contribute to seizures. Next slide. When I think about a seizure, I think about it as a fire on the brain, and there's really 2 ways that we treat that fire. The first, if you advance forward, is to contain the fire, and those are the rocks that we put around a fire to prevent it from spreading. And we think about anti-epileptics and anti-seizure medicines to contain the fire and manage the seizure that has occurred or may occur. Here are a common list of seizure medicines that we use, and we think about balancing the most effective seizure medicine with the one that's the least likely to cause side effects for the patient. The second way to manage the seizure, if you advance forward, is to put the fire out. And those are treatments to treat the underlying tumor, the swelling on the brain, or the underlying problem that's contributing to that seizure. We think about steroids, radiation, and chemotherapy. Treating the tumor can help to manage the patient's seizure. Bevacizumab or Avastin, you've heard a little earlier today, as well as surgery, which you heard yesterday from Dr. Fetchy. Next slide. And the last symptom that we tend to see frequently in brain tumor patients that we look for both traditional and non-traditional therapies for is brain swelling. We know that brain swelling is experienced in the vast majority of brain tumor patients, both patients with primary gliomas as well as metastatic tumors. When tumors grow, active tumors irritate the brain, and this causes swelling on the brain that we need to manage. When brain tumors die, the death of the brain tumor also irritates the brain, and the brain can swell, and we can see brain swelling and manage those symptoms. The symptoms that we think about in patients with brain tumors are the same that we think about and experience in stroke patients. And you can see here with the mnemonic FAST, face drooping, arm weakness, speech difficulty. And in stroke patients, that's the time to call 911. For brain tumor patients, that's the time to call your neuro-oncologist. In brain tumor patients, we also counsel you and like to hear about headache that doesn't go away, nausea, vomiting that doesn't go away, and those are symptoms that can indicate brain swelling. When I'm sitting down with my patients, I think one of the things that we need to remember is that everyone can have a bad day, and a bad day is not a brain tumor growth day. It's just a bad day. We're going to get through it and wait for the next day. But 3 bad days is a trend, and that's where 3 bad days of headache or nausea, vomiting, face droop, arm weakness, or speech difficulty could indicate something going on in the brain, like brain swelling, that we would need to further evaluate and manage. And that's really a time to call your oncologist for further assessment. Next slide. Steroids is one of the most common medicines that we use to treat brain swelling, and there's a lot of things that we think about as oncologists and as patients in managing patients who are on steroids. Dexamethasone or Decadron is the preferred steroid. There are a lot of steroids out there. This tends to be the most potent for the brain and the least likely to cause other side effects, though we can run into those. Our typical doses range from anywhere from 1 milligram a day to 16 milligrams a day. The body makes its own steroid, about 0.75 milligrams of Decadron a day. Steroid lasts in the body for 24 hours. So if you take a dose, it lasts for about 24 hours, and it's usually 3 to 5 days before the full effect of the steroid will wear off. We often divide the dose over the course of the day in 2 doses or 3 doses taken in the day to prevent side effects. And we really work closely with our patients and want to hear from our patients to try and find the lowest possible dose. Next slide. One of the things that both providers and patients know of the steroids we use for brain tumors is they are not the muscle building steroids. As you can see here, they're actually the muscle losing or muscle wasting steroids, and there's a number of side effects that we can see in patients on steroids. They are the most effective medicine to treat brain swelling, but we can see mood changes, insomnia, weight gain. They're actually muscle losing steroids. They can cause muscle loss in the upper portion of the legs, and patients have difficulty walking or standing up or rising up out of a chair or walking upstairs. Leg swelling, stomach ulcers, increased blood sugar, and immune suppression, a number of symptoms that we can see as a result of steroids. So we really work with patients to identify the lowest possible dose. Next slide. So in conclusion of the first part of this talk, what are the common brain tumor symptoms that we see? Nausea, fatigue, sleep, neurocognitive dysfunction, seizures, and brain swelling. And the things I'd like for you to take away from this is nausea is common and is often well controlled in brain tumor patients. Fatigue, sleep, neurocognitive dysfunction are also common and should be evaluated by the physician looking at the interplay between each of those three symptoms. Seizures often occur but don't necessarily mean the tumor is growing, and brain swelling is really best treated with corticosteroids, one of the most effective treatments we have for brain swelling, but we work to find the lowest effective dose for both the patient and the provider. Next slide. So now let's shift and talk about some of the complementary and alternative treatments that we have to manage these same symptoms. We're going to focus on 4. We'll talk about supplements, vitamins, and nutritional therapy. I'll spend a little bit of time talking about cannabis and what we know about cannabis currently, what we don't know, and where we're headed with that treatment. We'll spend a brief time talking about acupuncture and how that fits into the care of both brain tumor and general cancer patients. And then I'll briefly mention yoga, meditation, mindfulness, massage, virtual reality, and how we're thinking about those in neuro-oncology. Next slide. So I think first it's important to establish some definitions. Not all of these words mean the same thing. A complementary therapy is a therapy that we use alongside the traditional medical treatment. So complementary therapy means you use it alongside your conventional medical treatment. It may help you feel better or cope with your cancer or the treatment. An alternative therapy is something that's used instead of medical treatment. We really look to avoid these in neuro-oncology and are really speaking most with our patients about this third bullet, and that's integrative therapy. Integrative treatments, integrative therapies are used to describe those treatments that we combine conventional medical therapy with complementary approaches. That's something we heard last night from Maria Menounos' great talk, and I think this is what we'll hear over the course of the rest of our discussion, is we're really looking to integrate the treatments we just discussed with some of the complementary and integrative approaches that I'll mention next. Next slide. So today let's focus on these 4 complementary alternative treatments: supplements, vitamins, cannabis, acupuncture, yoga, meditation, and mindfulness. Next slide. So let's start with vitamins and supplements. There's a lot out there. We tend to categorize vitamins and supplements in 2 categories. There are multivitamins that we use for our general health. Take one a day, and it's not specifically treating a condition, it's for our overall health. And then there are single ingredient vitamins, and you see some of those here. And patients and providers use those to treat medical conditions. Vitamin D, vitamin C, ginger, garlic, green tea, turmeric, beta-carotene, the list goes on and on. Patients will frequently bring these to me and say, Dr. Stroud, have you seen this latest vitamin, and can you research it and let me know what you're thinking? And we like to hear and see that from our patients. Next slide. We're all using these therapies, and this is one of many studies looking at how commonly vitamins and supplements are used in the general population. 3/4 of Americans, North Americans, but I think you'd see this all through the world, are using a dietary supplement. And I think some sobering numbers: 77 report using a single ingredient vitamin, not just a multivitamin, for their general health. 33 are using this dietary supplement in place of a prescription drug, and only 60% of us are reporting that to our doctor. And that's one of the things that worries neuro-oncologists and oncologists alike, is we want to know what our patients are taking. We want to understand the benefit for those patients. We want to counsel against the risk. And so I'd encourage you really to speak with your doctor about the things that you're interested in taking and researching as you see them. Next slide. The same is true in brain tumor patients. We see 77% of brain tumor patients are reporting use of some type of vitamin or supplement or complementary therapy. Multivitamin use is the most common, but 22% of patients are using antioxidants. 7% of patients are using a macrobiotic diet, changing their diet to treat their tumor. And I think really importantly, and something we can talk about in the question answer part, is patients are doing this to take charge of their treatment. A lot of the treatments that we deliver, the clinical trials that we all just discussed in the last session, are delivered to patients, and this is an opportunity for patients to take charge of their treatment. I think concerningly, the average cost of these can be greater than $100 a month for 20% of our patients, and 74% report that their physicians are unaware. Next slide. And not all vitamins and supplements or antioxidants are safe in cancer patients. So I want to walk through some concerns with antioxidants and their timing and treatment and speak specifically about radiation. So let's think first with how radiation works. Advance forward. So therapeutic radiation, the goal is to treat a cancer cell, to kill a cancer cell. And part of what that does, advance forward, is direct damage to the DNA. And about 15% of what radiation does is damage the DNA. Next slide. But most of the way that radiation works is it creates oxidants, as you can see here. And that's actually 85% of what radiation does to kill cancer is through creating oxidants, or what we call reactive oxygen species. For patients who are interested in taking antioxidants, we worry that those treatments may make radiation less effective because we're looking to create oxidants. So we really think about antioxidants in two phases. Before patients have a cancer, that's something that may be a good idea, and we're looking for ongoing studies to understand how to integrate that for the general population. After patients have cancer, we need to be very careful with the use of antioxidants and think about when to initiate those therapies. And really after patients have completed therapy is when I consider that for my patients. Next slide. And I think this is true, and we can advance forward through the end of this slide. This is true for both patients with primary gliomas as well as brain metastases, both of whom undergo radiation therapy. Next slide. What do we think about diets? I don't have time to cover diets. Honestly, we could have a half-day workshop on the role of dietary therapies in glioma patients. There's a lot of interest in this. A lot of this is built around a concept from over 50 years ago called the Warburg effect, and you can advance forward. And this is a phenomenon that we know that cancer cells have an increased affinity for glucose. They like glucose. They live on glucose. And we use that therapeutically and diagnostically throughout the cancer center to diagnose cancers. And you can see here a PET scan has lit up a lung cancer in the brain. PET scans utilize glucose, radio-labeled glucose, to light up cancers. And so we know that there is a glucose affinity. What is less clear is whether we can starve cancers of that glucose. And as you can see here, we just don't know at today's stage what the optimal diet is for brain tumor patients. We have a lot of our patients who do very well with a standard North American or American diet. And so standard diets are perfectly good and helpful for brain tumor patients. We hear a lot about the ketogenic diet, but in neurology, in using this type of diet for adults with epilepsy, it can be very difficult for patients to continue lifelong. So I've made that red. The ketogenic diet, a strict ketogenic diet, is really very difficult for most adults to do. We're looking at alternatives like the modified Atkins diet or intermittent fasting. It looks like the modified Atkins diet works very well for epilepsy patients, patients with seizures. We don't know what to do with intermittent fasting, so we have a slow down yellow. And there are a number of other diets that we think about. And I think right now it's just unclear what the right diet is for patients. I think the diet that patients enter their treatment on is the ones that they should consider, and this is an important thing to talk to your oncologist about and potentially seek a dietitian counseling. Move forward. Next slide. Thank you. So in conclusions about vitamin supplements and dietary therapies, I encourage all my patients to discuss vitamins and supplements that they're interested in with me, to be aware of supplements that contain antioxidants. That's often what I'm researching when evaluating these treatments. Be aware that antioxidants can have negative consequences on active treatment. If you want to take an antioxidant, think about when the right time is, and potentially after treatment has completed. We all eat, and personalizing your diet to meet your needs is an important part of your cancer treatment. Next slide. So next, let's talk about cannabis. There's a lot of interest, I think, and excitement about cannabis in the brain tumor population, both for patients as well as caregivers, and as providers and clinical trialists. So let's break this down. Cannabis is actually two compounds. It's composed of both THC and CBD. You put both of those things together, and this generates the compound that we call cannabis or marijuana. THC is the component that has a psychoactive property, the euphoria that patients will experience or people will experience from cannabis. CBD does not. There's no psychoactive properties. Both of these can be used for medical or medicinal purposes, but they act differently. And when we combine them together, they have different actions. And so one of the things that we'll learn about cannabis in the current stage is we're still defining what's the right dose of THC, what's the right dose of CBD, how do we put these together so that we have a high benefit treatment with low likelihood of risk. Next slide. So what do we know about cannabis today? Well, this is used. Cannabis-based treatments are used to treat patients with FDA-approved agents today in both the cancer center and throughout the hospital. Dronabinol is a medicine I mentioned earlier in the talk, which is approved to treat nausea and vomiting in patients undergoing chemotherapy and for weight loss with patients with HIV. Dronabinol is a THC-based product, so we have THC-based products that are used in the hospital on a daily basis to treat patients with nausea, vomiting, and weight loss. Epidiolex is a medicine that is approved for treating seizures in a number of children with refractory seizure disorders. Epidiolex is a CBD-based product. It's very different from dronabinol or THC, and again, it's used every day in the neurology clinic to manage patients with seizures. So we use these medicines, and we know these medicines, and have both THC and CBD products that are used to manage patients with these conditions. Next slide. What we don't know is how to best integrate these therapies for patients with brain tumors. I think right now we have most data to support symptom management in the use of cannabis-based products for brain tumor patients. There's some data to suggest that this can be used for nausea with chemotherapy and perhaps other causes of nausea. There's data to support its use in pain, perhaps in seizure control and anxiety, as I've just mentioned to you. What we don't know is how this medicine will work for controlling brain tumors, for tumor control. Will it work for controlling tumors alone? How will it interact with radiation and chemotherapy? And as you can see from this graph, there's a lot of interest and excitement about the use of cannabinoids for managing both tumor growth invasion and glioma stem cells. But it's a complex situation that continues to be studied and really requires more study before we understand the true benefit for patients and ensure that there is low risk. Next slide. So what do I counsel my patients? I think CBD and cannabis-based products are currently safe and effective for treating certain children with epilepsy as well as patients who are experiencing nausea and vomiting from chemotherapy. These products are continuing to be studied for treating nausea, pain, stimulating appetite, and treating fatigue in other patients. And while there's interest in the anti-cancer effects of cannabis, further study is really needed before they're ready for prime time for brain tumor patients. Next slide. So we're going to end with a brief discussion of acupuncture, yoga, meditation, and mindfulness. And acupuncture is a needle-based therapy. It's a biofeedback therapy. The way we act is based on what the body senses. And this is a biofeedback mechanism of changing what the body senses to change how it acts and feels. Next slide. There's been a lot of interest over time in looking at acupuncture for a number of conditions and symptoms that cancer patients and brain tumor patients experience. Chemotherapy-induced nausea, vomiting. There's a lot of data on the use in cancer pain and peripheral neuropathy, as well as hot flashes. And these are symptoms that if brain tumor patients or any cancer patient is experiencing, I think there's a lot of benefit and low risk for acupuncture. What we don't know is how acupuncture works for other conditions, for anxiety, for pain, for headaches, for seizures, and for other symptoms that our brain tumor patients experience. And I think insurance coverage is a very important thing that we can deal with for patients who are interested in acupuncture, and it's something that we can address in the Q&A portion. Next slide. And then finally, we're looking at a number of other alternative and complementary therapies for patients with brain tumors. Yoga, meditation, mindfulness, we heard about from, again, Maria Menounos' talk and discussion yesterday, as well as even virtual reality. And I think there's a lot of promise for these in managing a number of brain tumor symptoms, but scanxiety is something that for patients and providers, we need help with. And many of you and many of our patients and caregivers understand what this word is. It's that apprehension, uneasiness, that intense anxiety, inability to sleep the night before getting an MRI scan or a scan to evaluate the cancer. The last time I gave this talk, we talked about scanxiety and some of the treatments used for that, and I was pointed towards an excellent blog from Adam Bessie, and you can see that in the slide here, a brain tumor survivor who really very eloquently describes what it's like to be a patient, as many of you know, and experiencing this. I think there's a lot of potential benefit for things like yoga, meditation. We're doing a virtual reality study here at Wake Forest evaluating this for this symptom of scanxiety as well as infusional anxiety, and something we're very interested in but is not ready for prime time at this point in time. Next slide. So again, I'm going to end with some myths and common questions that I experience as a neuro-oncologist for my brain tumor patients. And I'm excited to hear questions that you have. Next slide. So one of the common questions that I get is, does my doctor want me to just do their treatments and not worry with any of these other treatments? And I think the answer here is no. All of these treatments are our treatments. And this gets back to what holistic medicine is. It starts with the team, the patient provider team, and we're looking to work together to identify those things that will help patients do better. Those treatments that are high benefit and low risk. I think, you know, in that 15 and 30-minute visit, and again, we heard from, again, Maria Menounos' talk last night, the breast cancer expert that was on her show and really lamented over the difficulty in covering all the things that need to be covered in a short clinic visit. And we experience in this in neuro-oncology. We're reviewing the scan and looking at labs, managing symptoms and determining what the treatment will be. And we want and need our patients to ask the questions that are important to them. And if there are treatments, any that we've gone over, those that we haven't, that are important for you, I think this is the time to bring it up. Next slide. If it's important, won't my doctor mention it? Well, we don't have time to mention all the things that are really important to both us and our cancer patients. And so I ask my patients and love to hear from them about the treatments that are important for them. And it really opens up an opportunity to talk about what we know about some of these treatments, what the benefit may be, what the risk is, and how we should integrate it into their care. Next slide. And the last few questions, if it's not legal, will I get my doctor in trouble? Nope, everything that happens in the visit is confidential. So the things that are discussed by the patient as well as by the provider are sacred and are held in protection by the Hippocratic Oath from the physician side and by legal regulations from the patient side. We want to know what you're taking so we can evaluate how it interacts with your treatment. Next slide. Will my doctor reduce my cancer treatment if I complain of a side effect? I think this is a critically important question and is something that a lot of my patients I know struggle with, and you may have as well. We need to hear about side effects. Making a patient more sick will not help them be healthy in any respect, including from their cancer treatment. We want to know and need to know the side effects or the symptoms that patients are experiencing so that we can address those. And I think as an oncologist, we really have two jobs. And our first job is to figure out what is the best treatment for this patient. And that usually takes the first couple of visits. Our job after that is to get the patient through the treatment, doing as well as they possibly can. And that's what oncologists love to do. And to do that, we need to know what symptoms you're experiencing and to work together to manage those. So we want to hear these things. Next slide. And the last question I commonly hear is, shouldn't I just live with these symptoms so that my cancer can be treated? And I think this is really important. Improving the symptoms that brain tumor patients are experiencing helps them get through treatment and beyond treatment much better. And so this is something where we really want to work together to manage these symptoms using either traditional medical treatments that work well or some of the complementary and alternative treatments, integrating those together as we've discussed today. So with that, I think that's my last question, and I'm happy to open it up and answer questions that you all have.
Thank you so much, Dr. Stroud. Just as a reminder again, if you do have questions, please type and submit it using the Q&A box at the bottom of your control panel, and we'll answer questions as time allows. So Dr. Stroud, one of the first questions we have here from our attendee is asking, when you spoke about treatment fatigue, is there, or do you make a differentiation between physical fatigue and mental fatigue?
Yeah, this is a great question. I think we see both. A lot of our treatments, and particularly chemotherapeutic treatments, as well as radiation, can cause physical fatigue. And when I speak with patients about this, I usually discuss it. We all normally have a full tank of gas, and by the time we get to the end of the day, the tank of gas is gone. I think a lot of our brain tumor patients, as they're going through treatment or after treatment, they start with a half a tank of gas, and so they just get to the empty sooner in the day, and that's really physical fatigue that patients are experiencing and we look to address. Mental fatigue we also see. In patients who are physically fatigued, I think you see mental fatigue that causes memory problems and problems with thinking and that neurocognitive dysfunction, and that's really where that overlap happens. Sometimes addressing the physical fatigue can improve mental function, how our patients are thinking and functioning, but sometimes that needs to be addressed differently. And I think this question and this person brings up a really good example of how fatigue and sleep problems and neurocognition all interact. And we really look to treat all three when we see one of those symptoms.
Great, thank you for sharing and clarifying that. Are you able to share a little more information about the virtual reality study that you mentioned? What exactly does that pertain? What are patients looking at and how does that work?
Yeah, this is a great question. The study we're doing here is looking at use of virtual reality during the infusion to help support patients during a prolonged infusion in the cancer center. I know other folks are looking at using virtual reality around the time of a scan. While you're in the waiting room for the MRI, perhaps while you're watching the MRI, and then after the MRI, many patients experience this intense anxiety that can be debilitating before, during, and after that scan. And so these virtual reality programs help to trick the brain, to engage the brain, to think about other things besides the anxiety that the patients may be experiencing. It would be great now that we're looking at virtual platforms to be able to incorporate this at home, prior to the visit. And I think the sky may be the limit moving forward as technology catches up to what our patients need and as providers we're interested in.
That's wonderful. Really exciting to hear that. Now, some vitamins and supplements, they might interfere with each other. Can you share with our audience a good resource that they can turn to find more information or look up what are the right vitamins and supplements to take?
Yeah, this is an excellent question. There are a lot of resources out there. I would look to your oncologist or neuro-oncologist as a primary resource. I think we need to know what you're interested in taking. I frequently will work with my pharmacists. We have a large pharmacy department, as most large institutions do, as well as dietitians, looking at how medications interact. Whenever we write any chemotherapy, oral or IV chemotherapy, there is a comprehensive medication interaction check that occurs before the patient gets that medicine. And that's what our pharmacists do. We rely on them, and they're an important part of the team. I think for vitamins, supplements, and other botanicals, nutritional therapies, we want to do the same thing. And so I would lean on and rely on your oncologist as a resource and use those resources that are available to them and at your facility for additional guidance.
Thank you for that advice. During your talk, you talked a lot about cancer and malignant brain tumors. Is what you mentioned in terms of symptom management, both holistically and standard of care methods, is it applicable to benign brain tumors as well?
Yeah, I think all the things that we talked about are applicable to benign brain tumors, malignant brain tumors, primary brain tumors, brain metastases. In fact, some of the things we talked about are relevant to neurology patients who don't have a brain tumor. A lot of the symptoms we discussed, brain swelling, problems with seizures are experienced from patients who have any type of problem on the brain, benign brain tumor or malignant brain tumor. And the same goes for how we evaluate those, the things we're looking for in patients, and our treatments. Great question.
Thank you so much for sharing that. What advice do you have for patients to help them avoid, there's so much information on the internet and some of it can be fake, predators on sites selling magic cures, for example. What advice do you have for patients to help them avoid that and kind of be able to pick through the weeds and avoid the information that's fake and not true?
This is a tough question. And we all experience this, not only for medical purposes, but when we're looking up anything on the web these days, what can you trust and what can you not trust? I encourage patients to look on the web and to ask family members and friends about things they're interested in. If it's important to you, if you value it, I want you to look it up. And then I'd love for you to bring that information into me. I ask patients to bring it into me so that I can review that with them in the clinic visit. And I would do the same with your neuro-oncologist. That's what we do. It's why we do what we do. It's why we went into oncology, is to work with patients with these things. So bring that information to us, and we can help sort through, is this something that makes sense? Is this something that we delay? Now is not the right time to do this? Or is this just something that doesn't make sense at all, that we don't need to spend time worrying about?
Thank you so much. I think we have time for maybe one more question. You briefly touched on this when you're talking about acupuncture. One of our attendees is curious and wants to know, is acupuncture in general, is it covered by insurance?
Great question. It can be and it cannot. So for some indications, hot flashes in breast cancer patients is a good example. Many insurance providers will cover acupuncture. Certain pain and chemotherapy-induced nausea, vomiting, we can see coverage for acupuncture. There are many times, many diagnoses, many indications that acupuncture is not covered for by insurance. And not infrequently, I'll have a patient who just can't get acupuncture because of the expense. We always want to ask, and so if this is important for you, that's something where we can talk with your insurance. Our Center for Integrative Medicine does a good job at evaluating this for patients. So I think it is something patients can run into. The key is to ask and to find out.
All right, thank you so much, Dr. Stroud. That is all the time that we have for questions for this session. Thank you again for your time, and I'll go ahead and turn it back to Emily.
Thank you so much, Dr. Stroud. What a valuable session, and I truly appreciate you sharing with us about the holistic approach to the management of brain tumor symptoms. I hope each of you as attendees grab some golden nuggets from this session and are able to apply it to your everyday lives. For those of you who need a break, please take this opportunity to stand up and stretch your legs. We are almost through with our afternoon session, but we do invite you to stay on to hear from our researcher, Li Wang from Monash University, and we will be back here for our next session at 3:15 p.m. Central Time for Caring for the Caregiver. Thank you so much.
My name is Li Wang. I'm from Monash University, Australia. Today is my honor to share with you our work on investigation of telomere maintenance mechanism in ATRX mutant glioma. This study was awarded last year as Discovery Grant and is sponsored by the Bradley Benton Davis Foundation. This is us. We are from Australia, Melbourne, Australia. This is my team. And as you can see here, this is Maheshi Udugama, who is driving the project. So today I'm going to talk to you about telomere, which is a structure that is important for maintaining our DNA and maintaining the chromosome from being damaged. And you can imagine telomere like the plastic tip at the end of shoelace, which is important for protecting from the shoelace from being damaged. Telomere DNA has to be maintained at certain length. In human cells, telomere shorten over time as the cell multiply and grow. And this loss of DNA is a cause for cell mortality. In cancer cells, they obviously acquire the capacity to evade telomere shortening, therefore they gain cell immortality. How do cancer cells do this? How do brain cancer cells do this? Brain cancer cells can do this by turning on a mechanism we call alternative lengthening of telomere, ALT, and this is used in 50% of brain cancers. Our team studied how ALT is turned on in brain cancers and to acquire cell immortality. So DNA sequencing study in the last few years have identified two key mutations in brain cancer that use ALT, H3.3 histone and ATRX, which is the chaperone for H3.3. These genes are mutated highly in pediatric brain cancers. So what is histone? Histone H3.3, you can imagine it like a tool, and ATRX, the chaperone, is the builder, which is important in packaging and organizing our DNA with the help of the histone H3.3 to organize the DNA into patterns, and this is absolutely important for cell function. The same for telomeres. It has to be organized by with the help of H3.3 by ATRX so that the telomere can be fully functional. But in brain cancer, mutation of H3.3 and ATRX will cause telomere to be defective, and this is a reason why brain cancers can form. Our aim is to study how mutation in H3.3 ATRX turn out in brain cancers and to identify new treatments for brain cancers. To do this, we built cell model with H3.3 and ATRX mutation to investigate how ALT is turned on with the aim to identify new protein for cell survival in these cancers. To achieve our aim with the funding from ABTA, we have been successful in turning on ALT in our cell model. Now we are ready for the next phase of study, which is to define how ALT is turned on and to identify factors important for this process. To do this, we'll be using highly advanced protein labeling system and analysis, and then we will be able to label all the proteins that are important in turning on ALT in brain cancers. In addition to using this system, we will also be using highly advanced genomic analysis, which involve DNA sequencing to study how problems in DNA packaging and organization can be caused by mutation in H3.3 and ATRX mutations. So the outcome from our study, we believe we will be able to uncover key processes linked to ALT and development of brain cancers. This new knowledge will help us in the future, not just to understand how brain cancer form, but to facilitate future development on new treatment targets. For this, I want to thank you for your enormous support for our work. And in the near future, we hope to be able to share with you more of the outcome from the study. And meanwhile, please stay safe and look after yourself. Thank you.
Welcome back. We invite our co-chair, Dr. Mark Gilbert, to introduce our next speaker.
Thank you, Emily. Hello, as everyone knows, a brain tumor diagnosis is a life-changing event, not only for the patient, but also for family members. And this session will explore the many roles of caregivers and identify strategies and resources to facilitate the process of caregiving. It's my great honor to introduce, once again, the conference co-chair, Jean Arzbaecher, an advanced practice nurse at the University of Illinois at Chicago. As many of you know, Jean has facilitated one of the largest brain tumor support groups in the southwest suburbs of Chicago for the last 11 years. A fun fact, Jean is an avid Cubs fan, and after the long wait, states it was well worth it to be able to cheer them on to a World Series win. So Jean, please.
Hi, thank you, Dr. Gilbert, and welcome everyone. I'm going to talk about caring for the caregivers. I think there's probably some survivors out here, but you know, I'm going to talk about caring for the caregivers. I feel like you are unspoken heroes that we don't spend enough attention with, and I'm going to try to help navigate how to be a caregiver. Next. I have nothing to disclose. Next. First, I want everyone to stop what you're doing and give yourself a hand, and I'm going to give you a hand too. You're doing a great job. If there's survivors out there, please give a hand to your caregivers. Us healthcare workers, we need to give a hand because you are the reason that the survivors are surviving. Next. I love this analogy, and I got this from Paul Van Ryn, who you will meet in the patient caregiver panel, which is next. And Paul is married to Donna, who you met in the research panel. But he describes the survivor caregiver relationship as a dance. He says it's give and take, lead and follow, move together while moving in different directions, stay in contact while adjusting roles and distance between you. Sometimes caregivers need to take the lead, and sometimes caregivers need to let the survivor take the lead if they can handle it. So thank you, Paul. That's very thoughtful. Next. So I'm going to talk about some strategies and resources for success in caregiving. I'm going to talk about understanding and embracing the caregiver role, understanding symptoms and side effects common in brain tumors, use problem-solving approaches, taking care of yourself, and mobilizing resources. Next. So why is it challenging to be a caregiver, and why is it challenging in particular to be a caregiver of someone with a brain tumor? Next. Caregivers have many roles. Sometimes people in my support group say, well, I'm not really a caregiver because she goes to work every day, or I'm not really a caregiver, they don't need, they don't need any help. But just because the survivor doesn't need care in the moment, you are still a caregiver. You're a patient advocate, so you advocate both with the healthcare team and with other family members and with insurances and other many roles of advocate. A financial manager, managing the expense of having a brain tumor, as well as the finances in the family that maybe you've had to take over. A communicator, both with the healthcare team and your family. A medical researcher, we've talked about that, the need to always be on top of what's going on in clinical research and what different things may be available to your loved one. Some people describe it as a babysitter or handler. I have a patient who says, oh, my handler is here. Just, making sure that everything gets done that needs to get done. It can become a full-time job. Next. So how do roles change over time? The responsibilities often change after the diagnosis. So we did a study that looked at long-term survivors of brain tumors, and what we found was when the diagnosis happens, that many roles changed and reverted to the other person, to the caregiver. Examples are finances. For instance, someone might have difficulty balancing the checkbook or paying bills, so you might have to take over that. Shopping, cooking, driving the children, etc. The level of caregiving fluctuates with situations. So there's minimal caregiving, and that's what I talked about before. You're just always on the radar. Caregivers describe they're always on the radar. I just want to make sure they're doing okay. So that might just be checking in on them while they're working, just making sure they, had their lunch, have been up and walking around, took their medication, etc. Intermediate is when someone might need reminders about taking medications, reminders about appointments, basic self-care assistance. Maybe they have some weakness and need a little bit of help dressing, cooking, etc. And then maximal caregiving is around-the-clock care and supervision. Next. So being an advocate, it's probably the most important roles of being a caregiver, and it involves understanding the medical team and their roles and seeking opinions when indicated. Involve the survivor as much as possible. We're going to talk about that a little more, but explaining that you're the advocate and making sure that they are part of all discussions. Sometimes people come into my clinic and the caregiver immediately starts asking questions, and sometimes the survivor gets frustrated. So allow the survivor to get their questions answered and their concerns addressed before your own. Exploring treatment options, and then communicating on behalf of the survivor, communicating with friends and family, with the medical team. So it's important to establish some type of system of communicating with both. Frequently people say after they leave an appointment, they're expected to call 25 people and tell them what happened in the appointment. So coming up with some type of system where you can communicate with all your loved ones and you don't have to take the time to make all those phone calls. Next. So you need to embrace the caregiver role. Even though it's something you didn't choose to do, it's something that you have. So how can you embrace that role? Number one is day-to-day management. So be proactive. Plan your day, plan your week, plan your month. Establish a daily routine. People with brain tumors, it's very important for them to be in a routine in order to decrease the stress of life. Some people have said since the COVID has happened that it's a little easier now because there's a routine. We're all at home and things are quiet and there's not a lot going on. Keep a master calendar. I say put a big, dry erase calendar in your kitchen and make sure that every appointment is written in there. That way everyone knows what's going on in the calendar and everyone knows what they're going to need help with. And then record keeping. I think Maria Menounos talked about this yesterday, but making sure that you keep, a binder of everything that has to do with the brain tumor. When you come into clinic, make sure you're taking notes because there's a lot going on and it's a long and exhausting day, and you don't want to forget some of the answers to the questions that you had. So it's real important to write that down and keep records. If you go for a second opinion, it's much easier if you have a binder with all your records that you've had, your path reports and your treatment and things like that, rather than trying to remember all that. Try to maintain a normalcy. It's hard, there's nothing normal about having a brain tumor, but trying to fit it into your normal life. And then sharing your trials and tribulations, both with the healthcare team, let us know what kind of things you're struggling with, as well as what kind of things you're doing well. Most of what I'm talking about today, I've just learned from 20 years of working with people with brain tumors and what the caregivers are letting me know. Next. So understanding the symptoms. I know Dr. Stroud talked about symptoms, but we'll talk about them a little bit more. There are physical symptoms of brain tumors: headaches, seizures, nausea, muscle weakness, vision problems, bowel and bladder difficulties. Cognitive symptoms. These are the more difficult to manage symptoms just because they're the ones that can be the most frustrating. That can be personality changes, confusion, impaired judgment, memory loss, socially inappropriate behavior. Please understand that this is related to the tumor and it's not personal. So that's a really hard thing to accept, but understand that it's the tumor and that you have to move on. One of the things that caregivers say have said to me in the clinic is, the problem is he looks normal, but he's not. And that's where all these cognitive symptoms come from. And then emotional symptoms. People can have depression, anxiety, and anger. And again, understand that this is related to the brain tumor and that it's not personal. And it's okay to say, I know you don't really mean that. What you said to me was hurtful, and I understand that, but I'm gonna understand that it's related to the brain tumor, and we're gonna move on. So address it, but don't stress on it. We're gonna get into symptoms based on tumor location and side effects of treatment and tumor. Dr. Stroud talked a bunch about that, so next. So brain tumors, it's all about location. Next. So the frontal lobe, when you have, and I'm going to try to go through each of the lobes and maybe implications for caregiving. So when you have a tumor in your frontal lobe, you can have motor problems and weakness on the opposite side of the tumor. Language problems. We talked about, someone earlier today talked about lesions in the left hemisphere. The majority of people in the world are right-handed, and so their dominant hemisphere is in the left side. But even a large percentage of left-handed people have their dominant hemisphere also in the left hemisphere. So they can have language problems. And then cognitive problems, we talked about that. Inappropriate behavior, so how do you manage that? How do you explain that? It's all related to the brain tumor. An inability to concentrate. So you might have to take away all the stimulation around you. So don't try to have them concentrating on something. Don't have the television on, don't have the radio on, don't have a lot of people around. Really help them to focus on one thing at a time, because it's difficult to concentrate. Sometimes people say, at mealtime, it's very difficult because, the whole family is interacting, but then at the end of the meal, the person with the brain tumor hasn't eaten anything because he couldn't concentrate on eating because he was so busy trying to follow all the conversations. Emotional lability. So that's, laughing and smiling 1 minute, crying the next minute, laughing again the next minute. That's all related to the tumor. Inattentiveness, so they're not ignoring you, they just have inattentiveness, so they might not be able to attend to you at every moment. And then flat affect or disinterest. People say, oh, they just, all they want to do is sit around all day and they're not interested in anything. Understand, again, this is related to the tumor. Next. The parietal lobe is all about your sensory things. So you can have sensory discrimination difficulties and visual spatial impairments. So you might have a difficult time, doing a project that you maybe used to be able to do because you can't, figure it out from a visual spatial point of view. And then body orientation. So they confuse their left and their right. And then an important thing with the parietal lobe that we often see is called neglect syndrome. So that's where the person doesn't necessarily have weakness, but they have what's called neglect syndrome, which is they just ignore that side. So they ignore the right arm or they ignore the right leg. And what people will describe is, we were eating dinner and all of a sudden their hand was sitting in their mashed potatoes and they didn't even realize it. That's neglect syndrome. They're not even realizing, their brain is playing tricks on them. They're not even realizing that the right side of their body belongs to them. So it's important, if you know someone has neglect syndrome, to encourage them to pay attention to that side. Don't forget your right arm, don't forget your right leg. When you're walking, make them look at their leg and watch it walking, because often it's not as much of a weakness as a neglect. And then they can have difficulty with calculations. So even if they were someone that used to fill out the checkbook and do the checkbook and pay the bills, you might want to double check that to make sure they can do the calculations. Next. Temporal lobe tumors have interesting, they often have psychomotor seizures, and when people think seizures, they think having a generalized seizure where you lose consciousness and you bite your tongue and all your extremities are moving. But there can be temporal lobe seizures, which can be visual, auditory, or olfactory hallucinations. So if someone suddenly says, "What is that smell? Why is no one else concerned that the airplane, is on fire?" Or "What is that, noise? When did they start playing music?" Or just having a feeling of deja vu, or a feeling that comes over them, peculiar sensations and auras. Any of those you really need to pay attention to and discuss it with your healthcare team, because people don't think seizures, but in actuality, it could possibly be a seizure. Especially if what happens, it's very characteristic. "Oh, there it goes again. I have that weird feeling," or "Oh, there's that smell again." Make sure you're communicating this with your healthcare team. And then they can have a visual field cut deficit that's usually the loss of the upper quadrant opposite the lesion in the brain. So that, you think, probably, unless you're a baseball player, might not have implications, but if someone's driving and doesn't see the stoplight, they might get in an accident. Next. The occipital lobe, when you think occipital lobe, you think vision. So they can have loss of vision on the side opposite the tumor in both eyes. So it's important to make sure that they know that you're always making them aware that they're not seeing that side of the world. So you might want to walk on that side if you're walking, through a grocery store, you go to that side so they don't bump into things or they don't take someone out with their grocery cart. Just make sure that you're aware of their visual deficit, and they have to learn to scan the environment. So make sure you're looking to the left, make sure you're looking to the left. And then they can have visual hallucinations. Next. The cerebellum is involved in all of our balance and coordination. So if you have a tumor in your cerebellum, you might have an unsteady gait, incoordination. You may have obstructive hydrocephalus, which is a sudden worsening of neurological symptoms. And these things, if suddenly someone gets suddenly worse, they need to be addressed immediately. And then obviously, with problems with the cerebellum, you need to be aware of the potential for falling. So involving physical therapy and safety measures to prevent someone from falling. Next. When you think about the brainstem, that's where the high real estate is. So you think about Park Place and Boardwalk, those are the high real estate. Very small tumors in the brainstem can cause huge deficits. So we have deficits of the cranial nerves, which are the nerves that supply the face and the head and the mouth and the eyes and things like that. So someone could have double vision or facial droop. They could also have cerebellar dysfunction like we discussed before. So they might have balance issues or incoordination, difficulty swallowing. So if you notice that when they're eating or drinking that they're coughing a lot, that's important to pay attention to, because if they're having difficulty swallowing, they could be aspirating or having some of the liquid go down the wrong tube and going into the lungs. Nausea and vomiting that's not controlled by regular medication, disequilibrium, and then again, you can get this hydrocephalus or sudden worsening of neurological symptoms. With all the symptoms of brain tumors, pay attention to, like Dr. Stroud say, one good day, one bad day, maybe it's not a big deal, but 2 or 3 bad days in a row, you need to notify your physician. And don't wait till your next clinic appointment and then say, yeah, he's fallen 3 times, you know, I didn't want to call you. Let us know that you're seeing symptoms. Next. So I think Maria also said this yesterday, but caregiving takes a village. Remember that caregiving is a team effort. It's not an individual effort. And team members can be, you can get them from a variety of places. They can be family members, friends, volunteers, the healthcare team, neighbors. Sometimes I describe, when we have our support group, I describe caregiver as anyone who cares about the person with the brain tumor. So there's a wide umbrella of what defines caregiver. And each member of the team offers different skills and strengths to provide effective care. Next. So it's important to work together to become a supportive group. You have to expect and accept that there's different opinions and coping styles. And involve the person with the brain tumor. I can't emphasize that enough. It's very difficult when you have a brain tumor, you end up feeling like you have loss of all your control. So you have to get together and consider what sense of control you can give them, and they should be involved and be in the center of all care-related issues. Appreciate team members who are trying to help, even if the help is not exactly what is needed. You will get a lot of advice and you'll get a lot of opinions, and you need to just, you know, accept the advice, say thank you for your advice. We're going to go a different route, but, you know, I appreciate that you're trying to help. Be practical in dividing up caregiving tasks. Allowing family members to help in the ways that they are able, and assign tasks based on each person's abilities, lifestyles, and schedules. So if you think about, you know, even someone out of town, we frequently have people whose children maybe are out of town. There's a lot of things someone can do when they're out of town. They can be in charge of, you know, following up on research studies, making sure that, you know, they're on nci.gov every month to see what new studies are out there, whether it's time to be in a trial or not, see what new treatments are out there. They can be involved from a distance. And then you think about what people's strengths and weaknesses are, what they can, you know, what they do well. I think Maria Munoz talked about, you know, this person was really good at managing the medication. So if someone has a lifestyle that makes it difficult, they can only come on weekends, then get all the medications set for that week. Or they can pick up the phone and remind someone to take their medication when it's time. Caregiving tasks will change daily and weekly, and you have to encourage team members to be flexible and pitch in when needed. People often say when they come, like, well, we got all this help during radiation and now no one's helping anymore. And that's because you need to communicate. You know, during radiation, maybe that's what you needed. You needed help driving every day to radiation for 6 weeks. But if there's still things that you need, encourage people to pitch in, but let them know. Keep in mind that you're working toward the same goal, even if there are different ways to do this. So sometimes there ends up being issues with family members, and just keep in mind that everyone wants what's best for the survivor. It may be helpful to have regular family meetings, whether virtual or on email or on the phone call, just to make sure you're communicating what's going on. And again, include the survivor in those meetings. Next. Managing expectations. So family and friends may have expectations on how you should care for your loved one. Expectations about the amount of time that you should spend, expectations about the level of care. Despite the opinions, as a primary caregiver, you need to evaluate and decide what kind of support you need or don't need. So the only expectation you need to manage is the expectation of your loved one and what they need. Communicate with family and friends. I think one of the hardest things that happens is people feel like they're, they leave the clinic and they've had an MRI and they feel like they have to spend the next 6 hours on the telephone because everyone wants to know what happened. So set up an electronic system. CaringBridge has a nice, free program that you set up, and you choose to share what you want to share, and people choose to share whether they want to, access it. If you add something to the CaringBridge, they will get an email that says, you've posted something new, and they can look at the email and then determine what's going on. So you don't have to talk to everyone every single time. Designate one spokesperson who can be your contact person. If you have a family of 20 that all want to know what's going on, pick one that's the most able to contact everyone else and have them be in charge of calling everyone. I think the last thing you need to do at the end of a busy day when you've had a scan and a discussion and talking about treatment is go home and be on the phone for 4 more hours. Communicating with children to facilitate healthy coping and adjusting is very important. You need to talk to the kids and let them know what's going on, and use age-appropriate communication to keep them informed. Social workers in cancer centers and brain tumor centers should be able to help you with this. What is age-appropriate communication? But try to maintain a structure and keep routines and schedules. If they're playing soccer, allow them to continue to play soccer. That might be one of the things that you're going to need help with, but try to keep the same routines and schedules. Continue to try to have meals together and discuss it. And especially if the children are, in the age of computers, if you're not telling them information, they're looking it up on the web, and they're drawing their own conclusions. So letting them know what's going on and be as honest as you can, and also let them know that they will be cared for no matter what happens. Next. We're going to talk a little bit about problem solving. I like to say there are no problems, only challenges with solutions. When caregivers successfully solve problems, they feel in control and satisfied with their efforts. You may not have control over what happens, but you can change how you react to what happens. Next. The first thing you have to do is prioritize and solve the problem. So if you have to look at the importance and the urgency. So if you think about it, someone having a seizure, that's very urgent and very important, and you need to deal with that right away. Scheduling an appointment, yes, it's important. It might not be so urgent. Getting groceries, somewhat urgent, somewhat important. You have to eat. Yard work, not important, not urgent, and something you can just let go or have someone else do it. Next. And then be a problem solver with your team. Identify the problem. What is the problem? What do we need to do about it? Gather information, identify challenges, include everyone, have kind of a free-for-all. What are the challenges? And then generate alternative strategies. So you kind of say nothing is off the table here. What is everyone, what are some strategies, no matter how off the wall they are? Let's talk about each one of them. Do brainstorming. Predict the positive and negative consequences of each strategy and the probability of achieving success and solving the problem. Then make a decision that makes the most sense to you. And then you implement the solution and reevaluate the situation, follow through, but don't look back on decisions. So if it's a treatment decision, you looked at all the clinical trials, you looked at all the options, you talked about each and every one of them, you came up with a decision, move forward with that decision. You can reevaluate, but don't think, oh, I really wish we would have done this or that. You made your decision, you made the decision that made the most sense at the time, move forward. Throughout the process, try to maintain a positive, optimistic attitude. This is not a problem. This is a challenge that I will figure out. Next. Accept help. I think this is the hardest thing to do as a caregiver. Asking for help is not a sign of weakness. Finding help is a sign of wisdom and strength. I think that needs to be your mantra every day. Asking help is not a sign of weakness. Finding help is a sign of wisdom and strength. Help ensures that the person with the brain tumor continues to receive high quality care while you maintain your health and well-being. Consider professional help, home health aides, personal assistance if you need it. Next. So how do you accept help and how do you ask for help? You have to ask for it and accept it. And always remember that it's easier to give than receive. But at some point you need to be in the receiving end of help. Help is needed in every stage of the disease and treatment. Like I said before, sometimes people say, oh, it's, you know, during radiation they help, but now that he's not getting treatment anymore, everyone kind of forgot about us. Identify your support people. Find out who is saying to you, what can I do to help? If they say, what can I do to help? Give them something very specific that they can do. I have a story that I like to tell. I had an aunt that was sick with cancer and I was talking to her and she said, I need help. I have a commode now. And I said, what about all your friends? And she said, I can't ask them to do that. I said, but they want to help you. So she ended up passing away like a month later, and 3 women came up to me at her funeral and said, oh, were you the niece who said she had to ask for help? And they were hugging me. They said, we finally got to figure out what she needed and we're able to help her. So you can consider a care coordinator. Again, if someone's from out of town, there's so many websites right now that you can say when you need meals, when you need rides, when you need the lawn mowed, etc. Consider a care coordinator that can help coordinate all that. That way you don't have to be the one to ask for help. Someone else is asking for you. And remember, you're doing it for them. They want to help you. People that offer and then don't come through, maybe they don't want to help you, but the majority of people who say, what can I do, really do want to help. But be very specific about what you need. Transform non-specific offers of help into concrete assistance. What can I do to help? You know what you can do? You can bring dinner on Thursday night. You can shovel the snow. You can come and rake all my leaves. You can take my kids to their soccer game. Be very specific about what you need, and then people will feel better about what they're able to do. Don't be afraid to ask your healthcare team for help too. Think about what we can do to help you. Whether it's a handicap parking thing so you don't have to manage the parking lot, or if it's a referral for home health care or for home physical therapy. Think about what we can do to help and ask for our help. Next. It's very important to take care of yourself. If you consider the airplane analogy, what they say is put your own oxygen mask on before assisting others. We need you to have oxygen in order to take care of someone else. When you are healthy physically and emotionally, you're a better caregiver. Try to declutter your life. If you think about what kind of things are getting in the way of you being able to be a caregiver, and things like yard work and things like that, try to declutter those things and think about what's really important. Someone in my support group always shares, it's either going to tire you or inspire you, or people or things are either going to tire you or inspire you. If they inspire you, that's what you should choose to do. If they tire you, you should kick that to the curb. So think about what's important to you and what inspires you. And go easy on yourself. You're doing the best you can. This quote is, sometimes one of my caregivers say, sometimes when I say I'm okay, I want someone to look at me in the eyes, hug me tight, and say, I know you're not. So if you're not doing okay, it's okay to tell people that are close to you that you're not doing okay and that you need to talk about it, and talk about and share your emotions. And also it's important to take some time to yourself, take some time away. Find some people on your care team that are willing to come over, and when they're coming over, you don't need to stay. Maybe you need to get out and go take a walk and take some time away. And consider counseling if you feel like you're not able to manage. Next. Here's some tips for reducing stress. Of course, you're going to have stress just given the diagnosis. Avoid scheduling conflicts. Again, if you have the big calendar in the middle of the family room, then you know this is what's going on, and let's make sure everyone puts what they need on the schedule so we know what we're doing. Be aware of your limits. Don't try to be super person. Make sure you know what your limits are and try not to go beyond them. Again, ask for help. If you go away with anything today, go away with, take the time to ask for help. Prioritize tasks. We talked about that. What really needs to get done? If you only have an hour, what really, really needs to get done? Break down tasks into smaller steps. If you feel like you know, my house is out of control. So there's so much stuff around. Say, can I do this room tonight? I'm going to get this room done tonight, not the whole house, but I'm going to get this room, and I'm going to do one room at a time, or maybe even one thing at a time, you know, one closet, one drawer, you know, something that you can break up into a smaller step in order to decrease your level of stress. And then concentrate your efforts on things you can control. What can you control and what you can't control? You can't control what's going on with the tumor, but you can control how you're all managing with it. Next. And more stress management strategies. Exercise regularly. It's important. It's important to spend time outside, you know, maybe not when it gets really cold, but, you know, vitamin D and fresh air are really important in maintaining your own health and well-being. Schedule your social activities. Do that around people who are offering to help, but schedule that. If you're someone who would, you know, go with your girlfriends for wine, then go and have some wine. Or if you know, someone that like to go watch a ball game, then go watch a ball game. You know, get your nails done, get a massage, get your hair done, things that are social for you. You know, eat well, make sure you're maintaining your own nutrition. Also make sure you're taking care of your own medical needs. You know, make sure you're getting your routine, you know, mammograms and flu shots and things like that, because we need you healthy in order to keep them healthy. Get plenty of sleep. Schedule daily relaxing time. So you can do relaxed deep breathing or meditation or yoga. Just take some time away to go and be on your own and try to do something relaxing and try to remove all the stressful stimuli that's going on. And do things you enjoy. If you're someone who enjoys getting into the garden and getting your hands dirty and planting things, then do that. But if you don't, then let the weeds take over. It's okay. If you can't find someone to do it, then just let it go. And some people have found that writing in a journal is helpful. You know, that way you can kind of at the end of the day, this is what kind of happened to me today. This is what I felt good about. This is what was stressful. And just write it down so you feel like you're sharing it, even if you're only sharing it in a journal. Next. I'm going to talk a little bit about support groups. Support groups, I think, are so important in this brain tumor journey. 10 years ago, we started a support group, and I started it with one survivor and a caregiver. And I really believe that it has improved the quality of life of the people that participate in it. They understand, people in support groups understand what you're going through and understand, you know, have been where you're at. And other members can have similar experiences and may have suggestions for you. And sometimes you're the one who is able to give support, and other times you may need to get support. And there's people there that are going to help both. If you're in a support group, I know our support group is big enough that we split off. You know, we meet as a big group, but then we split off, caregivers and survivors. And the caregivers go in another room. And I think it's the only opportunity that many of them have to just say what's going on and try to get some help and know that their loved one is you know, in the other room and doing okay. And just being able to hear from someone else that you're not in this alone. We have a group, since we've been meeting for 10 years, we have a whole group of people that have lost their partners to brain cancer, and they still come to the group and they still support each other. So they've developed these relationships that are lifelong. It can be a virtual or an actual group. You know, right now our group is virtual. We hope it's going to be actual again soon, but we've actually had people from other states somehow find out about our group and come to our group and get support. So, you know, the groups are out there. If you look at the American Brain Tumor Association, they have a website of groups near you. If you don't have one in your state, start one. You know, figure out, many cancer centers have you know, the ability. That's how we started it. We found a cancer center and they just let us have the group there for, you know, they let us have the space, and we just started meeting. And if you build it, they will come. Unless you live in a real rural area, people who have brain tumors are willing to travel in order to get support and talk about all this. Next. There are many resources. Here's the ABTA resources. There's a caregiver handbook, the brain tumor. You know, we've talked a lot about resources, but definitely use the ABTA. If you don't have a support group, they have their Care Connection program. So you could connect with a caregiver who has, you know, a similar story to you and maybe has been around a little bit more. Next. Here's just some other resources, and hopefully these slides are all going to be available to you, but there's the Caring Bridge and cancer.org and cancer.net. Those have to do with the with ASCO, the American Society for Clinical Oncology. They have a lot of helpful things for patients. Lots of Helping Hands. That's a program that you can set up and say what you need, what tests you need, and people sign up for it. My Lifeline is similar to the Caring Bridge. And then like Cleaning for a Reason is an organization that provides free cleaning help for women who are receiving cancer treatment. So if you're a caregiver for a female and want to do that, you just apply for that, and they'll come and clean your house while you sit there, or you go out, or you go for your walk, and they'll come and clean your house. So there's a lot of resources out there that you need to utilize. Next. And this is I just want to share, this is my support group. So every year in May, we have a walk sponsored by our Cancer Support Center that we meet at, and the name of our team is Kiss My Astrocytoma. So it's in May, which is Brain Tumor Awareness Month. So just imagine, we usually have about 100 people, all with neon green, Kiss My Astrocytoma shirts, and it means a lot. So think about the support group. Next. And I think I'm done, so I'm willing to answer any questions.
Thank you so much for your wonderful talk on caregiving. If you do have a question, please remember to type and submit it using the Q&A box. So one of the first questions we have here is from someone who is wondering if you can provide insight and advice for maybe a patient or even a caregiver who doesn't have a strong support team. Maybe their support team is small or even non-existent. Who do they turn to? Where can they find that extra support that they need?
I think that number one, you can find people that maybe don't live right in your neighborhood and can help people from out of town. You can get, if you need care help, you can hire people and things like that. But also like the American Cancer Society, they can provide rides for people. And there's a lot of different organizations that provide that sort of support help. A lot of the cancer centers have volunteers that will come and visit, or will come and help you out, or maybe just come and sit with your loved one while you do what you need to do. It's tough. It's not, as well as when people need to work and they're trying to take care of people. It's something you have to balance it.
Thank you for sharing that advice. What recommendations do you have for caregivers that, they want to be able to do more for their loved one, but it's a fine boundary, a fine line when you're walking it to avoid overstepping or going too far. And, the caregiver wants to ensure that they're still respecting the patient, their loved one's autonomy, and their self-determination as well. What advice do you have for them so that they don't overstep?
That's a great question. Involve them in every aspect. I think I had a patient she and her husband came in and they sat down and I said, "How are you doing?" And about 1 minute later, he started saying something and she said, "Well, you lasted 1 minute." And apparently they joked in the car about, "Will you let me just be the person to talk?" And she said, "You lasted 1 minute," and they both started laughing. But, allow them to get what they need, especially in medical, things, but also say, okay, now if it's okay with you, I think I want to ask some questions. Are you done asking your questions? And is there, can I ask some questions now? And always involving them. Say, I'm worried you've fallen, so I don't feel like you can be alone. So how do you recommend? What do you recommend that we do in order to, to keep you safe? And I think one of the hardest things, I know I usually facilitate the survivor part of our group, and another nurse practitioner does the caregiver part. And I know in her room, they're always saying, I can't leave them alone, I can't leave them alone. And in my room, they're saying, they never leave me alone, they never leave me alone. So you have to kind of balance it and figure out what's the best way to keep them safe, but also to know that they have some say in all this.
That's great advice. Thank you so much. I think we can take one more question. What advice do you have, or what would you recommend for caregivers as they're trying to protect their loved one? You know, you talked about how caregivers can have a lot of stress mentally and physically as well, and they need to talk to professionals and get support that they need. But how do they do that without causing their patient to feel guilty for causing that stress onto them?
Well, I think you just, you try to do it, without maybe making a big deal about it. And you say, I love you and I'm sorry that this is happening to you, but I need some help too. I need to be healthy in order to take care of you. It's a fine line because there's a lot of guilt. And I think you have to say to your loved one, leave the guilt at the door, for better, for worse, or you're my child, or you're my mother and you did this for me. But, try to let them leave the guilt and just, be open about it. Be open about, I just need, I need someone to talk to that isn't related to me and doesn't have anything to do with the brain tumor. It's hard. I think we as healthcare professionals don't have enough time. Sometimes I'll go grab a caregiver while the patient's getting an infusion, or getting an MRI, just so they have an opportunity to ask tough questions that they don't want to ask, maybe, in front of their loved one, and just to see how they're doing.
Great. Well, thank you so much for your time and for sharing this wonderful advice for the caregivers and the supporters out there. I'm sure a lot of them took some great nuggets out of your talk. I'm going to go ahead and turn it back to Emily again, and we'll move forward with the rest of the program. Thank you.
Yes. Thank you so much, Jean. We truly appreciate for you sharing with us the strategies for how caregivers can care for themselves. We truly hope that those of you who are listening who are caregivers were able to resonate with this session, and also for the survivors that offered you some perspective. For those of you who need a quick break, please feel free to do so now. Otherwise, we do invite the rest of you to stay on to hear from our researcher, Dr. Zhengyi An from the University of California, San Francisco. We will be back with our final session, our patient and caregiver panel, at 4:05 p.m. Central Time. Thank you so much.
Hello, everyone. I'm Zhengyi An from UCSF. My project is targeting TLR2 in EGFR and EGFRv3 amplified glioblastoma. This project was supported by the 2018 ABTA Basic Research Fellowship in honor of Juliana Schaffer and Team Hope. EGFRv3 is a tumor-specific mutant of EGFR. It's with a truncation mutant of the extracellular domain of EGFR, so it's deficient in ligand binding. EGFRv3 is a tumor-specific mutant. For EGFR and V3 co-amplification, there are hallmark genetic changes occurring in around 20% of all GBM patients. Interestingly, EGFR-V3 amplification only occurs with EGFR amplification, indicating co-expression of those two molecules give the tumor some growth advantage. In our project, basically we focus on three specific aims. For aim 1, we want to characterize the function of EGFR and V3 in cytokine expression and tumor infiltration in different models. And for aim 2, we want to study the mechanism, how EGFR and EGFR-V3 activate downstream signaling pathways. For aim 3, we focus on finding some therapeutic methods to target the signaling cascade. And for aim 1, basically we found that EGFR and EGFR-V3 work together to promote CCL2 expression and macrophage infiltration in the tumors. A and B basically showing inhibition of EGFR and V3 decreased CCL2 expression. C and D showed that EGFR and V3 inhibition led to decrease in macrophage infiltration in vitro, and E showed that EGFR and V3 work together to promote macrophage infiltration in the tumors. In AIM2, we found a signaling cascade that is induced by EGFR and V3, and here TLR2 plays an important role. We found that TLR2 interacts with EGFR V3, but not EGFR. And when TLR2 is interacting with EGFR V3, TLR2 phosphorylation can be activated by EGFR and V3 together. This will lead to activation of the P38 signaling cascade and later induce CCL2 production and macrophage attraction. And here, the phosphorylation of TLR2 is mediated by a kinase ROCK2. And in AIM3, we found a targetable site, which is ROCK2, it's a kinase. We found inhibition of ROCK2 led to decreased CCL2 expression, decreased macrophage infiltration, and also decreased TLR2 phosphorylation. And from our project, we learned that EGFR and EGFR-V3 can transduce the signal to TLR2, ROCK2 to induce tumor macrophage infiltration. And also our study indicates that a potential therapeutic way can be targeting the EGFR, EGFR-V3, ROCK2, TLR2 cascade. And this can potentially be used as a therapeutic way to inhibit the growth of EGFR and V3 amplified glioblastoma. Thank you.
Welcome back, and welcome to our final session of the 2020 National Conference. The American Brain Tumor Association understands it can be difficult for family and friends to understand what you are going through. By hearing from other patients and their caregivers who are also on this journey, you can find the encouragement and advice you need from someone who has walked in your shoes. That is why our next session is titled Living with a Brain Tumor Patient and Caregiver Survivorship Panel. Each panelist will share a brief introduction about their story as they are navigating through the process of living with a brain tumor or caring for their loved one who has a brain tumor. Serving as our panel facilitator is our co-chair, Jean Arzbaecher, who you just heard from moments ago. Please welcome Jean, who will introduce each of our panelists. Thank you.
Hello, me again. Welcome to our patient and caregiver panel. Serving on our panel are three very brave brain tumor survivors and their caregivers. Donna Van Ryn and her husband, Paul Van Ryn. Donna is a 13-year-old GBM survivor who you met in the clinical trial panel. Donna and Paul also, I've known them for about 12 years, and they are an integral part of my brain tumor support group. Our second panelists are Aisha Khalid Khan and her sister-in-law caregiver, Kola Shuab. Aisha has a central neurocytoma with resulting hemiparesis. Our third and final panelists are Stephanie Flack and her husband, Scott Flack. Stephanie is a grade 2 oligodendroglioma survivor. Please give all of our panelists a warm welcome as they share their brain tumor experience.
Go ahead.
I was diagnosed with a glioblastoma in 2005. Since that time, I've been able to continue many of my activities as well as being able to teach. Now, I've had a lot of support from many different people. My major support has been my husband, Paul Van Ryn. He's been with me the whole time. He's also set up appointments for me to be able to get my treatments. He's had people drive me to different appointments. He has also been able to set up something so that when I was really in a bad state, There were people that would come in and take care of me in the mornings while he was at work, or there would be people come in the evening before he'd get home from work, and they would help me with my daily routines at that time. Now, when I started out with the cancer treatments, things went well for a long time. Then I started getting more involved, or the tumor started getting more involved in my life. I had 2 different clinical trials that I participated in. And during one of those clinical trials, I was unable to work. And that's when I had to have friends come in and take care of me. Now, fortunately, I belonged to a large church, and people immediately signed up to be able to help. That help included being able to drive me to my appointments, also to be able to help me with my children. If they needed anywhere to go, they would be able to do that. So it didn't just take my husband as a caregiver, it took many different people. Most of those people came from my church. And that's why I think I had such success with my cancer treatments, because of the support that I received.
I'll give you from a caregiver's perspective, a scenario. When she was first diagnosed, the church wanted to provide dinners or meals. So we'd get 2 one night, 1 the next night. You know, we'd have like 8 meals in 7 days. So I was like, time out, you know. So I contacted the church secretary and said, can we have one like every other day? And then I just directed anybody who wanted to bring something to kind of go through her. So she was able to schedule and coordinate. And that kind of gave me a clue on how to manage all the help that everybody wanted to give, but I couldn't take, you know, we couldn't handle all of it at one time. So we spaced it out over a number of months and stuff. And then continued all throughout her experience, her surgeries. So 2 surgeries, 4 tumors, 2 clinical trials, 3 years of roller coaster ride. So it was definitely up and down. But we're sitting here many years later.
Great, thank you so much. Our next panelists are Aisha and Kola.
Yes, hello. Thank you, Jean and Emily, for this opportunity, and hello to everyone. So I'm a survivor. I was diagnosed in 2014 with a benign brain tumor known as central neurocytoma. It was in my left ventricle, and I had a very benign introduction to my tumor. I've slipped on black ice on the way to work. I work as a physician assistant. At the time, I was working in CT surgery or cardiac surgery at Yale New Haven Hospital. And it was dark, it was early in the morning, I was going to my shift, and I slipped on black ice, and I ended up with a concussion, and just was an incidental finding on a CT scan. They said, oh, you have a brain lesion, but didn't really identify it as a tumor. And I had about 4 months to casually go to neurosurgeons and consults, and I thought it would be a very benign, routine type procedure. They said, we'll go in and take it out, and I should have gone home in 4 days. But I woke up not identifying my right side completely from head to toe. I was completely paralyzed. I had to go to rehab, and took me about 5 months to walk again. And I think it took about a year for me to be able to feel some portion of my foot. And so it was a very interesting opportunity to be a patient from being a clinician. But I don't think that I would have had the quality of life that I have now, then and even now, if it wasn't for my family and my friends. The person sitting next to me is my sister-in-law. Her name is Kola, and she's been a really huge part of my recovery. I live with what's called hemiparesis, so I have weakness of my right side. I walk with a cane, I wear a leg brace. I think it slows me down, but thankfully it hasn't stopped me. As I think Donna was mentioning also, like, you try to do what you can. And so, for instance, I've been able to travel. 2 weeks into my recovery, I was at rehab. They transitioned me from the hospital to rehab, where I was there for about a little over 2 months. I was already applying for jobs, and my caregiver or my medical team was like, "What are you doing? You shouldn't be applying for a job. You won't be able to work for a while, and you probably won't be able to do the type of work that you did." And in my mind, I thought, well, of course I'm going to work. It was difficult. I will say it took me about 5 months to be able to walk independently. I was walking with 2-person assist initially, and then 1-person assist, and then in a selected control environment. It took me a year and a half to be able to drive again. And, I've successfully been able to work I'm a professor, and I've been able to return to clinical practice after 2 years because it was considered a traumatic brain injury. So I wasn't allowed to see patients for at least 2 years, and now I can, and I have been. I practice in a primary care and an addiction clinic. But like I said, none of this would have been possible had it not been for my sister-in-law. So, and my family, so I'm gonna let her talk.
Yeah, I mean, she's been the whole time. She's been like so great. Like everybody else, we all have our good time and bad time, good days and bad days. So like, I think most of the time she's been like great, and she's been like good, and like most of the times I only help her like sometimes, like there are like times like I give her like food, and like sometimes she has some knots in her like shoulders, so I help her like stretch and all that, so that helps.
Yeah.
So I mean, I think being a caregiver, what best I can do, I can listen to her, because that's the best that I can do, because I cannot like tell like how does she feel, like how the type of the life she had it before. Like still she's like super busy. She's like working 2 jobs, like the university in the morning, and then she has clinics on the weekends. So she's busy, she's still busy, but still like, you get tired. Like even being like a normal person, you do get tired too. But like she has like, sometimes she has difficulty, so she get tired more as compared to I do get tired. So then she's like, I wish I would do that, do this, but I'm like, most of the time I'm like, come on, you're doing like a lot more than anybody else can do it, So
No, I
yeah,
feel very fortunate to have her.
Yeah, thank you.
Great, thank you so much. Our third and final panelists are Stephanie Flack and her husband, Scott.
Hello, everyone. My diagnosis came about in a strange way as well. And at the end of 2007, I had strep throat, and I was given an antibiotic that caused a very rare side effect called intracranial hypertension. And that caused a lot of spinal fluid to collect on my brain. And I started to have the most horrible headaches I've ever had. And my vision started to change a little bit too. So I went to my ophthalmologist, and he saw that I had swelling of the optic nerves. And then that proceeded to an MRI and finding the tumor. I had consulted with several doctors in my local area, and all of them said that they would not recommend surgery, that I should just leave it be and see what happens. And to me, it felt like I had a ticking time bomb in my head, and I just wasn't okay with that. So I had joined a support group, and also someone in the support group, and also one of the doctors that I consulted with recommended that I speak with a neurosurgeon at UCSF. So I contacted him, sent my records, and he felt that he could safely operate and remove most or as much of the tumor as possible. So in June of 2009, my whole family, including my kids and my mom, we all went to San Francisco, and I had my first brain surgery there. My mom is a retired nurse, so it was wonderful having her there because she could just kind of keep an eye on me and make sure I was okay, the way a mom would do. And then we came back after that, and I was followed by an oncologist at Northwestern in Chicago. And I did really well up until like summer of 2016, and they started to see some changes. So in February of 2017, I had my second brain surgery at Northwestern, and gross total resection both times. And I haven't had any treatments like radiation or chemo. And the first surgery, I didn't have any deficits afterwards, but with the second surgery, since it was close to the motor strip, I had some weakness on my left side. I still have a little bit of that. I trip a lot, I fall often, and he won't let me climb on anything because I fall all the time. Well, I don't fall, but I'm a fall risk, I guess. And I think the hardest thing for me has been that I'm not able to deal with stress well. So I was a stay-at-home mom, and then I went back to college while my kids were little, and I was finishing my degree, and I first got sick the semester before my internship. So I pressed through, and I was having the vision issues and the pain, but I was able to still graduate summa cum laude. But I really wanted a career. You know, I'd been home with my kids all these years, and I really wanted a career. And the tumor kind of took that from me. I was able to work one job because I was stubborn and I just wanted to do it. And I had a job as a substance abuse counselor at a women's prison, and that was my dream. So I was there for about a year, and then we had some prison closures and things, so I lost my job, and it was probably a good thing because the stress was just really a lot to take. And I've worked a few part-time jobs since then, but it's really hard for me to cope with any amount of stress. I get really sick.
Well, after her first surgery, you know, I thought it was going to be business as usual. I mean, look at her. She's put together really well. She, you know, on the surface, everything looks okay. She's able to, except for climbing, you know, get around pretty well. So I pretty much just kind of went on like everything was going to be fine. It's behind us, you know, the surgery's done, and life is just going to be as it was before. Really, I was a terrible caregiver. I was able to do like the groceries and start cooking more and doing some of the other things, but and I always thought that that was great. It's like, okay, so I'm just taking over this part, so all is well. But another component to that is the emotional one, and I had a little trouble with that. So I wasn't doing the checking in that I should have been doing with her. I just knew that, you know, it's just terrible. Cancer sucks. Everyone knows it. And so this is just going to be our new normal, and not really checking in with her and seeing how she's doing emotionally. It took me 5 years to get into a support group. I pretty much just kind of, I think I was just overwhelmed with everything. I just thought I was just going to handle things and be all right with it, and not really get the help that I needed. So it took a long time to basically reach out into a support group and start talking to other people about it. And that was part of the problem, though, is that I think I just repressed a lot of things. And when even at diagnosis in 2008, she was already, you know, connected. She was online. She was, you know, ordering books. She was reading things. She was telling me all these things. So I could have been doing the same research on it, but I just didn't, because I think I was just overwhelmed by it all. And just basically everything I knew about what she had, and all the treatments was based on everything that she told me. So lots of things went through my mind after her surgery, like would I be able to, you know, to be there for her if she became more dependent on me? Would I be there for her emotionally? And like she was saying, our kids were 6 and 8 years old. So a lot of things went through my mind, like what would happen if something happened to her? Would I be able to take care of the kids, you know, on my own? And we were very open and upfront about everything. Even at their young age, we were able to, you know, we explained everything to them. And it's like, this is what's going on with mom. This is what could potentially happen. We wanted to be upfront about everything in the beginning. But one of the things that I had to really come to terms with also was that all the plans that we had and all the, you know, the financial things like the retirement, the kids' college, everything else, and all these things that we, you know, like we're going to do that, you know, way out there in the future. We had to draw those things in and start doing all these things, you know, these bucket list things a lot earlier in life. And my mantra became, we really can't afford to do it, but we can't afford not to do it, you know, because time's just not on your side.
Thank you so much to all 6 of you. If for all of you, for all 6 of you, if you had one piece of advice to give to someone who is newly diagnosed, You as a caregiver and you as a survivor, what would it be?
Jean, you used the dance analogy before, and you can't drop your partner.
Oh.
You know, sometimes they're coming at you, you know, and you got to catch them. So, and sometimes they push you away, but you can't go away. You know, it's like you got to stay in the dance. So.
That's great. Okay, who else?
Something that I always try to remind myself about is that oftentimes people will say things that they think are helpful, but they're not. Well, the biggest one is, oh, but you look so great. And I just want to say, I look the way I look because I feel better emotionally, but the way I look doesn't reflect maybe what I'm feeling on the inside. So I just try to remember they mean well, and just try to let it roll off my back.
I agree with her. I remember talking about this with a friend about that as well, in that sense, about the things that people shouldn't say. And oh, you don't look that bad, especially when you've taken steroids. I remember I looked twice. My face looked like it ate my face from before. It was so puffy, and I'm looking at myself. I'm sitting in a wheelchair, and of all the things, I mean, vanity affects all of us. I don't care what you're going through. Nobody wants to look bad or feel like they do, even when you're feeling your worst. And I remember being in rehab, looking at myself in my wheelchair in the mirror, and my family was like, no, you look the same. And I was like, I definitely didn't look like this before. I'm like, I may not have been the cover of a magazine, supermodel, but I know I didn't look like this. And so, but I agree with you on that. And also I would add, in terms of advice, I feel like this is something I struggle with, and I'm learning by myself. You know, like, don't be so hard on yourself in terms of what you have accomplished in terms of your recovery. And also, I struggle with this still too. And so I think so like initially I felt really, you know, being that I had a benign brain tumor, and they said that the swelling in the brain from going in deep, because it was in the ventricle, right? So they had to go in deep to take out the tumor. They said, oh, that's what caused all the swelling, and that's why you have like these stroke-like symptoms. And my surgeon tried to be nice and encouraging, was like, oh, you'll wake up one day and it'll come back. And I can't tell you the pain that I caused myself waking up every single morning in rehab. And I would look at my leg and I was like, I still don't recognize it. I still don't identify it. And I felt horrible. And I felt like it was a major setback for me every single day to be reminded of not having recovered to the point where I could move my arm, move my leg, or feel my shoulder, feel my right side. And so eventually what happened was I just stopped. I said, you know what, this is not going to be one day I'm going to wake up and identify my right side. And I just started living 6 months from now. And it's been since 2014 that I've just been living 6 months from now, imagining what I want to be, where I want to see myself. And it doesn't always end up that way, but it's been very helpful. And so those are, I guess, of more than one, but I think it stemmed from her saying something about saying nice things. So those are my advice.
No, I didn't mean only one, at least one, I guess I mean.
Okay,
so
sorry.
No, thank you. Thank you very much.
Yeah.
Anyone else? We have 4 more of you.
Well, I could
Three.
say, definitely, like I was saying before, check in. You know, a lot of people, they look okay. They look okay, all right? But they're not. And so, like I said, a lot of times I see that seems okay. She's sitting there, she's, dressed up, she looks great. She's watching TV or she's on her phone. But there's a lot going on, there's a lot going through her head. And sometimes I could tell, at least now I'm trying to be a little more cognizant of it, that maybe if I'm talking to her and she's not responding, it's because it's just hard for her to focus on things. And so I have to make sure that she's okay, and especially now because she's got her MRI coming up in a week. So that's anxiety. It's been 6 months, and that's a long time to go between scans, I have to remember when it gets close to that time that there's a lot going on, you know, and I need to just check in every once in a while and say, how are you feeling? What are you doing? You know, do you want to do something? So you definitely got to keep that communication open. Don't just assume that just because everything looks okay, that everything is okay.
I also want to add something in it too. Like, I think we have to be like patient and give them the opportunity to speak so they can vent out all the trauma they've been going through, so they can talk. You know, that's the best least I think we can do, because like we cannot imagine like what they're going through. So all we can do is like listen to them, because that's the moral support that you needed the most. That was just a small thing that I want to add.
Great. Donna, any words of wisdom for your 13 years?
Well, actually, I don't know if it's really words of wisdom, but I just want to say that I am so thankful for the people who came in to help. And also, I feel so blessed that I'm still alive. You know, being diagnosed with a glioblastoma in 2005, still being able to work today, it is such a blessing. And I thank God for it. That is also my person, or the force that I go to is my God. And say, you know, help me with this, and those people that are also part of my church that have backed me up.
Great. I do want to open it up to questions from participants. So is there someone, am I supposed to do that? Sorry, I'm a little.
Yeah, thank you so much, Jean.
Oh,
So I
okay.
can go ahead and filter through some of the questions that are coming in from our audience. So each of you kind of touched on this in your own experiences, that, you know, when you're going through this, both as a caregiver and as a survivor, you expected things to go back to normal, and then they didn't. How have you coped with that moving forward?
One thing that I did was, I don't know who told me this, but someone said, you have a brain injury, and read about brain injuries and what that means and what that looks like. And that was like a big awakening for me, because I started reading about that, and it was like, okay, I'm not losing it. This is normal. And so that would be my piece of advice, to research brain injuries.
Does
anyone else have any advice, Aisha or Donna?
I think the new normal for me keeps changing. I thought my new normal after brain surgery took me about, I would say 2 years, 3 years maybe, before I felt like, okay, now I got the hang of my new normal. I'm disabled, and it's a new life for me. You know, not being disabled before, I was like, all right, and I felt, I was talking to my sister-in-law the other day. I was like, I was super positive, and I felt like, you know, there was times where I felt down, but for the most part, I was like dealing with everything was fine. And then it got to a point where my hemiparesis started getting to be a little more of a problem. I started having way more spasticity, and I'm very sensitive to humid, you know, being in the summer makes it very tough, but humidity is tough, and the cold is tough. And that was another normal now I have to identify with. And so I feel like it's always been struggles. And so now every 3 months I go for Botox treatment in my leg. And that's part of my new routine, where I have to do that. And so I just feel like, you know, the new normal keeps changing, and it's something that it's reflected now because of COVID. I've, you know, had to work remotely and trying to transition back into going to work in person. And I feel like now especially it's starting to hit me much harder that my new normal keeps changing. I don't know what my new normal is going to be 6 months from now. And I think part of what's helping me be successful in dealing with it is just trying to be adaptable. Like trying to just identify the fact, like, there's not really much I can do to change this. I just have to find ways to deal with it and live with it. And still enjoy, as Donna was saying, be grateful, you know, being grateful that it could be a lot worse, or that even when it was worse, it's a lot better now than it was when it was that. And so I think, you know, and sorry, I'm taking too much time, but I remember I texted my friend the other day saying, I feel like every day is a balance between being grateful and being ambitious, and also in contrast, being resentful and being sad. And every day, whatever I'm feeling, is dependent upon whatever wins in my attitude towards how I'm going to start my day. And so, because I think if a lot of us took everything that makes us sad and perseverated over it, I don't think we'd get out of bed. And I think instead you have to try to like find the courage in yourself and in your caregivers and the love and support they give you, or the community. If you don't have someone living with you, then, things like ABTA community, that's what helps you deal with it. And so that, like I said, living 6 months at a time. And if that's not possible, just saying today, how do I really want to feel today? How do I want to deal with this? Do I want to stay in bed, or do I want to try to at least face it and deal with it? So.
Thank you for sharing that, Aisha. Donna and Paul, did you want to add anything about how you've coped adjusting to the new normal?
Well, my new normal is pretty much what my normal was. I mean, I've gone back to work. I still manage the household. I still teach. I get a lot out of the kids that I teach and I work with. I'm back with people that I work with, the other teachers. I mean, we're doing it remotely, but the teachers are still in the building and the kids are at home. But I think all that's just kind of flowed together. I haven't found a lot of difficulty with that.
Great. Well, thank you both, or all three of you, for sharing your insight. One of our attendees here wanted to point out the importance of having a sense of humor during this experience. And that's something our keynote speaker, Maria Menounos, also spoke about, that one of her coping mechanisms was humor. I'd like to ask each of you to share what has been your coping mechanism as you've been going through this. Stephanie and Scott, let's start with you, and then we'll go to Aisha and Chola, and then Donna and Paul.
I'm not really sure. I love garbage TV, so I watch a lot of garbage reality shows. That helps me cope.
And I love sitting and watching those with her. we use like just funny shows. We find, especially right now during the quarantine, we've just found some new shows to just binge. And they really are is just kind of, lowbrow comedy, just easy, that doesn't make you think, that type of stuff. You really gotta have a spoonful of that every once in a while, just to get through it.
Yeah, so I had a big sense of humor before my surgery, and luckily that part of the brain was preserved. And I'm really glad, because I think I would have been really miserable. If I lost that versus losing my strength on my right side, that would have been devastating to me. I could live with my weakness on my right side. I can't live without my sense of humor. I mean, to the point where my friends and my coworkers always tell me you should do stand-up comedy, because I think I tried. I feel like laughter helps me deal with very difficult situations in my life. I was a caregiver for my mom who had leukemia and unfortunately succumbed to it 2 years after. And so I dealt with that, and then dealing with this. I mean, I joked with my surgeon. I said, if you drop a saline bag, it might help me. I mean, I need to pay off my student loans. And I mean, I was joking with him and just finding ways to deal with a stressful situation. And it still helps me. I feel like sometimes you just have to laugh at the absurdity of the situation you're in life, because really the only alternative is to cry or to fear. And for me, I feel like that just takes a lot of energy that I need for my daily, like being able to go to work, being able to see patients, or whatever it is you have to do, or going to a happy occasion for a friend or a loved one that maybe you're not feeling so happy in your life for whatever reason you're dealing with. And so I feel like having a sense of humor helps. Just makes it, gives you maybe a better perspective of a difficult situation. So I don't know, you think as a caregiver?
I mean, we watch like so many videos together, like The Office. Oh my God, I love it. She made me to watch it. So I mean, she's good.
Yeah.
Her sense of humor is like right on the top.
Yeah.
She's good.
In rehab, like the nurse's station was right next to my room, and I had Cheers reruns, I had Reba, all these different shows playing, and they would come in and watch with me sometimes. And my friend was really awesome, gave me her Netflix subscription, and I got hooked to it after that. I said, whatever, if I'm going to be here, might as well watch Frasier and all these other shows. And so it definitely helped.
Thank you. Donna and Paul, would you like to share some of the coping mechanisms that really helped you through this experience?
We see every chick flick that comes out now.
That's awesome.
I think one of the things that's helped me most is being able to go back to work. You know, I feel bad for those who can't do it, because that really gave me a sense of normalcy. And it gave me a reason to keep fighting.
That's beautiful. Thank you for sharing that, Donna. Another question we have here, I'm going to ask each of you to share again, is asking about what are some of those supportive care resources that were really helpful for you? Or were there any resources or things you wish had been offered to you as you were going through this? Let's start again with Stephanie and Scott, and then we'll go to Aisha and Kola, and then Paul and Donna afterwards.
I think we had a lot of help too from our church, both times I had surgery. And the first time I had surgery, I had been a stay-at-home mom, so I had a big network of other stay-at-home moms. So having the help with meals, and even somebody coming and taking the boys to a museum for the day, those things were very helpful. And my family were really great too. My mom came and helped me bathe. And my sister came and stayed a week, and it just having somebody there with me was really, really helpful and supportive.
You know, for me, it took, when I said it took me a while to seek out some support groups. When I decided to start looking for them, I had a lot of trouble in town trying to find them. I couldn't believe how hard it was to find a caregiver group. I originally started, and she thinks this is funny, I got connected with a dementia and Alzheimer's group at a retirement home. And so when I went in there, I was in there with, you know, it was all women, and they were at least, you know, in their upper 70s and 80s. I really felt out of place. I like the first couple of times I went to the meetings there, I would listen to the struggles that they're dealing with, and then start thinking, you know, they're like, Scott, why aren't you saying anything? It's like, I don't know if I really can. I said, I'm listening to the things that you're dealing with, and first of all, I don't think I belong here. And secondly, I think it's just a little bit different. So I really had trouble connecting. And luckily, a coworker of mine who goes to a church, not the church that we go to, a bigger church, was able to connect me to a caregiver and a survivor support group. So I've been going to that for the past 4 or 5 years now, and it's been nice, but it's not brain tumor only. In fact, I think I may be the only caregiver who's a brain tumor caregiver. A lot of, you know, it's just basically a cancer support group, which has been nice, but there's times when I wish that I could have some people I could talk to for cancer caregiver stuff.
Thank you for sharing that. Aisha and Kala, were there any support services that were really helpful for you, or was there anything lacking that you wish that you had access to?
Actually, I agree with the others. I was very shocked at how little information I was given in terms of like life, even for me after surgery. Like once I had the surgery, there was no follow-up, and I was very disappointed. You know, when I went to rehab, I was asking questions about what resources are available for people that are trying to go back to work, or, you know, my insurance ran out in the middle of me being in rehab. And so I had insurance coverage, for the physical therapy component. And so I had to transition to my home, and I was still a one-person assist. My brother had to put a gait belt around my waist and walk with me so that I didn't fall, because I couldn't go to the bathroom by myself. So I just had I needed someone to help me get there. And then I wasn't able to drive. I couldn't go down the stairs. And so I was really nervous about how do we set up with physical therapy. And I mean, and then after that, I said, okay, well, what about when I want to learn or practice driving or get tested or evaluated? I knew enough that I wasn't able to drive because I didn't have the control. No information. And I said, okay. Then, and so it was other patients that were saying, oh, I heard you asking these questions. Oh, there's this, company that offers, like, it's called Access Ride here in Connecticut. And I just looked at the lady and I was shocked. I said, I know I'm not the first person that's ever been paralyzed. I'm not the first person that's ever had a brain tumor. How come no one is giving me clear-cut information? And I mean, I can understand, patients ask you things like, when will I get better, right? That you don't have a definitive answer. But if you could at least tell me, hey, there's these support, rides. I didn't know about the ABTA. I didn't know even about the one in my local chapter here in Connecticut. And so that was really disappointing when I found out all of these existed. I think it was 7 months later. I had my surgery or whatever time it was, I think, but I remember having my surgery in May, and it wasn't until almost like December, January the following year, following year almost. And so I think that to me was disappointing. And now I created a blog page. I follow the ABTA because I think all these resources you shouldn't have to ask for it. Like, I think people, when you have surgery, you have someone coming in, hey, these are some resources available to you for whatever, direction your recovery takes you. But for sure, the ABTA has been a tremendous part of my, getting back to whatever new normal I have for that moment. And that's been helpful. And just talking, I think there's validation in talking to others who have been in a similar experience, because your caregivers can be very supportive, but sometimes you're like, well, I don't want to bother Cola. I don't want to, keep telling her how tired I feel or how much pain I have. I'd rather talk to Donna and Stephanie, and because Stephanie and Donna know what I feel like when I say I'm getting really bad headaches or pain in the surgical site 2 years after the fact, because they probably know what that feels like, So there's validation, I think, in talking to others, and finding it through you guys has been a really big help.
Thank you. Paul and Donna?
I think what you said about having support afterwards, I think for me, having the brain tumor support group with people that were going through the same thing has meant a lot to me. Because I was fortunate in the beginning that I did meet someone who actually steered me towards University of Chicago so that I could have my clinical trial. That's what helped me. I needed to be around somebody who had gone through the same thing. And I think a support group just for brain cancer survivors is a good idea.
That is great. Thank you all so much for sharing some of the resources you wish were available to you and what did help you through this experience. Now, for those of you who have children, do you mind sharing how your kids handled hearing this news and, finding out that their parent is going through something like this?
Actually, our kids are a little bit older now. When I was diagnosed, I had a daughter as a freshman in high school and a senior. And I think both of them really knew what I was going through because we had always talked things through. So I think the difficult part was when my son graduated from high school and went away to college. I think that was difficult for us and also for my daughter, which was something I didn't recognize until later. But now they're both adults, very well adjusted, 29, 32, married on their own, and we have a grandchild. So there is light at the end of this tunnel.
Oh, congratulations on the grandchild.
Thank you.
All right, let's see. So another question we have is asking about what's going on now with the COVID-19 pandemic. How have you all been coping, being remote, being at home? Would you say that your survivorship may have helped you cope during this pandemic as well? Stephanie, do you mind if we start with you?
Not at all. I am very introverted. And so, I used to have a pretty busy schedule with, I would go work out every day and doctor's appointments and things like that. But I like to be at home and I need downtime and I need quiet. So it hasn't really changed a whole lot for me with the pandemic.
Aisha, do you have anything to share about what the pandemic has been like for you as a survivor?
I think I agree with Stephanie. I needed it's been, I'm just really grateful. I think Donnie said it before, in terms of being able to work, I'm really grateful to have a job, especially now. I think seeing what a lot of people are going through that aren't necessarily survivors even, but even for survivors, I know some that have lost their jobs, and so I'm very fortunate that I can work from home. But I have to say, I was very grateful to have a slower pace and just have time to be with my family. Although I will say personally that I thought working from home would be a lot easier than it is, and it's not. I think you're very accessible, and that's something that I learned the hard way, because it's definitely not easy. And for those of you that have worked from home before, I mean, my hat's off to you. But like I said, I have been able to walk more, and there's things that I'm able to do now that I wasn't able to do before. And it's allowed me to be a little bit more grateful in that part. But a lot of my doctor's appointments, follow-up type things I have to do via telemedicine, and that's been something that's different. But I'm grateful that I'm able to do that even and to have access to that type of healthcare. So there's a lot of things that if anything, I'm just really grateful for. It's increased my gratitude for a lot of things, yeah.
Thank you. And Paul and Donna, how has this pandemic been for you? How are you both coping?
Well, I actually can do well either way. Sometimes I really just need to be at home, and I found reading very relaxing for me. But now that I'm back at work, I enjoy being with the kids again. Even though they're not at school, I contact them through Zoom, just like the other teachers do. So I kind of like both avenues. I like being busy, but I can be busy at home and I can be busy at school, but I also have that downtime too. So I think it's really meshed together well.
There are technical difficulties now and then.
Yeah, sometimes.
So she'll come home and go, oh man, I don't know what's going on there.
Or the network crashed at school, or, and the parents are wanting to know, why aren't you teaching? And, it's just been an adjustment this year with COVID, and even with the way that I teach. I'm not used to delivering things online like this. I'm used to being able to sit, because I'm an elementary teacher, I like being able to sit with my children. I guess that's just the mom in me, that it's very different for me to be at the end of a screen and trying to teach that way. But
yeah, sometimes teaching, you have to have a captive audience. You have to have them right there.
Yes.
In front of you. So.
What I'm finding is that some parents don't understand that I can still see what's going on. So I'll be teaching a child and you'll hear a baby screaming in the background, or you see grandpa walk across. So I think it's a real adjustment for teachers and for families, because they're not used to us being in their homes.
Definitely. I think that's something we can all relate to, that adjustment and all those technical difficulties that come with it. Well, that is all the time that we have for questions for the panel. I want to thank all 6 of you again for taking the time to share your story. You all truly are an inspiration for all of us, and I can't thank you enough. I'm going to go ahead and turn it back to Emily. Thank you again.
Thank
you. Thank you.
Yes, thank you to all of you for this wonderful session and really just closing out our 2020 National Conference. But I really would just want to commend each of you on your bravery for being willing to share the innermost parts of your story and just being vulnerable today to our attendees. And to each of you attendees listening today, I hope that you were encouraged and inspired by each of our patients and caregivers today. If any of you would like to connect with us or to help others in a way that these panelists are sharing their stories, we would love for you to connect with the ABTA. Thank you all. Before we end today, we invite each of you to share your feedback with us. Each of you should have received an email asking you to take a brief survey to evaluate this year's first ever virtual national conference. We ask each of you to please take a few minutes to share your feedback, which is important to us as we plan future programs. I would now like to welcome Ralph, ABTA President and CEO, to say a few closing remarks. Thank you.
Thank you, Emily. And thank you to everyone. This has been an amazing conference. I am Ralph DeVito, President and CEO of the American Brain Tumor Association. And on behalf of the ABTA board and staff, I want to give a hearty virtual standing ovation to Dr. Mark Gilbert and Jean Arzbaecher. They did a phenomenal job putting together a great 2020 virtual national conference. The speakers, the pacing, it was a lot of great information. Thank you so much to Mark and to Jean. And yeah, there are their photos. They are just two amazing folks, and the leadership that Mark has of the Neuro-Oncology branch of the NCI has been great. He's been a great partner and friend. I also want to thank the entire ABTA staff for their hard work, the patients, the survivors, the caregivers who've been with us for 2 days. I do want to reinforce what Emily said. The survey has been sent to you. electronically. It's brief. Please fill it out. Let us know what went well this year and how can we make it better for you next year. We want to continue to deliver meaningful programming for you, the patient, the survivor, the caregiver, and the family member. You are the people that we're doing this for. I also want to ask you to go to abta.org and sign up for a free e-newsletter. It is a monthly newsletter that is, as I said, free of charge. It is a great way for us to connect with you, to share with you the latest information from your friends at the American Brain Tumor Association. We could not do what we do without our amazing sponsors, and you heard from many of them. There is a screenshot of the sponsors, and I want to give a special thanks to Rick Sontag and the Sontag Foundation for being our presenting sponsors, and the Brain Tumor Network that was featured during our session is a great resource for people to rely on to navigate through this challenging brain tumor diagnosis. I know them, they're very talented, you can rely on them. So a virtual thank you for being here. I would normally say, travel safely. I will say now, grab your favorite beverage, have a glass of tea or whatever you wish. Enjoy your evening. Please take care. And this meeting is now adjourned.